of, which will be useful to us. I can see some of the known faces here, and obviously we can start off the discussion either with your questions or Professor Satyan can start with what he has in mind. So buffet is basically an assortment and we tend to overeat. Hopefully we don't overeat here.
Thank you all for joining this morning. I want to introduce myself. My name is Satyan Lakshmi Nrsimha. I'm a neonatologist in the University of California at Davis. My areas of interest are neonatal resuscitation, oxygen, and pulmonary hypertension. I think since it's a very small group, it might be good if you all introduce yourselves so that we know where you are from. And sir, we will start with you. I'll bring the mic to you.
Just introduce yourself.
So I'm Dr. Vijay Kumar, retired professor of neonatology, Madras Medical College. And I read here, it is a great opportunity to hear from Professor Satyan Lakshminarayan here, because very, very challenging. There are two nightmares for the neonatologist. One is PPHN and pulmonary hemorrhage. Thank you, sir.
I'm Dr. Alim from Singapore. I'm a neonatologist there. Thank you.
I'm Dr. Nishat. I'm a neonatologist working at Dubai, Latifa Hospital.
Myself, Dr. Anand Kumar Jagnani from Ranchi.
I'm Dr. Kanya. I'm Professor Neonatology in PGI MER Chandigarh. And Sridhar is our student, was our student.
Good morning all. I am Dr. Rishikesh sir. I am currently pursuing second year DM residency at GMCH Aurangabad sir.
Good morning everyone. I am Dr. Akshay. I just completed my DM from PGI Chandigarh and I am practicing in UP, Uttar Pradesh.
Good morning everyone. I am Dr. Nagesh, General Pediatrician from Hyderabad.
Great. Thank you all for joining this morning. This is a very informal session, as Sridhar said. And we thought we can have an open discussion on any topics that you like and anything that you can think about where we can coordinate and work together through NNF. We can also talk about any topics or any questions that you have either expertise or we have some expertise in, and we're happy to answer those questions for you. So if you have anything that you want to talk about, we can discuss that.
We come across so many times in neonatology with the infections. The blood culture remains normal, rather not positive, but then the procalcitonin and CRP are quite raised. That's a very difficult situation, how to decide, what antibiotic to be given, and how long to do.
So that's a very good question. And I know in Indian setup, many of you are not able to do cultures even. So I come across situations where colleagues don't send blood cultures and empiric treatment becomes a norm. So obviously sepsis, is an empiric diagnosis in most situations, and we have the categorization, possible sepsis, probable sepsis, and definite sepsis. So if you have possible sepsis where they are basing on risk factors, the baby's early symptoms, but then the inflammatory markers are not going high, and the culture is negative, if you have center culture, then it's like 2 to 5 days of treatment. The earlier we stop, the better. So no need to continue for 5 days if you're confident at 2 days. And in terms of probable sepsis is where the situation you describe, where the inflammatory markers are high, baby is sick, but the culture is negative or you don't have a culture. So in these situations, you need to treat longer and you can use the markers as a guide. Remember that in the first 3 days, the procalcitonin levels are not very well defined. It often goes very high and you may overtreat if you use procalcitonin. I know they have nomograms based on the age, but why do you want to break your head? I mean, many units have stopped using inflammatory markers in the early onset sepsis. They go by the risk factors and the clinical signs and the culture. But if you don't have culture, you have to use the markers. White cell count is not that good a marker in terms of because there is leukocytosis in the beginning and the trend is difficult to predict. So it's not as sensitive or specific. CRP, we have been using CRP. I know some units don't believe in using it. CRP is fairly reliable if you use it as a trend. If it is stable, you know that's less likely to be infection by 24 to 36 hours. You can safely stop antibiotics even if you're not send culture and baby is clinically well. If baby is sick and you have a high inflammatory marker, if it's late onset sepsis, you are justified in using procalcitonin, but CRP gives almost the same information. A little time lag advantage is there with procalcitonin, and if there is a liver dysfunction, the CRP may not rise, the procalcitonin may rise. But apart from that, you don't need to routinely do both. You're adding to the cost because procalcitonin is not a cheap test, and you're adding to the cost, you may add to the confusion as well. So if you go clinically and with the CRP, it's reasonable. If the CRP goes high and the baby was symptomatic, you'd give minimum 5 to 7 days of antibiotics. In Indian scenario, you know the ESBL is very high, so most of you end up giving, if the baby is symptomatic with the high CRP, you're on broad spectrum anti-ESBL treatment. So restrict the use. If you have a positive culture, then change it, rationalize the treatment. But if you don't have a culture, if you don't have a lumbar puncture, you need to give at least 10 days treatment. But it's all arbitrary. And obviously 7 to 10 days treatment according to the severity of symptoms. Wait for the markers to start declining. You don't need to normalize it as long as the trend is declining and baby is stable. Does that answer your question?
I have nothing to add, but for the sake of fun, I want to mention what's happening in the US from an antibiotic therapy perspective. There's a lot of restriction on the use of antibiotics in the US. For example, in California, our Department of Health comes and checks every NICU to see how many babies went through an NICU course without ever getting antibiotics. And that's what we are rated on. If we 100% use antibiotics in every single patient that's admitted to the NICU, we get a negative mark. If you have a high percentage of babies that came to the NICU and spent the whole time in the NICU never getting antibiotics, including empiric early antibiotics, then we are rated high, and that really helps us in defending ourselves. So that's one fun fact. The second thing is that the hospitals have become very concerned about antibiotic resistance. So there is a full-time pediatric infectious disease expert whose job is to see every patient in the hospital who is on antibiotics. So we need that doctor's permission. I'm the head of the department, but I don't have any authority to prescribe vancomycin on a baby. I have to get the ID doctor's permission. And if I have to continue vancomycin beyond 2 days, again, they have to certify. So these certifications have really reduced the duration of antibiotics. The third thing is that we are not allowed to write an order with no end date for antibiotics. So when you write an antibiotic, it stops at 36 hours. We have to write another order if you want to extend it beyond that period. So they're taking a lot of pains to limit the use of antibiotics. And the Department of Health watches as to how much antibiotics we use. So there is a famous neonatologist who runs the Department of Health. His name is Joseph Schulman. And he has looked at the variation in antibiotic use between different NICUs. And the NICUs, blood culture positive, that's totally fine. But like the cases you're talking about where there are high inflammatory markers but no positive blood culture, he looked at the variation between different NICUs. The variation is from 0.5 to 100 antibiotic days. That's how much variation exists between the NICUs with no difference in mortality. So obviously, all of us overuse antibiotics, and every one of us remembers a time when we didn't start antibiotics or we started antibiotics late and the baby died from sepsis. That baby is stuck in our mind. But theoretically speaking, we all definitely overuse antibiotics, and now the trend is moving in the other direction. There is a famous pediatrician who apparently had his own child where he did cultures on that baby and did a stool microbiota profile till the child was 5 years of age. And he has a really nice graph where he shows that once the baby developed otitis media and got 1 dose of ampicillin, and all the good bacteria in the baby stool disappeared in 1 stroke. So that shows the power of even a simple antibiotic like amoxicillin and how it influences microbiota. And given the importance of microbiome in gut, in lung and brain growth, there's a big concern about use of antibiotics. So it's an interesting approach. It doesn't work in all countries, but I just wanted to mention that the pendulum is going a bit in the other direction in some countries. Yes, madam.
Thank you, Dr. Satyan. In PGI also, we have PGI also we have as it is a big referral center, whole of North India actually comes to us, and we have high rate of sepsis, but we follow very strictly the antibiotic stewardship. What you said that you have to decide in the beginning only how long we are going to give it, and we have also weekly meeting with microbiologists and pharmacologists, both of them, and they keep on sort of poking us why this baby is still on antibiotics like that. So we have that exercise weekly. Anyway, coming to my actually the original question is the bronchopulmonary dysplasia. So we have very small babies these days, in all over India, and we get babies from 500 grams babies to 24 weeks onwards. So these babies, though most of the babies do okay, but some babies get really stuck. Those who develop bad bronchopulmonary dysplasia. So we try initially gentle ventilation, whatever possible, all those things, but some babies do get stuck, and some babies has pulmonary hypertension. And we are not in a stage of giving, prolonged INO in these babies. Some babies get onto sildenafil, and they are also on a lot of bronchodilators. And nutrition part, we are very much aggressive enteral nutrition we follow, because TPN has its own risk, and the sepsis and all those. So we do use TPN, but and aggressive enteral nutrition. But because of that small baby, many times there are feed intolerance, and also initial weight loss is quite high. And then we try to push the feed from after 3-4 weeks onward, they are all on 180 ml per kg at least with fortifier. So nutrition, we do take care, though a bit late. So what is new in bronchopulmonary dysplasia in our setup, we can do, because our infection rate is high. Our ventilator associated pneumonias are high, because if they get stuck onto the ventilator sometimes. So what is sort of not new, I would say the approach would be in our scenario.
I have to disclose that I have never practiced in India other than my basic MD here. So whatever I answer may or may not apply to what you say. PGA is a leading institution, and you probably know more about what to do with these patients in this country than I do. So some basic questions for you. What percentage of your patients in that gestational age category get antenatal steroids?
Those who are well followed up in PGI, they would get 80-90%, because sometimes these patients also come very late, like they are told, if you are in labor, then come, because we cannot admit these cases. So they would get 80-90%. But there are many cases who are getting referred from outside. In those, the rate is, the cover is not good, 60-70%.
Okay. Second question. Do you do any kind of Premilock approach with the use of hydrocortisone in the first 2 to 3 weeks of
No.
Fortunately, you don't.
No.
Okay. Well, how do you treat your PDAs, or do you not treat them?
We treat them if it is in extremely low birth weight babies. If it is a hemodynamically significant PDA, we do treat them.
Okay. And do you use a lot of dexamethasone later on?
No.
You don't?
No.
Okay.
Very limited. Only if some baby is stuck on ventilator, like a mini DART regime we follow in some babies.
Okay.
But not extensively.
Yeah, so those are great answers. So what is new in the management of BPD? Unfortunately, there is not much new right now. Ever since we have changed to predominantly human milk feeds or donor milk feeds, that seems to have helped to attain the independence from TPN and less central line associated infections. So CLABSI has gone down, and that has really helped out also. We now set up the gestational age of resuscitation has gradually gone down, and with the resuscitation of 22 weekers, those babies are contributing to a lot of BPD also in the population. So the key thought is to reduce the duration of intubation in any way you can. And so there's a Cologne approach where they tend not to intubate as much as possible and try to maintain babies on CPAP as long as possible, and only intubate with very strict criteria where they put a tube back in. So minimizing the duration of invasive ventilation has really gone up in pretty much every institution possible. Other than that, PDA is still a matter of confusion, as we heard yesterday, and it's been an ongoing debate. And we were just talking at the beginning of this session as to whether the fact that we have become a bit casual about treating PDAs, has that contributed to the higher incidence of BPD? That's a very, I don't think we have clear-cut evidence, because if you treat them with ibuprofen, the incidence of BPD is also going up. So we don't have a clear-cut answer there. So other than increased enteral nutrition with donor milk or mother's own milk, and minimizing the duration of extubation, minimizing the duration of intubation and invasive mechanical ventilation, there's nothing really on the horizon. There are a couple therapies that are being looked into based on IGF-1, etc. They're still in an investigational phase to manage BPD. And the other thing that there is some debate about is as to what oxygen targets you use during the early phase and late phase, more from a pulmonary hypertension perspective. The latest trial that's going on with the PD is the pivotal trial, which is enrolling babies for a cath intervention, either as a primary intervention or as a secondary intervention, fairly early in the course of PDA. And that has randomized a few babies, and we're waiting for that trial to finish. So this is a trial where if a baby has failed one course of therapy, that medication, then that baby can be randomized to either get a cath closure or a no cath closure. And we are hoping that that might shed some light as to what we do with the management of PDAs. So it's an ongoing debate, and my pulmonologists call my NICU as a BPD factory. They tell me that I bring in all these babies, treat them, and send out all these BPD patients out into the world. And there's a lot of concern as to how to manage these patients. So this is a global concern, what you're talking about. And at least I don't know a clear-cut answer. And I wish I did, but I'm happy to hear if Sridhar has other thoughts.
I mean, it's the same lines. I mean, yeah,
Thank you.
the interventions have to be appropriate right from the start. So from the beginning, if we do well, I think BPD rates, Dr. Alim from Singapore, he was mentioning the same, that the BPD rate is rising. The first few days of treatment impacts a lot, the nutrition, the prevention of infection, the golden hour management, including the delayed cot lumping. So if you look at all these and appropriate timing of the initial interventions, avoiding the frequent cycle of atelectasis in the NICU, the intermittent hypoxemia, and I mean, try our best to keep the lung recruited through. And timely steroid also, if you need DART regime to extubate sooner and avoid reintubation, as he pointed out. Infection seems to be the biggest factor. So once you get significant infection, and once Dr. Ambalavanan, I mean, he has done some research on PPHN in BPD setting. Again, I don't think there is enough evidence to say any specific treatment makes a big difference. So unfortunately, once that's a high mortality group, 30 to 40% mortality. Once beyond 38 weeks, they get pulmonary hypertension with BPD. But we need to screen for that as well. Thank you. Nishat, you have a point.
Yeah, I have a few questions, Dr. Satyan. One is regarding the infographics. How do you do it? Do you use any software, use a tool, or you do it in any other way? That's one.
Okay, let me answer. That's an easy one to answer. So I don't use AI. I will start using it. I just got my subscription for, there's a new Google version, Gemini version called as Nano Banana. So I'm starting to use it, but right now I have a pad that I bring with me on my laptop and I draw on it. I use Adobe Illustrator. It's a very nice graphics tool, and a lot of comic writers use it. So if you want to experiment with it, you can try it out. It's a bit expensive, but it's really worth it. And the good thing with using Adobe Illustrator is that once you draw an outline of a baby, you can make the same baby cyanotic for one paper, and you can make it acyanotic for the other paper. You can show differential cyanosis. So you can use the same outline for many things. It's very a versatile program. So my rule is that every neonatologist should be an illustrator, and so drawing your own illustrations helps you out quite a bit. And thank you for the question.
I think if you put in the prompt, give me infographic like Dr. Satyan does, it will probably give you a similar one, right?
The only thing with AI is that if you use ChatGPT and just give it prompts, it downloads words in all kinds of languages. It looks like Russian, some other language, makes it very complicated. If you use a much more professional paid versions, things get better. Yeah. So what I'm doing now is I draw a crude picture of what you want, even with on a paper napkin, take a picture of it and then upload to AI and say that, make this picture better and say what you want. And then it creates a much more nicer infographics. I was just at Hot Topics, and one of my colleagues, Kashif Ahmed, he gave a full talk on AI-generated graphics, and he did his whole talk based on that. And these graphics were spectacular and outstanding. So there is an option for you. Some people use BioRender as well. I don't know if you have tried that one out. BioRender has all these downloadable pictures that you can use. So there are lots of options. So I'm very happy that AI is advancing our use of illustrations.
Second question.
Right. Do you have a follow-up on, is it on the same topic or something different?
No.
Sir, my question is whether you are using hydrocortisone in the during first week in ELBW regularly for prevention of BPD. Have you started using or?
No, when the Premilock study came out, for a period of time, we were considering it. Our unit has a slightly high rate of SIP, so we decided not to continue using it because there was a concern that hydrocortisone might be contributing to that. But if any baby is hypotensive and requires a pressor, then we put those babies on a low dose hydrocortisone. That's the only area where we use. Otherwise, we're not using it. There are some units in the US that routinely use a Premilock approach with a course of early hydrocortisone. Sorry, you had a second question.
Second question is about PPH and same
Yeah.
and BPD. So, at what point of gestation of invasive ventilation do you shift from conventional ACPC mode to SIMV with PS with low rate long TI?
Yeah.
And how do you decide it? What based on what?
Yeah.
So
yeah. So yeah, I was dreading that somebody would ask that question. So so the short answer is that in the beginning, all our babies are on volume guarantee. It's a routine thing. You know, actually, we start with a jet and then switch over to volume guarantee. And then we keep following the respiratory graphics. And once we start seeing that there is some expiratory lag and there is some signs of expiratory obstruction, resistance is increasing, and then we start seeing when the flow curve on the graphics, you see the inhalational flow, and when during exhalation, if the exhalation flow is not coming back to zero by the end of the I time, then it's a sign that this is not really working out. Then we completely take off assist control and volume guarantee and go to a SIMV pressure control, pressure support mode, because we truly believe that the volume mode is not really beneficial once you get to that time. Because with the volume mode, especially using a Draeger, the PIPs might be fairly low because it combines baby's own inhaled volume and the machine's volume and adds the two up and delivers the tidal volume. For that reason, we switch to a SIMV pressure control, pressure support mode, and then do it in that way. So that's what we do. That's a great question, and we can. Okay. We will stop because it's 9 o'clock. We can talk offline. So.
One more question. It's again related to the BPD. As I said earlier, the BPD rates are increasing. Even though some units are successful in keeping the rates low, the severity of the BPD is increasing. One of the common problem we face is keeping the baby off the ventilator. Even we extubate early, sometimes they fail extubation and get reintubated. Second is when they keep reintubated with longer time, the suspected infection becomes an issue. When do you decide whether it's a ventilator-associated pneumonia and consider antibiotics? When you treat them more like a conservatively? Very difficult question, I know. Yeah. Any thoughts on that? Thank you.
I'm sure if you want to take that. So we used to do tracheal aspirates and look for white cell counts and do cultures during a tracheal aspirate, but we have been asked not to do them, and our ID experts have banned us from doing tracheal aspirates now. So we only get a tracheal aspirate to look at white cells in it and do a gram stain, but would not do any cultures in it. So if you have additional new lung shadows on an X-ray and a positive white cells in the tracheal aspirate, that's suspicious for either tracheitis or some pneumonia, and we can consider using some antibiotics at that time. Since we're running out of time, I just don't want to delay the next session, and we can have other questions.
Thank you, everyone.
Thank you so much for the discussion.
Thanks a lot. Thank you, sir. Thanks a lot for the interaction. I request delegates, those who have further questions, please continue discussion off stage. So the next talk is by Dr. Kanya Mukhopadhyay. Ma'am, I request you to come onto the stage. The session is maternal nutrition and fetal and neonatal outcomes. This session will be chaired by Dr. Anand Kumar Jagnani. Sir, I request you to please be seated on stage, sir. I request Dr. Anand Kumar sir to kindly introduce the speaker.
Pointer.
Hello.
Pointer.
I welcome Dr. Kanya Mukhopadhyay, Professor in Neonatology. She needs no introduction. She had introduced herself in the last session. I just welcome her to start her talk.
Thank you, sir. Many pointer. Yep. दिख नहीं रहा कुछ. Okay. So first of all, I would like to thank the Neocon organizers, both the central as well as the local AP chapter, for giving me this opportunity to talk on my favorite subject on the maternal nutrition and the effect on fetus and the neonates. So we all know that the first 1,000 days are extremely important for the child's whole life later on, and the next generation, in fact, not only in that child's child also is affected by the maternal nutrition. So we are talking about the first 270 days of the pregnancy, because it is I'm talking on the maternal nutrition. So the child's health is affected by maternal health, and not only during the pregnancy maternal health, it is the pre-pregnancy maternal health and her nutrition also affects the final child's health. On top of it, we have sometimes the fetus as such has their own intrinsic issues, and after birth, the child's environment, child's nutrition, socioeconomic status, they all affects the final child's health. And we have in between the placenta. Placenta also regulates the nutrient transfer to the child. And then how it is being shaped up, that child's health, it gets reflected in the child's adult health. And there are many factors like, as I said, fetal factors, maternal, placental, and uterine factors, which affects the fetal growth. Now coming back to the maternal nutrition, so which is extremely important in shaping up the child's health in future. And this starts from the preconception. Then it continues through pregnancy as well as during the lactation. And as the new evidence is coming up, it is the maternal nutrition which is not only directly affecting the child's health, it is causing a lot of epigenetic changes also, which affects the child health, as well as the maternal diet changes mother's gut microbiota. So we have a gut placenta axis which will affect the child's health. So it is mother's nutrition getting affected by the maternal microbiota, and which is also doing the epigenetic changes. So all this finally lead to the final child's health. If there is a poor maternal nutrition, it can affect herself. The mother can become anemic. They are more prone for than preeclampsia and sometimes maternal death. The child there could be fetal death, stillbirth, low birth weight, prematurity, all because of maternal malnutrition. And malnutrition is actually both undernutrition and overnutrition. And the child can be affected by stunting, global developmental delay, including cognitive dysfunction. So during first trimester, actually mother doesn't need any increase in the calorie. The essence of the maternal nutrition is balanced diet. That is very important. So rather than putting focus on the total calorie, it is the balanced diet, like a good mix of macronutrients and micronutrients, which affects the maternal health. As per the NIN, national this nutrition ICMR guidelines, the first trimester no need for extra calories, second trimester extra around 340 calories per day, and in third trimester about 450 calories per day are required. These are the ICMR NIN guidelines in which it gives the pregnant mother's intake. So along with the macronutrients, it is the micronutrients like iodine, folic acid, iron, vitamin D, vitamin B12, omega-3 fatty acids. All this if they are deficient, have a deleterious effect on the fetal health. So you have to take care of both macro and micronutrients. And maternal, this undernutrition or overnutrition or dietary imbalance, they all affect the nutritional programming in the fetus. So fetuses, all organs are involved because of this if there is a maternal nutritional imbalance. And down the line, then it causes insulin resistance leading to metabolic syndrome, and the child's adult health is also badly affected. During pregnancy, the maternal metabolism affects the placental function. I'll come to that. And finally, then it affects the fetal nutrition, that means fetal nutrient transfers, and finally, the infant health outcomes. In early pregnancy, the metabolism is anabolic. There is lipid deposition which supports the later catabolism, and lot of placental and maternal hormones are involved in this anabolic phase. Then the later part of the pregnancy is catabolic. That time maternal catabolism is supposed the fetal growth. So again, the placental as well as maternal hormones are involved in it. So if mother is taking a bad diet, which you can see on the top one, is a high fat, high salt diet, the baby is born big and with all their metabolic parameters abnormality. But if mother is taking a balanced diet, which is the lower picture, it not only reduces the preterm birth and normalizes the birth weight, it helps in a better neurological outcome as well as the child's metabolic health, as well as decrease incidence of child's various type of allergic disorder. So maternal balanced good diet is very important, and not a high fat, high salt diet. So both undernutrition and overnutrition, it affects the developmental programming of the organ system through the epigenetic changes, and the child is prone for all types of metabolic syndrome, including cognitive impairment, allergies, impaired immunity, etc. Now, between the mother and the child, there is placenta. So placenta also has its own regulation that how the nutrients will get transferred to the fetus. So it balances as a filter. And if you see this picture, then you'll see that there are, see, the fetal DNA sequence is decided at the time of conception. So that doesn't get changed. But the epigenetic changes actually involve the DNA sequence may be changed. The DNA, original DNA remains, but there is a DNA methylation. So there are various epigenetic mechanisms, and a maternal nutrition has a lot to do in altering this epigenetic mechanism. So then they affect the placental transfer, which then finally gets transferred onto the baby's health. So this blue one is the syncytial trophoblast. It is the first placental barrier that how the nutrients will get transferred to the fetus, from the mother to the fetus. And this fetal transfer is decided by many factors. So from the maternal hormones, maternal nutrients, adipokines, they decide. Then the baby's own regulation of the IGF, which is a major growth hormone in the fetal life, that decides, and placental signaling by mTOR and other mechanisms. They also decide that how this maternal nutrients get transferred to the baby. So nutrients, the hormones, growth factors, oxygenation, all these affect the placental basically physiology and pathology, and that decides then the nutrient availability to the fetus, and finally the fetal growth and various fetal organs, normal development or maldevelopment. So the nutritional epigenetics, how food shapes genes before birth, there is a lot of research onto it, and because it has very long-term implications. It is not only the child cells, it is the adult and it is a generational child. So badly affected child will give birth to a badly affected her own child. So it is a generational issue. And how this maternal diet and epigenetic changes causes is that by the methylation. So the maternal diet, maternal other factors, lifestyles, are exposure to various toxins like smoking, alcohol, etc. And her and father's genetic background, they all affect to modify these epigenetic modifications, and down the line then it is the child's health which is affected. So here in the experimental model you can see on the left side, when a rat is fed with a high fat diet, so in this rats there is increased risk of neurodevelopmental deficits. And how it happens that it upregulates, the high fat diet upregulates the pro-inflammatory pathways. So in the intestine, in the adipose tissue, in the placenta, the pro-inflammatory mechanisms are upregulated, and same thing happens even for the humans. So when she takes this high fat diet, then the inflammatory markers they go up and it affects the child finally. Another thing is that gestation and the changes in the mother's microbiota. So normally in the mother's gut, first in the initial parts of gestation, it is the alpha diversity, which is the firmicutes type of bacteria which predominant. But as the gestation progresses, it changes to the beta diversity, which is bifidobacteria, lactate products, etc. Now, if the mother's diet is not correct, then this gut microbiota in the mother also changes, and there is a gut placenta axis. So mother's diet which has changed the mother's gut microbiota pattern, which will signal that from this the products of short chain fatty acids, retinoid compounds, which get absorbed from the maternal gut to the maternal circulation, and that is going to the placenta. So all these get then transferred from the maternal circulation to the placenta and to the fetus finally. So if these pro-inflammatory markers are upregulated because of bad maternal diet, then the child is very prone for all the metabolic disorder, asthma, and immune compromises. But a good diet would protect the child from the asthma, and the fetal and maternal, the child's immunity will be better preserved. So this chart also shows the same thing: maternal diet, epigenetic changes, gut microbiota changes, which finally shapes the adult child's health and followed by the adult health. There is a lot of research on the epigenetic changes, how maternal diet shapes the child's and the adult health. So the UNICEF says worldwide women's diets are influenced by various factors, especially food access and affordability. There is a gross gender inequality. So the girl children get less nutrition, adolescent girl get less nutrition, and obviously then as mother, her malnutrition continues. So this is a worldwide phenomena. And there are many socio-cultural norms of restricting maternal diet during pregnancy, and not only during pregnancy, and of course after birth, during lactation. So UNICEF says it is a compelling investment in the children who get their right nutrition during the first 1,000 days, which is 270 days of pregnancy diet. They are 10 times more likely to overcome the most life-threatening child diseases. They complete 4.6 more grades in the school. They go on to earn 21% more wages as adults and are more likely as adults to have healthier families. So it is a very good investment in the maternal health if you want to have a healthy child and a healthy future. So I would like to finish by saying that a healthy mother can give birth to a healthy fetus or a child later, and then her subsequent generations. Thank you.
Finally, with a comment on this talk, beautiful talk, I would say that a healthy mother can give the healthy baby.
Yes.
And everything is from preconception. So proper counseling of the mother by the obstetrician, then the pediatrician can give a healthy baby. Thank you, madam, for the nice talk. Any questions from the audience? Thank you.
Thank you, madam, for the excellent talk, and thanks for completing it in time. Now, I request chairperson to facilitate the speaker and speak.
Hello. Next speaker, please.
Next moderator. Sorry, sir. So next session is a debate. Antenatal corticosteroids beyond 34 weeks. To debate on S, Dr. Sriram S. To debate on No, Dr. Vishnu Mohan PT. To moderate this session, I request Dr. S.N. Singh.
So, good morning to all of you. Just to set up the scenario, you all are aware that after the Action 1 trial, there is that is conducted from a low middle income country. So it has definite benefit for improving the mortality as well as respiratory morbidities in babies less than 34 weeks. But the use of antenatal corticosteroid has been extended beyond 34 weeks. And it has been practiced in developed countries. But there is a concern. The same may not be true for developing countries. So there are concerned about the short-term like hypoglycemia as well as long-term neurodevelopmental problem. So for this, I think there are two speakers. Dr. Sriram, he will be talking in favor of use of corticosteroid beyond 34 weeks. And following him, Dr. Vishnu Mohan will be talking against. So welcome you.
Thank you, sir. Very good morning to you all. At the outset, I would like to thank the organizers for giving me this opportunity to talk in front of the in this conference in this beautiful city of Vizag. So the time is short. We have given just 8 minutes to complete this thing. So I'll just run through. So we all know this antenatal corticosteroids have got significant benefits. There is no doubt about it. There are multiple trials, multiple meta-analysis, which have clearly shown it reduces major things like RDS, mortality, air leaks, and all the major morbidity, all the three-letter words of the neonatology. Now, so the same principle can be extended beyond 34 weeks is the question. Is it worthwhile? So is there a concept? Yes, steroids have been shown apart from increasing surfactant production. It has been shown to increase this molecule in the lungs, that is the epithelial sodium channel, not only in the lungs, in other organs also. But this upregulation of this epithelial sodium channel helps to shift the lung epithelium from a secretory chloride thing to an absorptive phase. So that helps in rapid clearance of the lung fluid, thereby reducing the transient tachypnea and other disorders which actually make the newborn need respiratory support after birth. Now, is there a need in our country? Is it really a high burden? Yes, late preterm is quite high in our country, as we see across the globe. So you can see that 12 to 18%. Actually, our prematurity rates are slightly on the higher side in compared to the worldwide data. And among that, if you look at the Indian scenario, these late preterm babies have a significant need for respiratory support. That is, almost 35% require, they develop distress and they land up in an ICU. And the odds of respiratory morbidity is quite high. This is from our Hyderabad study from Dr. Srinivas Murki. Similarly, another study from AFMC also shown almost 60% of these late preterms develop distress and they land up in the NICU. So once they land up, there is a cost. So I don't want to go into that. So the need is very clear. So there is a need. The late preterm burden is very high. They do develop distress. A significant chunk of them do develop distress and land in an ICU. And once they land, it becomes a burden on the family for finances. So is an answer for that? Let us see, does steroid help in reducing this kind of respiratory distress and hence prevent them from landing into the NICU? So this is a major trial. There are other small trials which have led to this major trial, that is the ALPS trial, that steroids for late preterms. The population was 34 to 36 weeks of gestation. They had a very strict criteria for choosing the mothers who were about to deliver in the preterm. So the intervention was 2 doses of betamethasone, 12 milligrams, 24 hours apart. And the composite outcome was they looked at this entity. They looked at the need for CPAP for more than 2 hours, the need for ventilation, or need for just oxygen with an FiO2 of more than 3%. So that was this one. They found that the need for respiratory thing is lesser in these neonates. So almost 11% required the surfactant, need for admission with CPAP requirement against 14% in the placebo group. So there was a 20% reduction was noted, but the NNT is 35. That means you have to give 35 mothers steroids to prevent one baby from requiring this kind of a composite outcome. If you look at the severe morbidities, that is extended, what they call it as extended composite outcome, which meant that the need for ventilation, need for CPAP for a longer duration, for more than 6 hours, for more than 24 hours, the need for surfactant was clubbed in this extended outcome, and they found almost like 34% reduction was noted in the trial. Now, coming to the morbidity data, they found that the TTN also got reduced, surfactant requirement was reduced. This is another interesting thing. Need for resuscitation got reduced. So many other trials have consistently shown that mothers who received steroids in the late preterm group did require less resuscitation when compared to the mothers who were not. And all these translate into less NICU admissions. But issues are there. Hypoglycemia, there was a higher hypoglycemic incidence of almost double in those mothers who received steroids. But fortunately, if you look at in detail about these hypoglycemic events, everything happened within first 24 hours and none of them were symptomatic, and the resolution was faster. So this is a follow-up data where they reanalyzed those neonates who developed hypoglycemia, and they found that the time to resolution is quite faster in those who received steroids, even though they did land up with hypoglycemia, and none of them were symptomatic. So what is important from this is that the babies do need a significant monitoring. Late preterm itself is a risk factor for hypoglycemia. And if they do receive steroids, they definitely need monitoring for hypoglycemia. Is there a long-term data? Yes, 6-year follow-up data has been published from the ALPS trial, which has clearly shown that there is not much cognitive dysfunction in those fetuses which were exposed to steroids. So you see that 17% had this cognitive testing. They had lower scores for the betamethasone group versus 18%. The confidence interval is across 1, so which says that the incidence of any disability, neurodisability at 6 years of life, especially the cognitive function, it's not the motor disability. The cognitive function was not different between these two. So the data clearly shows that the ALPS trial clearly showed that morbidities are lesser. The need for admission is less. Hypoglycemia do occur, but it did not translate into any short-term morbidity or long-term neurological issues. So are there any Indian data to support this? Yes, WHO did conduct a trial after this. So this is the antenatal corticosteroid trial, which happened in our own country in Nagpur in India. So the trial was stopped early. They planned a very huge sample size, but the recruitment was slowed down. They could not get those babies, and the trial had to be stopped prematurely at 7 when they reached a 700 sample size. They found there was no difference. The primary outcome of this trial was not looking at respiratory distress. The main outcome they looked at was neonatal death was their primary outcome, and only severe distress, so which was not very properly defined. It was clinician-defined respiratory distress. So these are some of the problems with this trial. So where they said, but there was no difference in mortality. The need for resuscitation was less. Again, this trial also showed that the need for resuscitation was less in the fetuses which were exposed to dexamethasone. The need for respiratory support was lower, but it was not statistically significant. Another trial, a small trial conducted from JIPMER by Dr. Vishnu Bhatt sir. So there they randomized 310 neonates, 310 mothers for DEXA versus placebo. But in this trial, the one of the major morbidity, diabetes, was excluded. Both pre-gestational and gestational diabetes was excluded. In ALPS trial, the pre-gestational was excluded, but not the GDM. So here they didn't find any difference between the primary outcome for where they looked at RDS or TTN. That was not different. The NICU admission rate was almost similar across the groups. So Indian data did not show much, but it was very different from what was, the criteria was very different from what the ALPS trial versus the WHO trial. So there is a meta-analysis of all this, which again supports the ALPS trial data, because that being a large trial, it shifts towards that. The conclusions are more towards the ALPS trial data. So it has shown that the relative risk is almost similar. That is 30% reduction in the need for respiratory support. And the mortality was not different, as was shown in the WHO trial as well as in the ALPS trial. The NICU admission was not different in this meta-analysis. Now, there was another recent meta-analysis. Almost 5,000 women were included in this meta-analysis. And this also again showed that the duration of CPAP for more than 2 hours was less in the mothers who received DEXA. And the surfactant was also less. So after the ALPS trial, several world bodies have changed their recommendations. ACOG, Society of Fetal Medicine, RCOG. RCOG does not practically endorse for every mother who is into preterm labor in the late preterm group. But if the mother is undergoing an elective CS, even till 39 weeks, so that mother needs to be given steroid. So that is one recommendation by RCOG, whereas ACOG states that ACOG endorses after the ALPS trial, it endorses the it endorses the need for steroids in the late preterm group. Now, following this recommendation, there were a lot of trials have come up. Observational data had come up, and they have that post-ALPS trial, in the US, there's a publication in JAMA, so where they showed that the need for respiratory support in that after the ALPS trial, the need for steroids jumped, almost doubled. People were giving a lot of steroids in the late preterm group. Did that translate into reduction in the NICU? Yes. Not very significant, but statistically significant, but the numbers may not be very high. But that also did show that there's a reduction in the neonates getting admitted to the NICU following the administration of ACS. So overall, if you look at, the need is definitely there. We need some magic bullet for these late preterm group so that they don't land up in NICU, because late preterm, they appear bigger, chubbier, but the morbidities are quite big in them. So they do land up in NICU. Some of them do need surfactant, and steroids probably seem to be helpful. But a word of caution is hypoglycemia is a concern. So luckily, evidence says that hypoglycemia is not translating into a need for extra IV fluids or extra, and it is not becoming symptomatic, but monitoring is very much essential for these babies. So late preterm per se, they also need monitoring. And if they receive steroids, they definitely need monitoring for hypoglycemia during that phase, especially in the first 24 hours. Beyond that, it may not be necessary, but first 24 hours, you need to definitely monitor for hypoglycemia. So, yeah, that is my take on this. Thank you.
Thank you, Dr. Sriram, for putting your points in favor. Now, I invite Dr. Vishnu Mohan.
Thank you, sir. A very good morning. First of all, I thank the organizers for this opportunity to be with us, with all of you today. So I'll be speaking against my friend Sriram, who was very keen and advising to give antenatal corticosteroids for late preterm gestation. So we all know antenatal corticosteroids have been the cornerstone of perinatal care from at least since last decade and a half. We know it reduces RDS, mortality, and IVH in preterms less than 34 weeks of gestation. But as my friend was telling, with the growing burden of late preterms in our country as well as globally, does this apply to these population also? Do the benefits of administering antenatal corticosteroids after 34 weeks of gestation truly outweigh the potential harms that these neonates are subjected to? So we all know there is a evidence to support that these reduce mild to moderate respiratory distress. But on the other side, again, as my friend was telling, we have neonatal hypoglycemia and potential long-term neurodevelopmental risks. So there is a significant, what is the problem? There is significant practice variation that exists between institutions and individual clinicians. We know they help less than 34 weeks, but beyond this window, the anatomical maturation benefits may not translate into meaningful clinical advantages, while systemic effects like metabolic and the suppression of HPA axis is a significant problem. So most of these guidelines were formed based on this ALPS trial. Again, as my friend mentioned, the primary outcome, there was a composite outcome was primarily derived by reduced need for respiratory supports, CPAP or HFNC. There was a marginal benefit, 11.6 versus 14.4. And again, the incidence of TTN was lesser, 6.7 versus 9.9. But does this have any beneficial effect in severe outcomes like RDS or mechanical ventilation or stillbirths or neonatal deaths? No. The effects were very comparable, 5.5% versus 6.4 in RDS, 2.4 versus 3 in the babies who needed mechanical ventilation, and there were no benefits in stillbirths or neonatal deaths. So bottom line, ALPS demonstrated benefit in transient to less severe forms of respiratory morbidity, but not in severe ones. But on the other side, you can see 15% of the placebo side had hypoglycemia, but 24% in the steroid exposed had hypoglycemia. So the number needed to harm was 12. So every 12th infant was subjected to antenatal corticosteroid had neonatal hypoglycemia. And we know even if hypoglycemia is asymptomatic or severe, they do have difficulties and problems at a later date. So potential long-term neurodevelopmental delays are still a question. So possible reason, maternal hyperglycemia induced hyperinsulinemia in these babies. So again, Indian studies, there were two studies, one from Nagpur and another one which was called off at Vellore, where the major one had 847 neonates randomized into placebo and steroid group. But the the reduction in respiratory need for respiratory support was not reproducible in this, like in ALPS. It was 4.9% versus 4.8%. So the evidence for respiratory benefit is not robust and is not reproducible in all these studies. So again, the question remains. So this was the study published from India. So the critical question of generalizability still remains. So again, these were some of the studies. This was a large study, a retrospective cohort study from Finland, where they found increases for mental and behavioral disorders with antenatal corticosteroids was higher when the 45% of the ACEs exposed fetuses were delivered at term. So this is another problem. So you give antenatal corticosteroids in these babies, and most of them go on to be delivered at term. So this highlights a concern that large number of these babies have unrealized short-term benefits, but remain susceptible for long-term risks. So again, another study from Canada where there was an increase for a composite of neurodevelopmental problems, 61.7 versus 57. So these composite outcome included audiometry testing, visuals testing, and probable neurocognitive disorders. So again, another study. So all these data suggest late preterms increases for investigation for neurocognitive disorders, mental or behavioral problems, proven suspected neurocognitive, all were higher. So these are the guidelines. As I was mentioning, the action trial, though it recommends in early preterms, in late preterm there is no recommendation. It advises not to use regularly. The FIGO guidelines again, it states between 34 to 36 plus 6 weeks of gestation. They do not recommend routinely. So there is a shift from more conservative to more permissive approach. The FIGO and WHO advises to use with caution, though RCOG recommends from 30 up to 34 plus 6 weeks of gestation. Again, asks you to be cautious and monitor. The ACOG again recommends in singleton pregnancies at high risk of delivery within 7 days, but with critical caveats like no tocolysis to complete course, and again asks you to monitor for hypoglycemia and not for the mothers who have received prior course. And again, the same with NICE guidelines as well. And the major study, the ALPS trial, which is the base for all these guidelines, they had excluded all these the mothers who had these risks like multiple gestation, the ones who had pre-existing diabetes, who received previous course of antenatal corticosteroids, and who were scheduled to have cesarean births. And again, the guidelines in these caveats, they were advising not to have tocolysis. Chorioamnionitis administration is not recommended in these babies. So potential benefits on one side is reduced TTN, reduced need for respiratory supports, but no proven benefit for severe respiratory distress. On the other side, you have increased hypoglycemia. Again, inconsistent evidence where the replicability was not much, and potential long-term neurodevelopmental difficulties were more. So a proposed framework would be to avoid routine use of antenatal corticosteroids in late preterm gestation and consider in highly selected cases with shared decision making. And if administered, a protocol of vigilance should be mandatory. So routine administration should not be recommended. Risks are tangible and significant. A proven increase in neonatal hypoglycemia and concerning signals for long-term developmental harm demand caution. Clinical decision must be highly individualized. Consider steroids only in select high-risk contexts after a multidisciplinary discussion and explicit shared decision-making. If given, be vigilant. Postnatal monitoring is not negotiable. The decision to treat is also a decision to commit to heightened surveillance for hypoglycemia. Thank you.
Thank you, Dr. Vishnu. So both the speakers said their perspectives. So since their time is actually not permitting, so we'll not invite for rebuttal. Okay. So just to conclude, although there is clear evidence for use of antenatal corticosteroid below 34 weeks, so especially after Action 1 trial, so there was a little controversy. But for more than 34 weeks, so there are issues for our countries. Definite issues for it cannot be generalized. Okay. So there are definite issues. Number one is correct gestational assessment. So that is one big issues. And when antenatal corticosteroids is given, when the baby is delivered, that is another issue. There is a very less data on this. So if delivery is beyond 7 days or beyond 2 weeks or delivering at terms, so there are risks for neurodevelopmental problem. So it cannot be generalized. Another is there should be neonatal care support that should be available. As highlighted by various studies, it only reduces the modest respiratory problems, not very serious. So in terms of neonatal mortality, there is no change actually. So, but the Western countries, RCOG, SCOG, and so many, they are recommended. But here in India, there is a lot of problem. The major chunk of prematurity lies between 34 and above. And if use will be generalized without monitoring and without follow-up, then it will definitely going to create an issues. And there are many other issues, like even dosing, even dose. What dose we are using, actually even lesser dose has been found to be useful for this. So we should wait for more evidence from low middle countries, and Action 3 trial. It is already under, and hopefully the report will be available very soon. So they have actually 3 arms. One is just control, another is 34 weeks and above, up to 36 weeks plus 6 days, and third is less dose. So we are waiting what is the evidence from.
So routine use is not recommended.
Yeah.
Maybe
Yeah.
electively used in specific cases. Yeah. Thank you, sir.
So thank you both the speakers and ideas. Thank you. Yeah. Yeah, basically, it's but long term, you're basically the major concern is lack of monitoring and follow. So you can imagine if you recommend it, its use is it's not same profile. A lot of SEA babies, okay, although they look small. So that's why the gestation age, it's an imminent birth and correct gestation age assessment. That is the very important point. So it will not be equated like a baby looking small, having less birth weight. So it will be equated with gestational age. So that is a big issue. So you are basically going to have a baby who is probably having a poor neurodevelopmental outcome. That is more dangerous rather than just mild to moderate respiratory issues, and which can be easily handled by.
But that risk is with all preterm babies, na?
Yeah,
With,
so
and not
basically
only
that,
late
that
preterm.
care is required. So India is moving towards like SP, newborn stabilization unit is being scaled up everywhere at CSC level. And actually you have to have a care for newborn, especially temperature, mild respiratory issues. You have to take care, feeding issues and all. So you have to develop it.
No, but sir, there are a lot of studies showing that the incidence of RDS is pretty much high, even 36 weeks.
It's basically mild RDS, mild respiratory. It is having a benefit, but in terms of final neonatal outcome, that is mortality, there is no impact. Okay, so that is the point.
Yes, as sir said, mortality, there is no difference. Yes, there is no cost effectiveness looking at exactly in the late preterm group, but if you look at, there are studies where they looked at overall cost of NICU stay in our country. I did project one slide, but I just ran through it. So there is a cost is definitely involved. If baby definitely gets admitted to NICU, cost is definitely an issue. If he lands up in CPAP for even just for 6 hours or something, it does have an impact on that. Long term, till now, safety is okay. The main issue is, as sir said, identification of which mother is going to deliver late preterm after receiving steroid. That is a major thing. It applies even for mothers who have received steroids less than 34 weeks also. Because all these long-term concerns, as Dr. Vishnu has pointed out, are those mothers who receive steroids and then landed up at term gestation. So if that happens, then the brain is exposed to steroids, but the baby didn't land up preterm. He continues to stay in utero and then delivers at term. Those are the neonates who are at risk of long-term neurological issues. Yeah. But if they land up earlier, steroids seem to be beneficial. That means if you give steroids for that purpose, that means if the mother delivers late preterm or preterm and he receives steroids, the steroids are beneficial. But if they continues to stay, then it becomes a problem.
Yeah,
That's
almost 45% was the number who progressed on to deliver at term. So that's a very significant number. So that's the problem with generalization. And again, one of these studies showed increased cost for the neuronal monitoring at a later date. So though the data is very less, the sample size was less, but that study showed increased cost for monitoring at a later date.
Yeah, imminent birth. Okay, so that has been very well defined, even for less than 34 weeks. So there must be cervical dilatation criteria, more than 3 centimeters, effacement, rupture of membrane, either rupture of membrane or the mother is having severe morbidity like APH and eclampsia like. Okay, so it's very stringent criteria even for less than 34 weeks. So it is not like कि थोड़ा सा लेबर पेन हुआ या कुछ लगा तो तुरंत दे दिया, or delivery is happening at terms. So this is the major threat for India. Okay, so there are very stringent criteria for imminent preterm labor. Okay, that has to be followed. That is not followed actually. Yeah. So thank you,
Thank you, sir. Thank you.
Thank you, sir. Thanks, sir, for the nice discussion. Now I request moderator to felicitate the speaker and speakers to felicitate the moderator. Sir. Next session is a panel discussion on fetal growth restriction, predict early, intervene timely, support lifelong. For this, I invite Dr. Ranjan Kumar Pejavar. Sir is Professor and Chief Neonatologist, Meenakshi Hospital, Bangalore. He is President NNF India, past Chairman IAP Chapter of Neonatology, and past President Federation of Asia Oceania Perinatal Societies, founder and editor of Index Journal of Perinatology. He has multiple publications. Welcome, sir. And for this panel, I request Dr. Abhay Matthew, Dr. Dheeraj Divakar, Dr. K.V. Sridevi, Dr. Ragasudha Chupana. I request moderator to introduce the panelists, sir.
Good morning to all of you. At the outset, please take it. At the outset, on behalf of myself and my panelists, I would like to thank the organizers for giving us an opportunity to be here at this NNF conference and the beautiful city of Vizag. Thank you. Now, this is a pure perinatal topic where liaison between various specialities are required. This is what happens in practice. And it is very important that it happens systematically and properly for a proper outcome, both of the mother and the child. So perinatal approach for managing babies is absolutely needed if we have to reach or come anywhere near a single digit neonatal mortality by 2030. Now, I am blessed with a very eminent elite panel. That is we'll start with Dr. K.V. Sridevi. She's the fetal medicine specialist. Identify yourself. And she's the director of the Ian Donald Ultrasonography Training Institute of South India. After her RCT, she got her diploma in ultrasound at UK and in fetal invasive procedures from Italy. Welcome, Dr. Sridevi. Dr. Ragasudha is a senior consultant obstetrician at Birthright by Rainbow Hospital. She is VP of OGSV, Vice President, member of Motherhood Committee of FOXY. She has co-authored 2 books, and her special interest is high-risk pregnancy and critical care obstetrics. Coming to the neonatologists, we have Dr. A.B. Matthew, Senior Consultant Neonatologist and Pediatrician, Sunrise Hospital, Cochin. He is the National Coordinator for Sepsis Module, which was the Presidential Action Plan of 2025. Dr. Dheeraj Divakar is DM Neonatology, Senior Consultant Neonatologist and Director of Radiant Children's Hospital, Udaipur. He is the Secretary General of NNF Rajasthan. So with these people, I'm going to try and unravel some of the issues in fetal growth restriction. Evaluation of fetal growth is a very, very important objectives of prenatal care. Identifying a small fetus, classifying the fetal growth, understanding the etiology and risk factors, formulating a comprehensive strategy to tackle this baby, fetus or baby, when delivered is an imperative reason for a successful perinatal care. So let's start with the first point in this discussion. And I would invite Dr. Dheeraj to tackle this one. Define FGR. FGR henceforth is, I will say FGR, fetal growth restriction. How is it different from SGA? Is there a classification for that? And if so, any consensus is there? Dr. Dheeraj.
Thank you, sir. Thank you, sir. So we will start with definition of FGR. FGR, fetal growth restriction, defined as failure. So FGR is defined as failure to meet the predefined biological growth potential by a fetus, and it can be early and late. But FGR, when we're talking of FGR, it is pathological. There is one more entity known as SGA, small for gestational age. So if you see the growth charts, the babies who are falling below a certain percentile, like 10th percentile, they are known as, defined as SGA. So abdominal circumference or estimated fetal weight, if it is below 10th percentile, it is SGA. But quite frequently they are interchangeably used with FGR. So there is confusion. So how to eliminate this confusion? So Delphi consensus was there. So before Delphi consensus, if we see some differences between SGA and FGR, SGA babies can be constitutionally small. It can be physiological, while FGR are always pathological. As far as perinatal outcome is concerned, in majority of the cases, in SGA babies, it is normal, while in FGR babies, it is abnormal. So if we come to the consensus, so Delphi international consensus is there. Here, 18 evidence-based parameters were given to international panel of experts, and they were told to arrive at a consensus. So after thorough study of these parameters, they arrived at a consensus and categorized it as early and late onset FGR on the basis of onset. So below 32 week, it is early onset, and after 32 week, it is late onset. And there were certain criteria, certain parameters, some solitary parameters, which are, if they are present, sufficient enough to diagnose FGR, and some contributory parameters which require other parameters also to be abnormal. So if we see in early onset, estimated fetal weight or abdominal circumference below third centile definitely alone is sufficient to define FGR. If umbilical artery flow, absent or reversal flow, alone is sufficient to define it as FGR. Whereas if the estimated fetal weight or abdominal circumference is below 10th percentile, it required one or more of the following criteria, like umbilical artery PI more than 95th percentile or uterine artery PI more than 95th percentile. Likewise, in the late onset FGR also, if estimated fetal weight or abdominal circumference below third centile alone is sufficient, but two or more of the following three criteria when it is below 10th percentile. Either the crossing percentiles are more than 2 quartile. Like if the growth was detected at 70th percentile and it went below 20th percentile, that means more than 2 quartiles. Or late, that means it has affected middle cerebral artery circulation also. So cerebroplacental ratio is below 5th percentile, or umbilical artery PI more than 95th percentile. So this was the Delphi consensus for defining FGR. And there are difference in early and late onset FGR. So early onset at FGR age, we have said below 32 weeks, and their prevalence. Next slide, please. So if we see, the prevalence of early onset FGR is 30% and versus 70% in the late onset. Or if you see in general population, 0.5 to 1% in early onset and 5 to 10% in late onset. Main challenge for early onset FGR is management, while diagnosis is the challenge in the late onset. Their biophysical parameters are abnormal, maybe abnormal. Fetus size is small in the early onset, where it may be normal in the late onset. As far as perinatal mortality is concerned, it is high in the early onset and slightly decent in the late onset.
Thank you. So we have to be clear about SGA and FGR before we proceed, because then we are going to a question of etiology and early risk factors of FGR. The eye sees what the mind knows. So we have to have some idea about this. when we have to suspect whether it is SGA or FGR, and if so, what are the risk factors, what are the etiological factors of that? To talk to us about that, we have Dr. Abby Matthew.
Good morning, all. Thank you, sir, for the question. The question can be divided into two parts. First is the etiology. The etiology can be maternal or fetal factors. So maternal, it can be pre-placental, placental factors and umbilical cord factors. So coming to maternal, it can be a chronic lung disease, anemia, suppose the mother is smoking, using substance abuse, environmental toxin, air pollution can affect. Coming to the placental factors, it can be maternal vascular malperfusion, like infarction, abruption, or it can be fetal malperfusion and other chronic placental mosaicism. Coming to umbilical factors, the umbilical cord there might be coiling, or the cord might be more length, or there is absent single umbilical artery and Willebrand's cord malformations. And coming to the fetal disorders, it can be genetic, like chromosomal abnormalities, microdeletions, or there can be congenital heart disease, gastrocases, or there can be congenital infections, which we commonly see like CMV, toxoplasma, or multiple pregnancy. Next slide. Coming to the risk factors can again be history-based as well as biomarkers. So coming to history-based, there can be maternal demographics like advanced stage, underweight, and there can be other factors like environmental pollution and toxins. Coming to medical conditions, the common conditions that can affect the mother are the chronic hypertension and chronic kidney disease, antiphospholipid syndrome, and gestational diabetes. And we should always ask obstetric history that should be whether there is any previous history of pregnancy with fetal growth restriction or preeclampsia. And coming to a small part about the investigations, the biochemical markers which may show in FGR baby low placental growth factors or a low pregnancy-associated protein A or a high alpha-fetoprotein. And during ultrasound, the obstetricians pick up findings like uterine artery pulsatility index of more than 95, uterine artery bilateral notching, etc.
Thank you. Now we go to the stage where we have a fetus, which we think may be FGR. So, Dr. Ragasudha, what is the role of early risk prediction? And is there any possibility or chance for prevention?
Yes, sir, very much. So though Dr. Abby Matthew has shared many causes for FGR, mostly FGR, essentially we see it as a disease of placental dysfunction, so which is the most common cause amidst other things, though there are many risk factors. And when it comes to prediction, so what we try to predict is the malfunction or the dysfunction of the placenta. So it starts with the history-based risk stratification. So this can be applied in, the best thing of this is it can be applied in low resource settings. So it's just history taking where we ask for all the risks that were mentioned earlier and also the causative factors. And this can, as a single prediction point, it can predict up to 37%. It can detect up to 37% of FGRs. And to that, we can add mean arterial pressure, which is also a very simple thing which can be done by anyone in any setting. This also adds to history-based risk stratification. Coming to ultrasound-based markers like uterine artery pulsatility index. So it is actually it adds so much extra 19 to 27% to history-based risk stratification, but it may not be available in all resource conditions. And biochemical markers is definitely PLGF and the previous slides, please. Previous slide. So biochemical markers, PLGF and pregnancy-associated plasma protein A. So these are the two markers that we measure along with NT scan between 11 to 13 weeks, 6 days. along with double markers to assess the risk of preeclampsia as well as Down syndrome and other chromosomal abnormalities. So if this is available, it increases the risk prediction to around 90%. So the model that rather than single prediction models, so combined prediction models are best. So what we have been following in our hospital is FMF risk prediction triple test model, which can predict up to 90% of these women. So that's what we have been following. And next comes the next part of this question is prevention. So prevention is also very, very effective. It begins with optimization. If we can predict, then the next thing is prevention, optimization of maternal health, like correcting anemia and correcting sugars, hypertension, so all these, and even undernutrition for those who are malnourished. So educating them right from the preconception period about the balanced diet and all that will definitely have a very good effect. So low dose aspirin trial has shown that it is 60% effective in preventing preeclampsia because the pathology and pathophysiology is almost similar to preeclampsia. So we extrapolate the data to FGR as well. So low dose aspirin, the dose is 100 to 150 milligrams, should be started always before 16 weeks, ideally 12 to 16 weeks. And the time of taking is also very, very important in the evenings or in the nights. And so this can prevent up to 60%. But having said that, low dose aspirin, even aspirin trial has shown the women with chronic hypertension, they fail to respond to this. And recently, in the last week, we have seen a woman whose PAPA was very low at the time of NT scan and double marker, who was given low dose aspirin right from 12 weeks of gestational age. In the evening, adherence was very good, but still she didn't respond. It was a failure. She has developed early onset FGR at 26 weeks itself. When we did early growth scan, it was second centile with absent diastolic flow. And she had to be delivered at 27 weeks last week. So there are certain aspirin failures as well, even though the adherence is very good, other than even chronic hypertension, individuals with chronic hypertension. Low molecular weight only if there is an APLA or confirmed thrombophilias, this can be given, but not universally for all women.
Thank you. Actually, you actually put some optimistic views about the FGR in your answer. And then, of course, you said that there are some aspirin failure cases also. Early detection is always better, right, of FGR than the prognosis is better. Okay, now next we go into some hardcore fetal medicine. Hardcore fetal medicine telling us about the aspects of screening for FGR, especially about Doppler velocimetry and sonographical fetal weight estimation, which is quite an important aspect. And for that, Dr. Sridevi, could you kindly proceed?
Thank you for the question, sir. So I would like to answer this question as fetal weight and Doppler separately. Coming to the fetal weight estimation, the first thing we have to know is the gestational age. So if we don't know the gestational age, whatever we are going to do is like we are just going to walk in a blind room without light. So we measure the fetus at different weeks. The first thing is CRL. And next, DPD, HCA, CFL are the 4 parameters we are going to measure in all the scans from the second trimester till term. These values gives us numbers, and the numbers are going to talk. So what is this measurement? So we are going to get biometry, and this biometry is going to give us the size and the growth of the fetus. Next slide. But there's a lot of difference between the biometry, that is what we see in a single scan, but the single scan never tells about the growth. It's a change in biometry on different occasions. That means you need serial scans to know about the growth of the fetus. So somebody comes with a single scan and show you how it tricks you to say that this baby is growing fine, but not so. The growth depends upon 2 components. The one is genetic and the other one is substrate supply. The next one. So we can see here the growth charts. The first one is normal because it is between 10th and 90th percentile for the gestational age. The second one is very obvious. It is crossing centiles and it is less than 10th percentile. The next one. Here, the first slide shows the crossing percentiles and more so in the abdominal circumference. But the second one is adequately grown gestational age. But you can see in AC, which is around the 80th percentile, is coming to 20th percentile by 34, 35 weeks. It is crossing percentiles. That means this baby's growth potential is fairly here. These are the ones which we miss just if we take the gestational age weight into consideration, because this weight is a surrogate marker. Just by weight, if we see, we are going to miss these cases because there's a not crossing 3rd percentile or 10th percentile. There's a reason why we see a lot of stillbirths at term which the growth is fine. So in 3rd trimester, when we are doing growth scans, we have to do a Doppler. This is where the Doppler helps us to screen these babies which are at risk for failing the growth potential they are supposed to be. And always, we need a growth chart in the 3rd trimester scan. We have to look at the growth chart. The next slide. So the 3 things which we see in the Doppler are uterine artery, umbilical artery, and the middle cerebral artery. Next slide. So the uterine artery Doppler we do in both 1st, 2nd, and 3rd trimesters, but any PI more than that's the only thing which we're going to use is the pulsatility index. When it is more than 95th percentile, we are worried. But isolated uterine artery PI doesn't give us any value. We have to do it with a combination. So if we are doing the screening in the 1st trimester, it has to be with the maternal factors, mean arterial pressure, and the biochemical markers. So usually many of the private settings, when we do a 1st trimester screening, this is part of it. So anything risk of 1 in 100 is high risk, and they are started with the co-screen. I'll show you the reason why. Next slide. So I don't want to go into the details, but the ones which are marked, we can see 60% sensitive to very severe preeclampsia less than 32 weeks. And 2nd trimester, it is 93% sensitive, but because uterine artery Doppler screening is that not very sensitive to late onset, but it is very sensitive to early onset preeclampsia, which we are worried about. As an obstetrician or a neonatologist, these are the challenges we have. So the advantage of doing screening in the 1st trimester is we have a therapy because the uterine artery trophoblastic destigitalization happens in 2 phases. The first is at 11, the second is at 16. So if I'm doing screening at 11 weeks, I can give a therapy, which is an echo screen, which helps in the next phase of destigitalization problems to not happen. But if I'm doing screening in the 2nd trimester and I want to give echo screen, the second wave of destigitalization is also done. So my strategies are not going to help much in these women. Next slide. So moving to the umbilical artery Doppler, more than screening, it is basically useful to help us to prognosticate and diagnose. So you can see the first slide, how the diastolic flow is good. So we always need good diastolic flow, less PIs. So if the PI is increasing, that means the diastolic flow is decreasing. So once the diastolic flow is 95 percentile, that means this placenta is at fault. Umbilical artery Doppler speaks about what is happening in the placenta. So if umbilical artery Doppler is more than 95th percentile, that means almost 35% of this placenta is at fault. We are seeing next changes like absent or reversal flows, then it is almost 60% of this placenta is at fault. So once we see this, the next vessel we are going to check is the middle cerebral artery. We can see in this picture, the middle cerebral artery always we need high resistance, intracranial pressure maintains this. So as we have seen in uterine artery, as we have seen in umbilical artery, we need less pressures. So anything more PI, we are happy, or less PI, we are happy. But here, the less PI, that means if the PI is falling, we are worried because the intracranial pressure decreases when there is hypoxia or an adaptation. So any PI of middle cerebral artery coming less than 5%, this puts us an alarm. So this again helps us for screening one late onset or the fetal anemia. But the CP ratio, that means C is for cerebral, which tells us about the middle cerebral artery PI, and P is for placenta, is umbilical artery ratio. So the ratio of these two, if it is close or less than 1, we are worried. So individually taking umbilical and middle cerebral artery, the CP ratio has more prognostic value or is a more stronger predictor to know the problems in the fetus.
Okay, now, well, we have reached a stage where in layman's term, we have two persons in the society, and both are showing signs of unruly behavior. One we have ruled out, won't be much of a problem. The other one we are monitoring very, very carefully. So, but to monitor and to monitor the growth, it is always said that one reading will not give you any conclusive information. So even here, like the growth charts, we have intrauterine growth charts. May I ask Dr. Dheeraj to take us through this issue of growth charts?
Thank you, sir. So when we are speaking of growth restriction, the role of growth chart become very important. These are basically specialized tools used to track the growth of the fetus or preterm infants. And very well-known growth charts are like Fenton's growth charts, Intergrowth 20%, Lukashenko. Lukashenko is, of course, now outdated, no longer used. They help us identifying SGA and LGA babies, like those falling below 10 percentile or above 90th percentile. They are very crucial for assessing fetal well-being. And here, since we are concerned with the fetal growth restrictions, so estimated fetal weight or abdominal circumference is very important. That part in the growth chart is very important. So now what to use? Which growth chart should be used? There are growth reference versus growth standards. So growth reference are basically descriptive charts, which are used to assess the distribution of weight of all the newborn in the normal population. Here they include both normal as well as complicated pregnancies. So they are affected by rate of pathology in the population. So, like the population where incidence of LGA is more, like due to diabetes or obesity, versus the population where incidence of growth restriction is more due to malnutrition, their reading will be affected. So growth standards have come into existence where low risk pregnancies, they are prescriptive charts which uses data from the low risk uncomplicated pregnancies. So they are slightly better from growth references. Now, what is about estimated fetal weight and birth weight? So birth weight based charts are very good, but there is one shortcoming that they are not very accurate in the preterm gestations. They tend to underestimate the rate of FGR in the preterm gestation. So there is the limitation. That's why the estimated fetal weight based charts came into existence, where the measure which has to be compared is the same. That is, these charts are prepared using estimated fetal weight, and during pregnancy also the growth is monitored by fetal weight estimation. So these charts should be preferred over the birth weight based chart. Then next come universal chart or customization. This is very important because previously it was assumed that the growth is universally same of the fetus. Only adverse environmental conditions, they tend to affect the growth in different part of the globe. But that also, on the basis of that, like WHO standard and Intergrowth 21st charts came into existence. But later it was realized that it is not only affected by environmental factor, racial factor also has a role. So NACSD charts came into existence, which eliminate the bias factor of race, and they prepared race-based charts like white, black, Asian, and Hispanic races. Then later it was realized that this is also not sufficient, and maternal physiological parameters also affect the growth of the fetus. So maternal weight, height, parity, fetal gender also taken into consideration, and charts were prepared. So these were the customization. Later it was realized that individualized growth of the fetus should be taken into consideration. That means during second trimester of the gestation, a fetus growth was assessed serially, and growth trajectories were prepared. And in the third trimester, the fetus was compared that whether it is achieving its growth potential or not. So these are the some major growth charts. 10th percentiles are shown, like headlock, NACSD, intergrowth, WHO, and Alexander. Alexander is only birth weight based. The rest all are sonographic fetal weight estimation based. Now, this is very important. Some of the growth charts like headlock and WHO, their 10th percentile is upward shifted. Whereas some of the growth charts like intergrowth 21st, their 10th percentile is downward shifted. So here lies the problem. So you can see the green dots, they are normal pregnancies, normal mothers, and the red dots are mothers at risk. So those charts who are upward shifted, they have tendency to detect all the high-risk pregnancies, but at the same time, they will also detect some normal pregnancies. So there is high false positive rate. Against, if you see the charts who have lowered shifting, like intergrowth, they have tendency to detect most of the high-risk pregnancies, but at the same time, they tend to miss some of those cases. So there is under detection. So here lies the role of customization. So that FIGO and Newborn Committee of Society of Maternal Fetal Medicine, they have given some recommendation that growth standard should be preferred over growth references. Then some local or regional charts should be preferred over universal charts. And universal standard may be used like WHO and intergrowth 21st, but that should be adjusted. That threshold should be adjusted according to the local population. And as far as twins are concerned, twin specific chart should be used. Otherwise, we may end up overdiagnosing the twins as FCR or small for gestational.
Okay, now we have to hasten up now. Now we have come to a stage. We have to counsel the lady regarding her impending delivery and baby. We can't keep her in the dark. How do you go about that, Dr. Aksuda? Yeah, you that.
So thank you, sir, for this question. So it is very, very challenging. Counseling this couple is very, very difficult, though at the time of after we predict, we tell them that the risk of growth restriction or preeclampsia could be higher. They fail to understand all the implications at that stage in the first trimester. So after diagnosing FGR, and moreover, after seeing Doppler changes in the early gestational age itself, it is definitely a challenging counseling session, which needs to be a multidisciplinary counseling session, because everyone needs to be on the same platform. The data that we give to them, that should not confuse them, but they should have a very clear picture of what's going to happen to the baby and when they need to be delivered. So all that should be given very, very clearly in order to have better trust upon the team. And it should be very, very, outcomes should be very clearly explained. So this is where the neonatologists are involved. So they can explain to them the survival rates and the neurodevelopmental impairment and the risk of neurodevelopmental and long-term impairments and the problems that the baby will have to face in the immediate neonatal period. And even the place of delivery is also very, very important. It needs to be a tertiary care center where all these are available, especially when it comes to extremely preterm babies as well as preterm babies, early preterm babies. And so all these need to be, and even the finances, economical implications, even they need to be discussed, because it's not, it's a very costly affair, which might cost many lakhs to them. And we can even tell them about crowdfunding if they cannot afford the cost that is required to have them kept in the NICU. So all this is from the data which shows the survival rate as well as neurodevelopmental impairment. So showing these data, we can explain to them very clearly what's going to be the outcomes for these babies after they deliver. And we also reassure them that we'll be with them in every step, and with a very good optimization as well as an expert neonatal care with all these facilities, so the best possible outcome could be given to these babies.
Now we come to the most trickiest part of the problem, timing of the delivery. How to know how to go about it, and what will happen. To talk about this, we have to ask Dr. Sridevi again.
Thank you, sir. Basically, I'm going to speak the fetal aspect of delivery today, because the maternal aspects are also there when we have to take the decisions for delivery for the preterm. So the decision, especially in relation to FGR, depends upon the stage of FGR the baby is. So if the baby is in stage 1, for all the 4 stages, the fetal weight less than 10% is common. As the stage increases, it is the Doppler changes that are going to become more and more severe. So the first stage, it is just the CPR less than 5 percentile, middle cerebral artery less than 5 percentile, and the umbilical artery and the uterine artery Dopplers more than 90%. When coming to the stage 2, along with the fetal weight, it is the absent and diastolic flows. But any scan you're doing, just one scan, don't report it and jump and say this is a problem. We ask them to wait for some time, we repeat the scan, or sometimes we call them on the same day evening, and then we reconfirm the findings before we tell this is abnormal and we're going to take action. And coming to the stage 3, there is further progressive disease where we see the reversal of flows with the ductus venosus Dopplers hitting more than 95th percentile. And the stage 4, even the ductus venosus is reversed. Next slide, sir. So if it is FGR1, you can wait for 37 weeks. Vaginal delivery is not contraindicated, but if the MCAPI is less than 5%, then it's a compromised babies. The chances of emergency cesarean during labor is around 50%. So we need to talk this to the mother also. In FGR cases, from 34 weeks, we should start thinking of delivery when the baby reaches 34. So in stage 3, from 30 weeks onwards, we should start thinking of the delivery, and stage 4 from 26 weeks onwards. So this is a graphic depiction where we see if it is less than 32 weeks, we just wait because we want to buy time. So we want the Dopplers, later Dopplers, or we use even the venous Dopplers to take a decision or call for the delivery. Next slide, sir. Well, the main aim of surveillance is to recognize hypoxia, deliver before asphyxia. Therefore, we avoid prematurity and deliver a healthy neonate. Next slide, sir. So when to deliver? The major, because there are so many concerns, is the things we do see, but the major determining factor is the gestation age and the neonatal care available. So we have to actually counsel regarding in utero transfer, then you deliver and send the baby in the cases of extreme prematurity. So if it is less than 32 weeks, every day is a painful. So we actually play more with the Dopplers. We do regular scans, and we just wait till the venous Doppler changes are there. But if it is more than 32 weeks, I think we can deliver the babies with the corticosteroids. So when to call it late, it's $1 billion question, because it can be a non-reactive NST or a biophysical scoreless 6 by 10 with oligohydramnios, or an umbilical middle cerebral artery going into a background, venous Doppler changes like a volume decreasing, lack of growth, gestational age 35 or 36 weeks, or the maternal conditions. These things doesn't happen as I have told. They can be a combination of things. Sometimes a chronic situation, suddenly an acute situation may come over it. Like chronic hypertension, suddenly she might have imminent preeclampsia, or sometimes they might come with an abruption. So we have to tailor the decision deliveries in these cases. There is no single line to say this is a date to call it as a date.
Okay, we come now to the baby has to be delivered, and quickly, 1 minute each, delivery room management of the mother, Dr. Ragsudha, followed by the delivery management of the baby by Abby Matthew.
I'm very sorry for the interruption. So there is now an extremely preterm baby in the hospital who is going to deliver just now. So that's why I'm getting the call from the neonatologist. So delivery room management, team readiness is very, very important. So we need to inform or give the information to our neonatology team so that they would be ready with everything that is needed at the time of delivery. And maternal stabilization is also very, very important. I mean, so we must ensure hydration to the mother, that she is well hydrated and prevent hypotension, as well as avoid supine positioning of the women, because these babies, they are already challenged with very low reserve who can become hypoxic very early. So they need to be under continuous fetal monitoring. And as I've already told, neonatal preparedness is very, very important, because these babies, they might need immediate and active resuscitation at the time of birth. And even temperatures need to be maintained very well, as well as there can be hypoglycemic sugar control should also be maintained very well. So it's all this. So the main aim is to have the baby in a very, very good condition. And sometimes we might need to take, as Sridevi has already told, when CPR is less than 5th centile, so 50% of these women can land up in late preterm in a cesarean section. When we see CTC abnormalities, repetitive deciltrations and other problems, so we might have to take them for an immediate C-section. So all these are very, very crucial. They play a very crucial role in managing the labor room at the time of the delivery of these women with FGR babies.
Dr. A.B. Matthew, now regarding the baby, don't please duplicate what she has said.
Madam has just told. Madam has told about the obstetric point and about the baby's point, so things like it. So we had a heated discussion regarding antenatal corticosteroids. So we will ask our obstetric friends to have a judicious use to give if pregnant, if the delivery is impending and if gestation age is less than 34 weeks. And when you give steroids, there can be a transient improvement in Doppler, but you should not change from your original management plan. And there is a role of magnesium sulfate also, as it has a neuroprotection in women who are at risk of preterm in fetal growth restriction less than 32 weeks. And studies have shown that it decreases perinatal mortality, cerebral palsy, gross motor dysfunction. And there are so many other investigations which are of no proven benefit, like sildenafil, VGF, gene therapy, prostaglandins.
Dr. Dheeraj, comprehensive strategy for delivery room management has been now explained. What is the overview management of SGA babies? It's a different topic altogether.
So, as far as management is concerned, proper diagnosis and treatment. So, diagnosis, I think our previous speakers already have covered, like pinpointing whether the cause lies in the environmental factor, maternal factor, fetal factor. Then we come to the delivery room management. Is most of these babies are they are exposed to undernutrition and hypoxemia. So, a skilled team which can deal with all sort of challenges during resuscitation should be available. They are at high risk of hypoglycemia and hypothermia because of low reserve of the brown fat and subcutaneous fat. So thermoregulation with all the steps of warm chain should be maintained from the birth, from the labor room to the NICU. Hypoglycemia also because of low glycogen reserve, as well as insulin sensitivity related things. So proper glucose monitoring and management. Then they are at high risk of developing NEC and feed intolerance. So protocolized feeding regimes and age per unit prophylactic probiotics should be used. Respiratory failure, so proper adequate respiratory support should be provided to them. They have high tendency to develop IVH also, so IVH preventing bundle should be there. Very important is their follow-up. They are at high risk of neurodevelopment impairment because of low gray matter in the limbic system. So some motor scores, low motor scores, low cognitive scores are there. So proper prompt neurodevelopment follow-up is important. And while managing them, it is very important that rapid catch-up growth should not be there. Otherwise, they have tendency to develop the central adiposity syndromes. They have high tendency to develop metabolic syndromes, and in later adult life, they are at high risk of obesity, diabetes, and cardiac diseases. So their early management is very crucial, very important for their overall survival and overall better neurodevelopment.
And the last part of the discussion, Dr. Sridevi, you have to counsel the mother what will happen in the next pregnancy.
The counseling depends upon the causes of FGR. So the pre-pregnancy counseling is very essential, and the maternal factors, especially regarding the hypertension or any metabolic diseases, the mother, it has to be stabilized. Coming to the fetal things, if it is an infection in the previous pregnancy, the chances of recurrence is very low. But if it is a congenital anomaly or a genetic abnormalities, a proper workup is very needed. Unless we have a proper index case workup, we can't put a needle and we can't see in the next case. So it's very essential to do it proper genetic workup before this woman becomes pregnant. So pre-pregnancy, we have to know the cause and we have to stabilize these women. But if they are pregnant, the first trimester screening, especially the uterine artery Dopplers with the maternal factors and the biochemical screening helps us, because this is a point where we can catch many of them, because preeclampsia is one of the main reasons for the placental insufficiencies which cause IUGR.
Thank you. Gone are the days when we said, I am in charge till the cord is cut, you take over afterwards. Those days are gone. Pediatricians, obstetricians should liaise right from the antenatal period, in some cases even preception. And we now have the luxury of having fetal medicine specialists, pediatric cardiologists, super specialists. Let us not be shy. We will hold hands together and liaise early so that we'll have a good outcome, both mother and child. Thanks for your patient listening. FGR is a very, very tricky subject, but it's a sterling example where perinatal management brings out good results. Thank you.
Thanks a lot, panel, for the comprehensive discussion.
Thank you very much. I enjoyed this discussion. Regarding the growth charts, there was a talk regarding we should have a Indian charts. But as I understand, India is a very large country, north, south, east, west. So should we, what it would take to have Indian charts? I mean, what kind of population you will have? You will say these are truly Indian charts, because the growth potential of Punjabis is much different from that compared to what is here in Northeast or in the South India. So what are your take, Doctor, the first one? Sorry.
Neeraj, after that I want to add.
So what do you feel? Or should we go for WHO charts, which represents the global?
Globally, sir, like if we talk of Intergrowth 21st, WHO and these NICHD. So in Intergrowth 21st also, published in 2014, like 8 different countries from high and middle income countries, the sample size was taken. From India also one city was there. So they eliminated the risk factor of like adverse environmental factors. So still, I think that factor alone was not sufficient. In WHO also, I think 10 different countries, it was published in 2017 and the sample size was 1387 patients. So here also, there were some confounding factors, and that universal weight of all the babies across the globe was not same. That's why the need for individualization came into existence, and that like maternal physiological parameter, maternal height, weight, plurality on fetal gender, all these also taken into consideration.
But if you take too many variables, it will become very, very complicated, and the people may not be able to use it.
Can I answer your question?
Yeah, please go ahead.
The growth charts, when we come, we largely come into an Asian population. So when we have growth charts, all these parameters, because when we put the growth charts, the ethnic origin comes.
Yeah.
So we come into the Asian, so the growth charts modify according to that in the softwares we use. And I personally use a software which the data is for the South Indian. It's good to have the growth charts for different regions. But the problem is we don't have those many studies or standardized things. So if it comes up, it is good. But there are studies which is Indian population But in Indian population, the subgroup of the states or the regions is not there as of now. The one which which I use personally in my clinic is the software which the study is done. Majority of the women who are enrolled into the study, because it is a heterogeneous population. You cannot say when you are, treating, a Punjabi can walk in and say, I can't do this. Yeah. So it is a heterogeneous population. So even if the WHO or whatever done, everything has an ethnic origin. These are Caucasians, they have Africans, they have Americans like that. So in those charts also, as Asians, we are part of this study. So there are some growth charts which when we use online, sometimes we have some issues. Then yes, because of the ones which are on the machine or the ones which are like, European charts or American charts, where the baby is small, but once we shift and put it in our software, they'll be growing fine.
Thank you. So
Thank you. Thank you, because we were already overshot the time. I would like to go out of this hall with a parallel question. What is an Indian costume? What is Indian cuisine? That's all. And thank you, panelists. You are very succinct and crisp. Thank you very much. And thanks one and all. Plenary session has started in Hall A. And you are requested to move to Hall A. Individual, come, you can ask whomever you want to ask. But the session is over.
You.
Thank you.
Thank you, panel, for the comprehensive discussion on FGR. So I request panelists to please honor the chairperson and chairperson to please felicitate the panelists. Next, there will be a pause in session in Hall B. Please note that next session will commence at 1:30 p.m. All participants are requested to proceed to Hall A for plenary, followed by NNF oration and gold medal paper presentation. Thank you.
Usually this question will be asked about this chart.
Actually,
Moving on.
Hello, 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 check, 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 1, 2, 3. Hello, hello, check, check, hello.
పాండు సార్తో మాట్లాడాలి మేడం ఆయన ఏమంటే చేస్తాం
ఆయన్ని ఈవెంట్ అతను ఈవెంట్ అని ఆర్గనైజ్ ఈవెంట్. హలో హలో చెక్ 1 2 3. హలో 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 చెక్ 6 6 6. హలో 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 చెక్. హలో 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 చెక్. హలో హలో చెక్ 1 2 3 4. మైక్ చెక్ 6. హలో 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 ఇది హలో 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 వస్తుందిగా అది ఇంతకుముందు వచ్చినట్టు. హలో మైక్ చెక్ 1 2 3 4.
test. 1, 2, 3. Hello, hello. Mic test. 1, 2, 3. Hello, hello. Hello, hello. Mic test. 1, 2, 3. Hello, hello. Test, test. Mic test. Hello, hello. Mic test. Hello, hello. Hello, hello. Mic test. 1, 2, 3. Check, check. Mic test. Check, check. Mic test. Hello, hello. Mic test. Hello, hello. Mic test. 1, 2, 3. Hello, hello. Check, check. Mic test. 1, 2, 3. Check, check. Mic test. Hello, hello. Check, check. Mic test. 1, 2, 3. Hello, hello.
Really correct.
Hello, hello. Check, check. Mic test. Hello, hello. Check, check. Mic test. 1, 2, 3. Hello, hello. Check, check. Mic test. 1, 2, 3. Hello, hello. Check, check.
Hello, 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 check, 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 check. Hello, 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 check, mic, check, 1, 2. Hello, hello, check, 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 check. Hello, hello. Hello, 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 check, check, 1, 2, 3, 4. Hello, hello. In question. Hello, hello, hello. ఇప్పుడు హలో 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 ఇది బాధ అవుతుంది హలో చెక్ 1, 2, 3 హలో 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 1, 2, 3, 4 మైక్ చెక్ 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 హలో 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 చెక్ 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 1, 2, 3 హలో 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 చెక్ 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 హలో హలో చెక్ చెక్ 1, 2, 3 మైక్ చెక్ 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 హలో 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 చెక్ హలో 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 చెక్ 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 మైక్ చెక్ 1, 2, 3, 4 హలో 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 చెక్ హలో 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 చెక్ 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 6 హలో హలో Hello, 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 check. Hello, hello, check, 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 check. Hello, hello, check, check, check. 1, 2, 3, 4. Mic check. Check one, check one. Hello, hello, check one, check one. Check, check, check. వస్తుందిగా మంచిగా ఉంది అది. Huh?
Sorry? Baby. ఇటు ఇక్కడ సరే అది పెట్టినా అవును నేను ఏదో ప్రాబ్లం లేదు ఫ్రీక్వెన్సీ చేంజ్ ఫ్రీక్వెన్సీ కాదు క్యాప్చర్ అయితే ఏం లేదని ఇచ్చిండా అన్నాడుగా ఇప్పుడు నీకు ప్రాబ్లం చూపించినా పట్టుకొని చూపిస్తా ఏది వస్తుంది అది కూడా వస్తుంది ఆన్ చేసి పెట్టినా hello 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 check 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 hello 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 mic nu మాట Hello, hello, check, check, mic test, 1, 2, 3. Hello, hello, check, check, mic test, 1, 2, 3. Hello, 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 check, check, mic test. Hello, hello, check, check, mic test, 1, 2, 3. Hello, hello, check, check, mic test, 1, 2. Other.
Check, check one. Check 1, 2. Check 1, 2. Check. Check. Check 1, 2. 3, 4.
ఈ మైక్ మళ్ళీ ఇక్కడే వస్తుంది. నేనేం చేయలేదు, ఇలా పెట్టినా. నువ్వు కట్ చేయాలి లూప్. ఆ, ఆ, ఆ.
Check. Check 1, 2. ఇప్పుడు పోయింది చూడు. చెక్ 1, 2, 3. ఇప్పుడు పోయింది కదా. టెస్ట్. టెస్ట్ 1, 2, 3.
అవట్లేదు.
టెస్ట్ 1, 2.
మాట్లాడు. నేను ఎవరు మాట్లాడినా?
కుమార్ అన్న, ఓకే.
నేను ఒక్కటి చెప్తా విను. ఆ మైక్ ఉందా, కెమెరా ఉందా? ఈ వీసీ సెషన్ ఒక్కసారి బంద్ చేయి. జస్ట్ కెమెరా మైక్ బంద్ చేయి. ఆ మైక్ బంద్ చేయి ఒకసారి. నువ్వు చేసుకో.
హలో చెక్ వస్తుందా మాట్లాడేది వస్తుందా? Check 1, 2.
హలో వస్తుందా? చెక్ చెక్
కెమెరాకి వస్తే అది పబ్లిక్ వ్యూ ఉంటుంది కదా, ఇట్లా డైరెక్ట్ రాదు. ఇళ్ళకెళ్ళి ఇచ్చిన
కానీ ఈయన మాట్లాడేది ఇట్లా ఈయన పడుతుంది. హలో చెక్ చెక్ 1 2
చెక్ హలో హలో చెక్ చెక్
ఇంకొక కార్డు లేదు అంటే
లేదు నేను తెలియదు ఆప్షన్ అదే నేను తెలియదు.
Hello, hello, check 666. 1, 2, 3, 4, mic check. Hello, hello.
ఇక్కడ నేను మాట్లాడేది కూడా వస్తుంది.
అందులో మైక్ ఆన్ అంటున్నది అందులో మరి ఎట్లా వస్తుంది నువ్వు మాట్లాడు
కెమెరా తీసుకుంటుంది.
ఇప్పుడు వస్తుంది. ఏ ఆడియో కూడా వస్తుంది
నేను మాట్లాడేది కూడా వస్తుంది నాకు.
నువ్వు మాట్లాడా ఏది మా ఆయన
వస్తుంది.
వస్తుందా ఓకే అని ఏం చెప్పినా పబ్లిక్ వస్తుందా చెప్పాలి కెమెరా దాకా ఏం చెప్పాడు నేను ఇచ్చిన సౌండ్ అది ఎట్లా వస్తుంది రెండు మాటలు
అది మాడతాను.
వీటంగా వచ్చేసాయి సౌండ్
హలో చెక్. ఇప్పుడు నీకు అది సౌండ్ వస్తుందో చూడు ఈ ల్యాప్టాప్.
ఇప్పుడు ఇప్పుడు పెట్టి అలా చూపెట్టా నువ్వు ఎట్లా పెట్టుకుంటే నేను ఎట్లా
ఒకసారి ఒక పని పెట్టు. నీకు సౌండ్ వస్తుందో చూడు ఫస్ట్. తక్కువ చేయాలి నేను. సౌండ్ సౌండ్ కొంచెం కూడా వస్తలేదు. సరే నేను తగ్గించిన. ఇంకానా?
హలో చెక్ చెక్. హలో 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 చెక్ చెక్ 1 2 3. అన్నీ ఉంచు స్పీకర్లో ఉంచు. హలో 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 చెక్ చెక్ చెక్. హలో హలో చెక్ చెక్ 1 2 3. మైక్ చెక్ చెక్. ఏ స్పీకర్ ఆన్ చేసినా ఎంత చూడు. హలో 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 చెక్ చెక్ 1 2 3. హలో హలో చెక్ 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 చెక్. హలో హలో 1 1 1 1 1 1 2 1 2. హలో హలో హలో. ఇది 2 దాంది మానిటర్. అది కాదు పైది చూస్తున్నావు కింది చూడు. ఇది హలో అక్కడ చూడ ఇన్న వాళ్ళు వస్తున్నా చూడ ఇನ್ನು స్పీకర్లో. హలో హలో చెక్ చెక్ 6 2. హలో 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 చెక్. Hello. Hello. Check. Check 1, 2, 3, 4. Mic check 1, 2.
Hello. Hello. Hanji. Yeah. So I just wanted to see, can I share my slides?
11, 11, 11, 11.
Okay. Okay.
Hello, sir. Can you hear me?
Yeah, I can hear.
Okay. We'll share you, and I mean, you can share the presentation from your side, right?
Oh,
Yeah,
yeah,
we can
yeah.
see your presentation. We can see.
It will work. No?
Done. It's clear. So 135 will connect you, sir. Before that, the moderator will be introduce you. Okay.
Yeah. So you can I keep my first slide on?
Yeah. Keep it on your first slide.
Yeah, I'll keep on first slide.
Yeah. And don't disconnect. We'll let you know directly.
Yeah, yeah.
Okay.
Okay.
Done, sir. Is it clear, right? Audio?
Yeah, yeah, yeah. I'm okay.
Okay. Right, sir.
Who is the moderator?
Uh, the details I don't know as of now.
Never
So I'll
mind.
let you know.
Never mind.
Okay, sir. Thank you.
Hello, sir.
Yes.
Sir, is it audible, sir?
Yeah, I can hear you.
Yes, sir.క్కడ display అవుతుందా? Sir, it is working fine, sir.
Good, good.
Thank you, sir. I will call you again. Yes.
Yeah,
Before.
I'll leave the slide and computer on. There should be no issue. Okay?
Okay, sir. Thank you, sir.
Yes. Yes. Now you can see.
Mic is coming, sir. Video is not coming, sir. Slides are coming. Yeah.
Yeah.
Yes, sir. Yes, sir.
Hello. Check, check. Mic check. Hello. Hello, sir. Is it audible, sir?
I can hear you.
Hello. Yes, sir. Yes, sir. Your voice is also audible, sir. Thank you, sir.
just ask Tejo because during the papers, all the halls are closed. No? Art papers. Art papers are still going on. You want to start?
I will just ask.
audience को साढ़े पर कलर क्या हुआ?
అలా కాదక్క ఒక ఇక్కడ వెనకప్పుడు ఆడియన్స్ ఇది ఒక ఆయన తెలుగు నుంచి ఇంట్రడక్షన్ ఆయన
నా ఏమైనా ఉంటుందేందా
ఏమో అన్న అన్నాడు అన్నాడంటే వచ్చేటట్టు కనబడతాడు ఇప్పుడు నేను బయటకు పోయి వచ్చినాక ఈ వాట్సాప్
ఇదేందన్నా ఎవరు అనేది నీవా నీవే అన్నా అన్నా
సౌండ్ పెట్టుకోండి నాకు ఏమవుతుంది ఏం చేస్తుంది
ఇది నైట్ ఎన్ని గంటలకు ఏడు ఉంది ఇది వరుణ్ బీచ్ ఏడు ఉంది ఇది ఇదేనా మ్యూజికల్ టు నైట్ సొమ్మన కూడా కూడా అన్న
ఒకసారి అది ఆన్ చేస్తారా? Hello, sir. Sir, because of passing talks in Hall B,
I know.
we are just waiting, sir. And in other hall, gold medal papers are going on. Once they are completed, then we can start, sir. Just
Sure.
5 minutes, sir.
Sure. Okay.
Thank you, sir. खत्म हो गया सर, खत्म हो गया, खत्म हो गया पर वहाँ यस सर, आई विल कॉल यू फर्स्ट. Hello everyone. So we are restarting sessions in our hall B. So next session is by Dr. Ashok Kumar Dirari sir. So capacity building in neonatology is simulation the future. To chair the session, I invite Dr. Ashish Jain sir. Sir is delivering this lecture via Zoom because of logistical issues. I request chairperson to introduce the speaker.
Good afternoon, everyone. I think Dr. Deorari sir doesn't need any introduction. Directly or indirectly, all of us here are his students at some time or the other, and he has been my very dear teacher and guided us. Sir is now currently a Pro Vice Chancellor, Swami Rama Himalayan University. He was former Dean cum Principal HIMS from 2022 to 24 at Jolly Grant Medical College, Dehradun. He's been President 2020 Secretary from 95 to 96, NNF India. We all know he's headed the Department of Pediatrics at WHO Collaborating Center and All India Institute of Medical Sciences, New Delhi. And he's the body member for the various aims like Kalyani, PGMR, Chandigarh. He was also chairman Simulation Center, and the Simulation Center at AIMS actually was initiated by him and grew loads. He was lead for the QI WHO CRO and chairman Unitajo Group for STW ISMR. So we all know these STWs are available, around 14 of them, and sir was chair for them, which is now guiding a lot of private practitioners and people who take care of newborns worldwide. He's member every woman, every newborn, everywhere, global initiative. And sir has chaired and been important member, a lot of committees in the ministries, the TAG committees, the GOI. And we all know about his passion. And more than that, we know that how he achieves his dreams and works towards it. We are very fortunate to have him here again today. Sir, we all welcome you. And over to you, sir.
Thank you. Thank you, Ashish, and everyone who is. What I'm going to do is I'm going to cover capacity building in neonatology, how we can take simulation-based teaching, learning, and education in training our healthcare professionals. It includes not only neonatologists, but the medical officers, the pediatrician, nurses, and everyone who is working, how simulation can be part of it. I remember 35 years ago, we all were trained by American Academy of Pediatrics in neonatal resuscitation program. And for another 10 to 12 years, we spread along with a lot of medical colleges and nursing colleges, teaching of undergraduate medical students, the practitioners in the art of neonatal advanced life support program, which is called as the NALS program or NRP program. And we know we used to use simulators and with the help of the task trainers, we were teaching in small groups. And the learners used to really enjoy the teaching learning, which used to be many times hands-on training to the participants and return demonstration and the feedback to the students. And subsequently, in the year 2000, we were able to show the impact of NRP program in 14 medical colleges by creating a network pre and post, which is published in Annals of Tropical Pediatrics, which showed that by training people in simulation-based NRP, we were able to reduce asphyxia-related mortality, and the better practices for doing bag and mask ventilation improved while the chest compression and use of medication decreased. So over the next 22 minutes, I am going to cover and explain the ways one can use simulation-based training for training the healthcare professionals, explain how simulation brings patient safety and quality in healthcare delivery, and then many of you who are researchers give you some idea for doing contextual research in healthcare using simulation. I see simulation as a methodology which adds value to the entire teaching learning process of the healthcare professionals. How this simulation will unfold over the years is dependent on the current generation of leaders in healthcare who will be the key players in determining which direction future of simulation-based education would be. David Gaba, who is in charge of the simulation center at Stanford, and he is the inventor of the human simulator. He said simulation is a methodology, it is not a technology to replace or amplify real experiences with guided experience to evoke or replicate substantial aspects of real world in an interactive manner. So David Gava is supposed to be a father of simulation-based teaching learning, which is getting spread with the new generation of healthcare professional. So simulation is a type of adaptive teaching learning methodology which involves pre-briefing, simulation scenarios followed by reflective debriefing in a psychological safe environment, not to blame or shame the students. It augments students' learning through simulation, recreating real life cases in artificial environment using mannequins and standardized patients. Simulation enhances students' confidence, improves the clinical competence, communication and critical thinking, and teamwork in clinic, and also leads to clinical leadership and much more. We all know Institute of Medicine in the year 2001 gave the definition of quality healthcare. It has to be patient-centric. It has to be a effective care with efficiency, with patient safety and timely care, with equity of healthcare. I am very sure many of these aspects of quality healthcare are addressed by incorporating simulation-based teaching learning for the healthcare professionals. And even those in service can use simulation-based teaching learning for improving the patient outcomes and the processes of outcome. We all know there is a model of quality in healthcare which is called as a Donabedian model that based on the structure and the processes, the outcome are delivered for the patient care. Donabedian, we know, is a physician and a founder of the study of quality healthcare and medical outcome in research. And this model shows that for the structure, like we do education and teaching learning for our healthcare professionals, for building skill and competency building is the process in which the simulation can play a great role. And by this, the output is going to improve, and then patient care is going to improve. So healthcare delivery is going to be better if we incorporate simulation-based teaching learning in our education of healthcare professionals. The advantages of simulations are multifold. It builds non-technical skills like the communication skill, the leadership skills, and efficient resource utilization. It improves the team dynamics, which can be practiced. once or more. One can practice interprofessional case scenarios while you want to do simulation-based teaching learning. Debriefing of the candidate regarding the learning experience can be done. The challenge in developing countries is lack of trained faculty members who are proficient in doing reflective debriefing following a case scenario which is run. We need faculty members who can nurture students' ability to think and be curious while they are doing simulation-based exercises in healthcare settings. Simulation-based learning needs willing faculty consultant time. That is most important. It needs planning of scenarios, so it needs extra time, which has to be given by the faculty and the people who want to run simulation-based teaching learning. One has to pilot test the scenarios, incorporate the feedback, and rerun. And then for undergraduate medical students and nursing students, we have to make this integrated into their curriculum. Ideally, ideal site for doing simulation exercise. Yes. Can you hear me? Ideal.
Yes, sir. Very well, sir.
Okay. So ideal site for doing simulation-based teaching is a room which is adjacent to a unit, an ICU or SNCUs, or a labor delivery room or a postnatal ward. These can also be practiced in a simulation center, which may be a central center in a particular institution. Now, I just give you example of how do you plan a simulation center for just doing a demonstration of kangaroo mother care. There is Miller's pyramid. According to that, we need to have first the knowledge about that, and then there has to be a demonstration, then a return demonstration and the constructive feedback, and then the individuals are able to perform that under supervision. So this is the Miller pyramids for the learning which in the educational methodology, and the same we do while we want to do a counseling or a teaching learning session for kangaroo mother care. We need to plan a lesson. We need to have a lesson plan. In the lesson plan, we need to have some information on how do you want to provide the knowledge, what type of equipment, supplies you are going to need, and how you are going to do a demonstration and a debriefing for that session. So you need to have a checklist for that, and then this has to be followed in the form of a pattern approach for developing psychomotor skills. The pattern approach is demonstration, then the deconstruction, then the comprehension, and then the performance which has to be done. So simulation is not always related to use of high cost mannequins or task trainers. It can be done in a situation which may be a postnatal ward or something which you want to do that in the form of groups for people. Creating a simulation scenario, it takes time, and while you want to run it, you have to create an environment which has to mimic the actual scenario. Maybe like a labor delivery room or an ICU, you need a team leader and a team, and you need supplies, low-cost models and supplies, and then proactive preparation for that. And as I said, it has to be done in a psychological safe environment where the participants are not ridiculed, judged, insulted by the faculty and peers, because that is the best way for learning for the younger generation. I am very happy to share with you that All India Institute of Medical Sciences, New Delhi, WHO Collaborating Center, only 6 weeks ago has released a simulation-based case scenarios, which are 18 in number, in the form of NeoSimSure neonatal simulation scenarios, which are applicable to SNCUs and NICUs. And these are pilot tested, feedback is incorporated in them, and these are freely available on WHOCC website. For running these scenarios, you need a champion, you need case scenarios for doing pre-brief and the brief and then debrief, and everything is captured in this booklet. Usually it is done in a small group or peer-to-peer. One needs to have a planning of that. You need supplies and mannequins for running these scenarios. So it is not only that in the SNCUs or NICUs you are going to run this. It can be used in a postnatal ward, in a package of World Health Organization, which is called as Essential Newborn Care Package 1 and 2, which are there in WHO website. If you look at that very carefully, it is basically a Helping Babies Breathe program and Essential Newborn Care program. There are simulation practice cards which are there, which are incorporated in the entire package of teaching learning which has to be done. And for any medical officer or a pediatrician, it is very easy to use these flip charts with the provider guide and simulation practice cards, which can be used very, very easily. And the new concept, which has been advocated, especially in low middle income group countries, is low dose, high frequency capacity building for doing resuscitation or even for making sure essential newborn care evidence-based guidelines get implemented. In low dose, high frequency capacity building, you do short focus sessions repeatedly and frequently, and it leads to significant improvement in skill retention and performance. And this has been done. And in a study in Tanzania, a study improved the resuscitation skill. Time for first ventilation reduced from 118 seconds to 101 seconds with limited impact on mortality, while an Ethiopian study reported reduced delivery room mortality from 3.5% to 1%. And as I said, already in the ENC package, which is there, it is these practice cards are there, and how the discussion has to happen together, peer to peer or in small group. You discuss together in the group what went well. Did you follow the action plan? The action plan is there in the ENC chart. If not, why? So these are the prompt questions which are there. ILCOR 2025 guidelines advocate use of low dose, high frequency capacity building for healthcare professionals for skill retention. It is there in 2025 guidelines. So expected outcomes of low dose, high frequency simulation training in newborn units is it improves the resuscitation performance, it reduces the skill decay among the healthcare professionals, because repeatedly on a fixed time in a week, maybe twice in a week for 10 or 15 minutes, you run the scenarios and do it repeatedly. There is potential reduction in neonatal mortality when combined with system improvement, health system improvement. So the recommendation are you need to do it weekly or bi-weekly, short intervals, simulation-based practice. Maybe you need a mannequin or a bag and mask for doing it if you want to teach bag and mask ventilation, and there has to be a place where this can be done. And the evaluation of that has to be, one can do some type of contextual research by skill retention, or clinical outcomes or compliance can be looked into, or one can judge pre and post evaluation, and the MCQs or OSCE or competencies can be checked if you want to evaluate whether that is working or not. I am so happy that National Neonatology Forum of India, along with WHOCC, already used a pre-term package which is endorsed by NNF and Indian National Association of Nurses. And we already did an e-course in 2020. It is all published for 4,600 nurses which were enrolled over the country and Southeast Asia region. And following this training, there is some degree of simulation-based teaching, learning, or evaluation and OSCE which were done. We know for teaching high skills like teaching healthcare professionals, uh, uh, teaching how to use ventilator on case-based scenarios, we have models which mimic a newborn baby or a preemie newborn baby which can be ventilated, which can show you the lung compliance changes, even the vital signs can be shown on the monitor. And these are high cost mannequins which cost more than crores to be bought by any institution. But we also have low cost lung simulators which can be used for teaching graphics with the help of ventilator monitor. Now the last part of my talk is on how do we take it forward and create evidence whether simulation-based teaching learning is actually helping or not. So we can use this model of Kirkpatrick evaluation model by judging the satisfaction and the learning and the impact, and then the results, which is return on investment. Satisfaction can be easily done using a Likert scale, which can be run by everyone. And then the learning can be by pre and post MCQs or OSCE or focus group discussion, so that you are using a mixed method approach rather than using only a Likert scale. So combining MCQs, OSCE, and focus group discussion, which makes mixed method approach, the chances of publication are going to be there if you are trying to evaluate simulation-based teaching learning. On the other hand, if you want to see the impact and if you are able to judge that and measure it in the form of change of behavior, practice, implementation, time to do a procedure, for example, compliance to hand hygiene, or time to intubation or failed intubation number of times, then it shows the impact. And then long-term impact in terms of mortality also can be recorded if you do it on progressive basis. So as I mentioned in the beginning, we published this way back in 2001, impact of education training of newborn resuscitation practice in 14 teaching hospitals in India. It showed a significant shift towards rational use of resuscitation practice and reduction in asphyxia-related mortality rate. Simulation-based education versus conventional training for initial steps in delivery room care of preterm babies, an open label randomized trial was published from AIMS New Delhi in Indian Pediatrics in 2022. It did not show much difference because the number of participants were only 14 and only one time simulation-based education was given to the participants. There is another one study which is under publication, which is on impact of teaching simulation-based teaching for crisis resource management, a prospective randomized study, pilot study, which is done among pediatric residents. And in this study, our primary objective was whether teaching CRM will improve the delivery of resuscitative measures in simulated environment. And the secondary was whether CRM will improve team leader performance and overall team performance using a Gibbs method of scaling. So recent years, we know that quality improvement is also coming in a big way for improving, making sure our evidence-based practices get applied at the places where they are needed. So it is important that we must combine the simulation along with the quality improvement methodology. Both the trainings have to go together, because the quality improvement methodology, if you integrate it, it tells you how you are able to measure the processes and the outcome, and then the impact of simulation. And then if we have to do simulation-based teaching learning, always remember we always work with the nurses and obstetricians together, So it has to be interprofessionals and interdisciplinary also. So I'm not going into what is quality improvement. We have a very simplified version of 4-step approach of quality improvement, which is called as the POKI model. If one can do this online, create a certificate for yourself. Step 1 is identifying the problem, forming a team, and writing an aim statement. Step 2 is analyzing and measuring quality of care. And the step 3 is PDSA cycles and then sustaining the improvement. So quality improvement methodology has to be part and parcel. And there are a lot of publications which are there in which simulation-based education is mixed with quality improvement to show reduction of central line infections. And in adults, there are many studies which have shown that one can reduce door to needle time in stroke thrombolysis through a protocol revision and simulation training, a quality improvement project, a Norwegian study. And then similarly for myocardial infarction patients with the ST elevation, you can reduce the time to intervention if you merge quality improvement and simulation-based teaching learning. There are various methods which are used for simulation-based education. One can use procedural simulators like the task trainers, part of mannequins designed for specific psychomotor skills and adult airway trainer. One can use computer-based simulators, e-simulation for case scenarios, and then patient simulators, which are full body simulator, can be programmed to respond to changes like SimMan and human patient. And recently, in recent year, virtual reality has come in a big way. And then one can simulate the environment using audio, visual, and tactile, and create virtual hospital and virtual operating theaters. So the time is now moving towards virtual reality, augmented reality, and mixed reality. At our institution, which is Himalayan Institute of Medical Sciences, which is a constituent part of Swami Rama Himalayan University, we are very happy to install for our training of our MBBS students and even the nursing healthcare professionals, a AR, VR mixed reality lab. Currently, we have 6 stations on which the undergraduate medical students, while they are in second year, third year, and final year, are exposed to learning procedures. And here is one of the procedures. They are learning how to insert copper T in a woman for family planning. So there are nearly 75 modules which are tailor-made for the UG medical students and nursing students. So we are using currently this, and whether this is going to be cost effective or not, currently we are running a ongoing 3-arm randomized control trial on the students, trying to compare AR, VR with the normal task trainers and students who are getting exposed to both. So the trial is registered and is being run. So my key messages at the end are simulation-based teaching learning adds value for healthcare professionals training at all levels. It does not replace what all of us are doing, which is like a bedside teaching, which has to be done for healthcare professionals, the future generation of students. It is add-on value. And we need to customize and test newer methods of simulation for their cost effectiveness, because many of these simulators are very, very costly. And as I showed you, that it is not only high cost simulators one need to have, one can innovate and do frugal innovations and create simulation scenarios using low cost methods. And the third message is quality improvement has to be part of simulation-based teaching learning. We must use this approach, which is called as a SQUIT approach, which is named by Ames group, and that will lead to publication in journals. Fourth is evidence exists that it enhances quality and safety in healthcare. There is no doubt simulation is going to be the way forward. and I can see that golden hour management, which has to be done by our healthcare professionals as a team, doctor, nurses team, who are providing care in the labor delivery room or operation theaters, can be one area in which you can have simulation-based teaching learning along with the quality improvement methodology. So we need to do more research, and the research findings need to be shared, and they should be in public domain so that if someone has made a mistake of buying high cost investment, the others should not fall in that trap. So unless we do more research, we will not be able to educate our own people. And my only request to many of you who are sitting here, younger people, is to innovate and think what can be made in India for India, so that you are able to reduce the import cost and the cost which the Indian government has to pay for importing high cost simulators, and even for AR, VR and mixed reality. Many of us has to create all those things, innovate it, make in India, so that for vast majority of the people, they are available at low cost. Thank you so much. Thank you, Ashish. And I see with you is Ashok Kumar sitting, or?
Yes, sir. It's my equal pleasure to introduce our esteemed co-chairperson, Dr. Ashok Kumar, who has joined us a little later, but very much to our fortune. A name that commands deep respect in the field. Sir brings decades of distinguished experience as clinician, academician, and mentor. And over to you, sir, for your wisdom and insights on this.
Thank you very much, Professor Deorari, for dealing with this topic. Simulation is the way forward, as you have mentioned, and you are a pioneer in, putting forward this idea and implementing it at AIMS, and then spreading this message to all over India. One of the important things with the simulation is, see, nowadays, the people are very conscious that when they visit any hospital, and if the medical professionals, health workers have to perform any procedure, the procedure should be safe. So naturally, the trainers, the students cannot directly perform the procedures. They have to be first trained. And the simulation is the way forward to train them. One of the important advantages of simulation is they can repeat the procedure repeatedly. One of the important prerequisites for simulation is we need a dedicated faculty, or what I call the little champions, who are motivated, who inspire, and who really nurture young minds. If the peoples are very much authoritative in their nature, judgmental, then the whole purpose of simulation will be defeated. So when the students or the learners or the professionals, be it nurses, medical officers, or pediatricians, are making mistakes, they have to repeat the procedure until they reach a level which is deemed to be satisfactory. So thank you very much for enlightening us on this very, very important topic. And I wish there was more audience, people would have benefited from your this deliberation. But as the things are, this was a post-lunch session, and the post-lunch sessions are usually very difficult, but you have engaged the audience very much. So thank you very much. Thank you.
Thank you so much. Thank you.
Maybe we can take one or two questions. Sir, there are no questions. But sir, I have one question. Yeah.
Yeah. Okay. Yeah, it's working. Namaskar, sir. Sunil Monga here. I have this question that in our country, we still have a huge variation in terms of the skill that is available at each individual. It's very, very subjective. So simulation definitely offers a huge advantage to bring up these people to a similar and same level. So are we talking in terms of a skill level indexation, which should be the minimum standard before any student or any doctor or nurse staff is allowed to perform an operation or work on the patient. That I thought would be a very important thought to deliberate.
So, thank you, Sunil, for your important question. So, as far as I know, at this point of time, there is no regulation for that. But I know this, NMC has in mind introducing next exit examination, which is going to be for MBBS students who are going to come to the field. And in the next exit examination, there is a part in which skill and simulation is going to be tested on each and every medical graduate. Whether that will translate into whether they will practice or not is a different. And it has to be done by like regulatory body so as to get this implemented as a policy guideline for each and every healthcare professional. But I know in surgery, if someone wants to learn knee replacement surgery or any other type of surgery, there are simulation based techniques in which you can practice it, re-practices, so that you are able to refine your skill. And the learning curve for those doctors for providing safe surgical surgeries is much less as compared to a person who is not exposed to learning on a simulation based AR VR environment.
Thank you, sir.
Sir, it was very amazing to see that last slide. It looked like a space lab with the students working on the AR machines. So does the AR machine also tell them, because here nobody is monitoring them, so how do they know that, they have...
Okay, so the AR VR lab which we have, it has two methods. One is the learning mode. In the learning mode, it will teach you in a stepwise manner while you are interacting with the patient what are the steps and how you do the procedure. You take a consent, you talk, and you pick up equipment stepwise. And the second is it will ask you, you want to do it on your own if you know it, so you practice it. And then you practice it, you will make a mistake. It will give you at the end a feedback that you scored 80 out of 100 and these were the steps which are missed by you. Okay. The student can re-practice once again because he knows now these are the steps he or she missed and he or she can practice again and again. Okay. Ashish, I hope.
Yes, sir. I mean, model can work without an observer.
Yeah.
Thank you.
Thank you, sir. Thanks a lot for the nice discussion on simulation.
Thank you so much. Thank
It
you.
is great you come here, sir. But thanks a lot, sir. And I request Dr. Seshgiri sir to facilitate the chairpersons. For the next talk, I invite Dr. Rahul J. Verma, sir. So this is a panel discussion on choosing the right equipment, insights from the clinical and industry leads. For this panel, I invite the panelists Dr. Om Prakash Manohar Jamadar, Dr. V. Shashikumar, Dr. Umesh Sangle, Dr. Sunil Monga. So Dr. Rahul sir is Director of Pediatric Sciences, Director of Academic and Research, Head of Integration of Mother and Child Health. He is affiliated currently to Dr. H.M. Reliance Foundation Hospital and Research Center. He is Star Alumnus at Symbiosis International University. He is President Neonatology Forum Mumbai and National Trainer of Advanced NRP. Some papers and presentations to his credit. Thank you, sir. And I request Rahul sir to introduce the panelists.
Afternoon, everyone. No. Now can you hear me? Oh, thank you very much. I'm on Twitter over there. Thank you. So, yeah, can we, let's go to the presentation. I've got the introduction over there. Cut short, we are half an hour late. So let's see if we can save some time and some yawns. Thank you very much. So I would, at the outset, introduce my panel. So I have Dr. Om Prakash Jamadar over there, who's a neonatologist and he's a consultant at Apollo Hospital, Navi Mumbai. Then I have Mr. V. Sasikumar, who's the founder and the managing director of Phoenix Medical Systems. I have a young Umesh Sangle, who is done some work with IIT, and he's the co-founder and director of a new firm called Nuvia Tech Devices. I have Mr. Sunil Monga, who's the CEO and co-founder of Bird Meditech. And I have an Indigo victim who is not reached over here, Dr. Poonam Singh from Rishikesh, I believe. So we will manage with our 4 panelists over here. Thank you very much. And thanks to NNF for allowing us to interact. How many clinicians over here? No. I wouldn't believe that. How many clinicians over here? See, that's only 4 hands, you know. Anyway, just checking to see if you're away. So the idea is not to tell anyone which equipment to buy. Rather, I think we should go through a process of assessing the requirements, how we manage the equipment, what are the difficulties, and the difficulties are not just from the clinician point of view. The difficulties are also from the manufacturing, from the AMC point of view, and we'll try to see if we can touch a few before time gives us up. So I'll start off with the queries. And my first question would be to Om Prakash. How do you understand the real world needs of a high acuity tertiary NICU, state of the art, in a busy metropolitan corporate hospital? Results are very, very important, versus a busy, very busy special care baby unit in either a district hospital or in a tier 2 city. How would you think the needs would change?
Thank you, Dr. Rahul and organizing team for allowing us to be here. So all of you are familiar with this word PPE. COVID has given this word PPE, personal protective equipments. So this is very important in terms of understanding equipments. P is your place of work. That is very important. Where you are working, whether it is a level 3 referral unit or a metro city hospitals or a tier 2 or level 2 units where you are getting a primary care of patients. Because the place has got different facilities. You have got a high-end facilities, your temperature is controlled, the supply of electricity is very well controlled. You can think of using high-end equipments. And second piece, your personal. This is very important before you go to the equipments. The person who is going to manage the situations, whether they are trained enough to manage extremely preterm babies, high-end situations where there's a need of inhaled nitric oxide or high frequency ventilation. So personal is very important. The staff is also part of it, where we need to make sure the staff are adequately trained to use the equipments. And then comes your equipments. The equipment is not the first thing. You need to know the place, you need to know the person who are going to manage, and the kind of work that you are going to get. And then in the equipments, it's not just your equipments in the NICU which are required for managing the babies. We need to think of equipments which are required for preventing the problems, like a laminar flow, which is essential for preventing sepsis. You need to prepare fluids under the laminar flow. That is also part of the equipments. Equipments which are required for diagnosis purpose, like the bedside ultrasound, bedside 2D echo. They are also equally important, provided the person who is trained to do the things bedside. Then only that equipment is valuable for you. And then the equipments which are required for therapeutics. So from therapeutic point of view, all of you are familiar with. So let's compare the level 3 units, and we are there in the metro cities where there are teaching medical colleges are there, and level 2 units or maybe like the primary referral centers are there. So there, if you consider a ventilation, for a high-end units, you require conventional high frequency ventilation as well as a nitric oxide. For a smaller setup, the basic ventilation. Along with that, what is most important in that place is availability of a non-invasive ventilation. That is most important. From ventilator, then we go to the incubators and warmers. So warmers are required at all places. Incubators are also good, but again, in a smaller places where the fluctuations are, a lot of fluctuations are there, the maintenance is difficult. So incubators are difficult to manage. And then rest of the equipments, if you look, as simple as a syringe pump or effusion pump, sometimes it is difficult to get an appropriate size of syringes at the places where there are, lack of facilities are there. So all these factors are very important.
Prakash, if I could just interrupt, because we have many other questions to go for. Basically, to sum it up, an advanced NICU looks for high precision and advanced modes in their equipment, while the busy special care nursing units, neonatal units, they operate in very indecisive and labile environment. So stability is a very important thing, and quality may have to step back and be replaced by stability and what we call as an after sales support, isn't it? More or less. Right. Coming to the next query, and this I would pass on to Shashi. Has the equipment industry attempted to present a comprehensive equipment list for an NICU? So do we have, today we are talking 25 years from the last time Dr. Deorari has actually released his book on neonatal equipment. Do we have a standard set? Do we have a standard procedure? Do we have a standard AMC available to us as a comprehensive package to be offered to each neonatal unit? And if not, how practical would it be now?
Yeah, thank you, Dr. Rahul. I mean, and the organizers, Dr. Rahul has taken a lot of pain in putting all the questions together. Thanks a lot for that. Yeah, I mean, in terms of list of devices, what is required, Dr. Derari did create some, device list and equipment book and so on. But unfortunately, that has not gone through. I mean, today, every hospital has their own way of buying. And I would even say that you can have, small hospitals to a large institution to a government hospital. Each one decide their own way. Government hospitals, unfortunately, it's driven by the state governments. They own their own way of purchases. Recently, which is very good, the government has come up, they are putting up a tender. We're not only asking for the price of the product, but they're also asking for AMC after the warranty for 8 years, which is very good. But it's not been practiced well. That's what I would put it. I mean, it's not put into practice well.
Right. So we do believe there's a gap in this.
Absolutely a gap.
As to what we would like to have, what is available and what is asked for.
Yeah. And as I would even add saying that, we have a lot of experience as an industry, we can also come up with what solutions are possible for a hospital.
Sure. Thank you.
Maybe this is a good, time to collaborate with NNF and bring up such a toolkit.
I believe a movement was initiated sometime back pre-COVID, whereby we were to have a cell which was to compromise. It got compromised, but comprise of clinicians as well as the manufacturing people. And maybe that can be rejuvenated to bring about a common platform to be able to at least recommend a basic set of equipment, which will not only have a one-time cost, but also the recurring cost of management over at least the next 5 years. Because we believe that the cost of any equipment should be spread over at least 5 to 7 years before the newer equipment takes over.
We should resuscitate that initiative.
Sure. We have, I don't know if you have anyone from NNF, but I'm sure someone will do that. It's been promised, I assure you. Right, coming to the next question for clinicians, that is, when would you decide, Om Prakash, on a new neonatal device, and what are your top 3 decision criteria? How do you decide what would you want in that particular equipment, and how would these priorities differ across the levels of care?
So what is your need that is most important? If you are setting a new NICU, you want all varieties of equipments, particularly you care the vicinity, what is not available, you want that thing. But if you have got already set NICUs there, where it's a small setup or big setup, we want what are the patients that I need to manage further in terms of improving their quality of care. So these two factors are important. Then comes what are the options available, particularly options which are cost effective, not just the upfront cost of purchase, but the cost of maintenance in terms of available facilities, service engineers. All these factors make a lot of important, and your peer experiences, particularly the experience of getting proper services. All these factors decide what I'm going to purchase when I'm looking at the new equipment.
Great. So basically, to sum it up, we want the equipment to be reliable, whatever we are requesting for as the need for the hour. It should be serviceable. Many of the times we pick up foreign equipment only to find that we do not have a backup service. We need a great after sales service. And I think that is something which all of us should now focus upon, not just the equipment, but the availability of a good after sales service. And maybe we should start deviating away from the concept of the lowest bidder being the winner in this, and look at an overall cost of ownership, and more importantly, cost of life. I think it doesn't depend only on just the cost of the machine, but we also need to correlate it with the cost of life in the NICU. So these are some of the points which we look as priorities. Right. Mr. Monga, many NICUs in India now use locally manufactured equipment like warmers, phototherapy, but still import high-end respiratory support like CPAPs, ventilators, and even life-saving supports like incubators. So what safety or performance gaps would prevent a shift from the Indian manufacturer as a continuance and avoid shift moving on to the foreign help?
See, the most important thing that the doctor wants is that can he leave the baby alone with the equipment? And obviously, that means is it performing to deliver what it was set? For example, we've had in ventilators, you set a certain tidal volume and it is not delivering that consistently breath after breath. It keeps changing. And you can have issues like, buildup of retention volume or buildup of EtCO2. So those are the factors which are very critical, which for the high-end equipment, people are not able to rely on. These are life-saving equipment, and that's why the shift from imported to Indian equipment is not happening. But why is it not happening? Why is it that Indian manufacturers are not able to come up to this level? So essentially, there are a few factors like we don't have sufficient investment in R&D. We don't have sufficient support coming in from the government. We don't have the kind of raw material that is required to play with. We don't have the technologies that are required. And most important is, two things. There has to be an ecosystem where a complete continuing from raw material to technology to support systems. And the last thing what we find is that the volumes that we address, for example, I want to buy a component. If I buy it directly from the factory, I have to buy some 10,000 pieces. And in medical equipment, 10,000 ventilators is going to be something which I want,
Sure.
be able to think of.
Why do you say the government will not support us? Because now, at least on television, most of us hear a lot of incentives towards Make in India. A lot of promises are done. So are they not being kept? Are we not in a position to exploit the best out of that?
There is a huge gap between the intent and the delivery. Yesterday, here, there was a good thing I saw for the first time. What they've probably tried to copy the China model is that they gave land at 1 rupee per acre to 6 large companies to build up huge setups. And if you go to China and you look at the industries, here we typically talk in terms of an industry which is 10,000 square feet or 30,000 square feet. There, any industry that you look at would be like in lakhs of square feet.
Right.
So the kind of infrastructure that is required, so they give zero interest finance, almost free land, and access to technical know-how. So you
Sure.
can indent know-how from anywhere in the world.
Sunil and Sashi, you all are experienced people. Let's go to Umesh, who is just starting off his career. And do you agree with what was said, or do you find things are different? Because you have just started off your R&D and now culminating into manufacture.
So yeah, there are some modifications or improvements we did that standard for design where we understand standard requirement because standard relies on the patient directly relates to safety. Lab and the testing facilities are currently fragmented. For a single device, you have to visit to multiple facilities to test the same device, the multiple scenarios. That takes time. That product development cycle, that delay is real.
So we do have a long wait in a way if we go to see.
Yes.
Right. Okay, Sashi, we'll come back to you. What are the most common perceptions or biases, justified or outdated, about Indian-made equipment? You've been there now for almost 3 decades?
Yeah, 3 decades.
Yes.
Yeah, I mean, one thing very clearly is every time we say that Indian medical devices are not robust, definitely they say that. And of course, less with features. I don't think that's the truth today. I mean, we, as a company, we have around 60, 70,000 warmers in the market today, approximately 30,000 to more than 30,000 phototherapies in the market today. I mean, it cannot happen that way. And I would even say that Dr. Bhutani, in his one of the recent publications, he has said that the company, he's named the company too, saying that we really work towards the company with Brilliance Phototherapy. We were able to bring down the neonatal mortality due to connectors from between 2014 to 2019 really down, and we can attribute it to the product innovation what Phoenix and Stanford University together created. So it's not. I mean, it's. I would say it's just a perception which, unfortunately, in India we all have, because we've always believed that Indian devices are not great, and that's what I would definitely say. And of course, I mean, as a company, we have got enrolled into UNICEF, WHO. It can't happen without any of these things. So it's just, I would say, perception. Yeah.
So can I just add on a question at a personal level?
Yeah.
So your phototherapy units is what you were mentioning, isn't it? So do you all also manufacture the LEDs of the phototherapy unit?
No. That's coming from internationally. I mean, chip manufacturing is absolutely missing in India. That's just not for the medical industry. It's across the every industry. We're all suffering with that. Yeah.
So basic material is a challenge. You still need to assemble. You have the ability to assemble.
Yes.
However, production at a smaller level, at a minute level of each component is a challenge as of today.
Absolutely.
And I think that's very important, because that's the message we need to pass on.
Yes.
That we need to go much more into basic requirements and then sophistication, rather than going into sophistication and
yes.
then deciding.
So one thing what the government has done is to bring the duties down so that you are on par in terms of when you're getting the devices. I mean, the electronics is at 0% customs duty today. So we're not, I mean, so it's sort of okay. But then, whenever you have a gate, you know what happens.
Sure.
Yeah.
Okay. Carrying on with you only, Sashi, sorry. How should clinicians assess quality and safety beyond basic, certifications? For example, CDCO certification, CE certification. Is there something which we as clinicians should be knowing about and should be actually deciding, rather than just believing the word of the manufacturer, or more importantly, the dealer who sells the machine?
Yeah, I mean, quality systems is very, very important. Good that, the IMDR, Indian Medical Regulatory Act, which has been brought in by Government of India, it's a good step. But I mean, all the medical devices doesn't have any standard at the moment. They're saying that if you have an international standard, you just, get it registered into India too. But that's very, very important, because you as a consumer do not have any facility to check whether this equipment is working well or not. So there's an independent agency which does an audit on your premises where the manufacturing is going on. Also, they do provide a certification based on the device. So every device, as for the international safety standards, IEC is what we call it as. Just the electrical safety is one point, and then you have also the device safety for every device. So this is very important. Every device has got its own safety standards. To give an example, as for the IEC international standard, any surface you touch on a device should not be more than 40 degrees. This is tested. You run the device for days as a steady state, and check if there is any part of the equipment which can go more than 40 degrees centigrade. And also, for example, a pinch. none of the devices should pitch anything. I mean, this one incident, I mean, so many incidents where the baby's hand was on the side of the incubator, you close it, and then, so those are things which are very critical, and that's taken care by the certifying agency already. Yeah.
Can I throw one question at the audience out of curiosity? How many actually have an annual calibration certificate for the various equipment that you all use in the NICU? 3 out of at least 60, 4 out of 60, not too bad. So I think the onus of assessing onset and continuance of efficacy of the equipment also lies on the clinician and not on just the biomedical department or the manufacturer. And I think that is something all of us should be looking into as to how often should our machines require calibrations, the POCTs that we use, the sonography machines that we use, the X-ray machines that we use. I believe all of them require a calibration point on a specific time interval.
I think I'd add here saying that there is no compulsion for any hospital today because everything, I mean, electronics drifts. There's no compulsion today to calibrate and make sure the products are giving. I mean, you have a lot of blood gas analyzers.
Yes.
None of them are calibrated and kept in, right order.
Unfortunately, the only people who enforce the calibration is when you go for accreditation.
Exactly.
So NABH, JCI, AACI, you name it. Those are the ones who will compel you. But yes, the requirement from within, without a carrot and a stick attitude, unfortunately doesn't manifest with us. Sunil, how should clinicians currently assess quality and safety beyond the basic approvals? Continuing that previous question.
Yeah, so it's important to understand what class does the product lie in. So as per the CE or the European standards, they call it class 1, class 2, class 3. So class 3 are the IVD products which go inside the body. Class 2A are the ones which are associated with electrical safety. And class 1 is which is maybe non-contact or it does not go inside the body. So based on the classification, the standards will vary. Class 1 devices can be self-certified. So if you have, the manufacturer has the testing equipment in-house or he uses an external facility to get them tested, he can self-certify. But when it comes to class 2, which are electrical like radiant heat warmers, phototherapy, these would require a third-party accreditation of the standards that are required for that equipment as per the IEC protocols. Now, these can be electrical safety protocols, it can be EMC protocols, that means electromagnetic radiation or electrostatic discharge. So if I touch the equipment, I shouldn't get a static discharge. So all these things need to be certified by a third party, which is a notified lab. It is not any lab. Unfortunately, the thought process or the need in this country at the end of the buyer is not configured to ask for these certifications. Now, IMDR necessitates, mandates that no manufacturer can sell their equipment as of 2023, September, that was the last date. They gave 3 years for onboarding. So, but I see that nobody, including government, asks for licenses before they procure the equipment. Even in the CDSCO, which has given the list of licenses to be given. For radiant heat warmers, they have 4 categories, and including a class B category, which is class 1, which they can self-certify. Now, radiant heat warmer, it goes into self-certification. How do you compare it? You are working on the L1 principle. How do you compare it with a class C product, which has gone through third-party certification? EMC and electromagnetic radiation, you need very costly components to cut down the radiation, which could affect the performance of other equipment in the NICU, or it could get affected by this. If you do not put those components, like 5,000 to 6,000 rupees is the cost of that component. Now, a radiant heat warmer, which is unfortunately selling like dal bhaji nowadays at 20,000 rupees, and people are buying them. That's the very unfortunate part. So
that's all thanks to the L1 situation, I'm assuming.
Not just in government, even in private.
Okay. We'll come to the L1 thing. Let's see how it works. Umesh.
Yeah, I would like to continue with Sashi sir's message that imports are being easy right now in India. But scenario is that for the devices like respiratory monitor, the critical devices, 70 to 80% electronic components are imported. And it's a crucial part where the minor change in supply chain, like demolishes the predicate testings. So if you change a single component, you have to retest it. Then the current testing facility, as Munga sir suggested, NABL accredited labs are there. Very few labs are there, but they are fragmented. Like if I have to, like if I take an example of a phototherapy device, if I have to do a ISO 1348, ISO 10993, the biocompatibility test for the material, if supplier agrees and suggests me that it's a biocompatible grade material, but even I have to make sure that I have to go to the lab. There is very few labs in the Delhi and the South India who do the enable accredited testing.
So you need independent validating labs.
Yes, but they are fragmented, not a single system or the community where I can send a device and do all the testing at a time. So that delay goes on increasing, and that's a problem here in the getting the compliance clearance.
Right. So one of your systems you showed me was a Billy blanket, isn't it?
Yes, it's a portable
Yeah.
phototherapy.
The thing was that the connecting wire,
Yeah,
which connects the blanket to your monitor,
right.
is imported.
It's imported.
So why, once again, I'm thinking of repeating that, why are simple things also getting imported? And I suspect the answer you would give is because it's more economical.
More economical, but more reliable as well. Indian
Reliability is a big factor,
yes,
isn't it? And we'll come to that.
because we should not like ignore the standards.
Sure.
Yeah, patient safety.
Okay, so what concrete mechanisms should be built into procurement to protect patient safety? So this is not the hospital, not the doctor, but we are actually talking about actual patient safety. So what are the measures that as a manufacturer would advise to us clinicians to ensure safety of the patient?
Yeah, one very important thing is to get the safety certification from a accredited lab. That's very, very important. That said, now the equipment also needs to be, it's not that, once you buy, it'll work forever. So some sort of, service level agreements should be there in place. Yes, but I would even say, the way in which we have seen some of the hospitals, for example, they won't even have switched on, and they're saying that the equipment is not working, and you all the way go and just switch on the product. So which clearly indicates there should be some mechanism, maybe a remote, diagnostic kind of a way in which the equipment calls the hospital and tells what is happening. And I would definitely appreciate some of the governments, which are Tamil Nadu government, for example. What they have done is they have, this is what my engineering guys, service engineering team was telling. What they're done is they have a portal on which the hospital will, upload if there is a product failure, and the TAT, that is turnaround time, is monitored. And if you don't do it in a particular span of time, you're punished. So, or your your AMC, everything is gone. So this is one very good thing. I think monitoring is a very important function here. And I think as a hospital groups have to take up the monitoring as a very important.
Real-time monitoring would definitely help. And
Yes.
it's possible. Real-time
It is
monitoring
possible.
is possible.
Yes.
Sunil, you want to add anything?
Real-time monitoring may be a little bit of a challenge because it requires a real-time registry. But as we move towards equipment which are connected to the net, then it becomes much easier. But till that time, it's very important to understand that they should have very clear SLA, service level agreements, which clearly define not only the uptime but also the mean time to resolution. And if that should be like within 72 hours, and if that is not being met, then it's very important that a replacement should be available. And these need to be documented, these need to be monitored so that there is a basic level of service that is being provided, for the lifetime of the equipment.
Challenge would be in keeping a second component, second part, or a second machine available at every place of installation, or at least in that town or city. That would mean a lot of distribution.
It becomes very easy if, I'll tell you, I have like Shashi was saying here, 60, 70,000 warmers. Similarly, I have around 50,000 warmers. But the problem is, especially from the private sector, I have only 10 AMCs out of 50,000.
Yeah.
People don't want to go for an AMC, number one. Number two, they are very happy to replace with not original equipment manufactured components. They will buy substitutes, and that is where the costing. Because
Right.
ultimately, for us also, it's much more economical when you have numbers. So for hospitals like Safdarjung, Kalavati, Saran, where I have good volumes, one person is posted there on a constant throughout the year. I mean, 24 by 7.
So basically, if I spend 100 rupees, if I reserve 100 rupees for an equipment, 50 rupees should go actually into the cost, around 25 to 30 rupees in the AMC, and the remaining should be for the replacement of parts which are payable. Am I right or wrong?
That's a very important point you touched here. Most of the government agencies will have a clear budget for capital, but when it comes to maintenance, there's no budget. They
So
really need to
CapEx,
create a budget.
CapEx exists, OpEx does not.
Yes.
Right. Okay. What design features are non-negotiable as far as the SNCUs are concerned, where they are hard-working horses, where it's difficult to access, where it takes a much longer time for an engineer to reach? There should be something which you cannot trade off at all. What would you believe that to be?
India is the best lab in the world if you have to have equipment that work. And the first lesson we learn here is that nothing can be taken for granted. Now, whether it is your power line conditions, so in the design, most of the equipment are built for 230 volt plus minus 10. We have to go 230 volt plus minus 20. Now, nowhere in the world you have frequency variations. Here we talk about 50 hertz, but frequency variations are also observed. So we need to make sure that our equipment can take care of those. Then we have huge variations in the environmental conditions. So the temperature conditions vary, the humidity levels vary, we have dust. So the equipment needs to be designed so that it doesn't allow ingress of dust. It doesn't have sharp corners. It essentially the sub-assemblies are IP rated so that even if there are spillages, they are taken care of. And if there are cooling fans, preferably have fanless designs, but if there are cooling fans, then they should be sealed fans. From the point of view of modularity, serviceability, it would be very good that you have modular sub-assemblies, which, even a basic 10th pass student or mechanic can go and open the device, pull out that sub-assembly and replace it. So local replaceable unit, LRUs, it should be based on that. And in that entire design, it's very important that at no point of time we should forget at the international level of safety. For example, is there a leakage current? Because for a newborn with a sensor, 15 microamperes would be the leakage current limit. So those are, as per the IAC protocols, the device must meet those standards. And there are two more things. There is performance integrity. That means, does it perform to what you have set? If I've set 35 degrees centigrade, does it maintain 35 degrees centigrade plus minus 0.2 degrees? Or there are variabilities, and like that for all other parameters. The phototherapy, is it delivering the flux that it was? And obviously, important is that the procurement methodology also needs to take this into context so that the safeguards are there in the procurement.
Right.
Make sure that the lifetime of the equipment,
Sure.
it is performing as per day one.
Right. Coming to a question, I think, to all three technical people. So you get technical specifications from the government, from the state, from the institute. So do you think these specs are what is the requirement, or would you believe that something else needs to be sorted out?
Yeah, so generally the technical spec is given, if at all, mostly by the governments. Private institutions have their own way of buying. They have a procurement department, they have a biomedical department, and so on. They're very tight, actually speaking. The private hospitals, corporates are very tight in terms of understanding what are the product, what way they want. They have an experience, they need the latest, and so on. When it comes to the government, it's a state government which decides. Even though NHSRC from Delhi did some work to see that there's a standardization of certain essential equipment across India, but that didn't work. And therefore, the state government sort of gets into the act of giving the specifications. And I'm sure that every state has got its own preferences, and that's what it is. But if you look at it long back, we had this NNF coming up with a specification for a warmer for the resuscitation corner, and was thrown to all the industries to do, get a device which is appropriate. And all the companies came up with a device, and everyone was given a purchase order. It's not that a bias was created on a specification, and therefore it's one guy wins everything. That's a kind of work which has to be done in India, and that's what is getting done in China, and that's why they're successful.
And I think clinically, what's important is that it's not the best, but it is what is the requirement for a unit which matters a lot. I think today we are looking towards more CPAP systems. We are looking at blenders rather than looking at high-end ventilators, which used to be the requirement, whether justified or not, maybe 10 years back. So I think that is something which is very important to look at. Om Prakash, when considering the overall cost of ownership, how do Indian products compare?
So Indian products are getting quite good nowadays. I always ask, like, how many of you thought of buying a Mahindra or Tata cars earlier, But nowadays, 10 years down the line, you can see the quality of products in all aspects. Same is for the neonatal equipments. As he said, like 70 to 80% warmers are of India made. And that is what in our NICU also. But unfortunately, what is lacking is like ongoing maintenance and care. That is the reason we tend to go to the Western made, particularly when there is a fineness which is required. Software side involved, like a ventilator requiring high frequency ventilator, very low tidal volume. In that situation, we still more depend on the Western rather than the Indian made situations.
Thank you. Cost of ownership is, we've already discussed that, but I would emphasize again that it is not just buying the machine. It's not the capital expenditure, it's the operating expenditure, maintenance, and the outcome from the machine in the form of saving lives, which should be taken into account. Umesh, how can hospital industry partnerships be structured to generate robust data? Everything runs on data. We had a couple of lectures on AI, it was on data. So how would we make that?
Like hospital industry partnership is a must because the real-time data and the actual scenarios will get validated there. Validation is an important thing. But the thing is that real-time feedback loop, that the rapid feedback loop is essential. If industry is deploying 3 to 4 devices for the pilot testing, then that should be true feedback. They should not hesitate to give the bad feedbacks. It should be a real time and the rapid feedback so that they can improve and they can implement the devices. Devices should be made according to the need of the clinicians, not as per the need of the industry. So yeah, that's important.
So local R&D and validation is very important, not just use.
Yes.
Right. We'll give that a miss. I have only a minute more, so I will apologize. Okay, important question. Top 2 or 3 reasons why many of the medical devices now become the heaviest and most expensive paperweights in our unit.
Lack of the maintenance. I always tell that when you are purchasing a new equipment, you should take a CMC because you can negotiate at the time of purchase. But once the product is sold out, then they will not entertain much. So maintenance is the most important factor. That is the reason they are there in the graveyard. And in government system, many times they look at the lowest bidder, whatever is cheaper that you get and which may not be appropriate for you. So that is the second commonest situation that the graveyards is building heavily in neonatal ICUs.
Right. So small part failure, service logistics, and lack of AMCs. Once again, emphasizing on AMCs as part of the component of buying new equipment. What scalable service models can help prevent equipment from being neglected or abandoned, especially in the smaller SNCUs and in tier 2 cities where a full-time service person is not available?
Yeah. Yeah. So definitely, I mean, this is one thing which I just told, I mean, a while back. Monitoring is a very important exercise. How do we monitor? I mean, it should be as what we said, a portal. Portal is created, that hospital portal is created, and that hospital, wherever an equipment is going wrong, they put it up, and the hospital, the company also is in the same portal. So what happens is you will at least know the turnaround time, and you can sort of understand, measure, and say that you can improve here and so on. Of course, you'll have to have an annual maintenance contract being signed in, otherwise there's no use. Yeah, so I think that's one very important. I think monitoring is a very important exercise which has to come up with both sides, transparent.
Sure. Looking 5 to 10 years ahead, how would a truly successful Make in India? Last year I spoke on Make in India equipment, and this year we are stuck with this. How would this improve with 2 to 3 policy or industry actions that are most urgent now? I think the technical people would be able to help me out on it.
Yeah, so of course, in terms of procurement of material and so on, should make it a little more, sort of better in terms of ease of purchase. One example would be the procurement in terms of how the Chinese have done it. They said you can import only 25% of your requirement. If in case you're having 10 equipment to be bought, only you can buy 2 equipment imported. Rest 8 should be from the same country. So that way you are, sort of forcing the hospitals to buy from local, and therefore there is a, building of the industry and keeps going up. That's what it is. And and again, the challenge which we have, a spec which is there, which is similar across the country, not everyone giving their own specifications, and we are having stuck with everyone giving their own wish list. So that's one thing which we should avoid. Yeah.
I think all of us are required to plan out what next best we can look at over the next 5 to 10 years and build up not just equipment, not just end user issues, but also an ecosystem starting from research to manufacture to comfort in manufacture and sale to utilization to after sale service and disposal. Because with all of this, you're going to get a lot of lithium batteries lying around. So that is the other thing we need to look at. I think with that, I will end the session. Thank you very much to all the panelists. Umesh, Sashi, Sunil, and Om Prakash. Thank you very much, everyone.
Thank you, sir. Thanks a lot. I request panelists to please felicitate chairperson. And chairperson to felicitate the moderators. Sorry, moderator to felicitate panelists. Next, we have a debate on zero separation of mother-infant dyad. Is it possible or not? To debate for this, Dr. Sugandha Arya, and against this, Dr. Kamaldeep Arora. To moderate the session, I invite Dr. J.P. Dadich. CV. So Dr. J.P. Dadich is Senior Consultant, Vastalia Child Care Center, Gurgaon, Haryana. He is advisor to NNF for protection, promotion, and support of breastfeeding, chairperson, NNF breast milk and breastfeeding support, promotion and protection, recipient of Dr. Armida Fernandez Oration of IVCF chapter 2024, former secretary of NNF 2023. He has more than 40 publications and 20 chapters, contributed to NNF CPG and contributed to several guidelines, reviewer of 14 international national peer-reviewed scientific journals, trainer for national and international courses on neonatal resuscitation, newborn care, IVCF. Thank you, sir, and I welcome you. I request moderator to introduce.
Yeah. So good afternoon, everyone. And at the outset, I would like to thank the NNF leadership and the organizers of Neocon 2025 for giving me this opportunity to moderate this session. So do we have the introduction slide of Dr. Sugandha? No. Oh, it's there. Okay. So, friends, we are having this mini debate on is zero separation of mother-infant dyad possible in NICUs? Well, when we say zero separation, it means the small and sick newborn is in the NICU admitted, and mother is also admitted along with newborn in the NICU. And mother is there 24 hours a day and not as a mere spectator, but taking part in the care of the newborn. Now, this is a new concept which has emerged in last decade or so. And why we are debating here? Because though we have the knowledge, the evidence is emerging day by day, but the clinical integration is still very patchy. It's inconsistent. It's not being implemented in many units. So we have for this speaking in favor of this particular intervention, Dr. Sugandha Arya. She is the professor of pediatrics at VMMC and Safdarjung Hospital, New Delhi. She is in charge of Mother NICU, MNICU, working as a faculty in newborn unit of Safdarjung Hospital for last 25 years. Clinical investigators in WHO ICMR research projects, including Dennis study, immediate KMC trial, Action 3 trial, neurodevelopmental follow-up study, and author of original articles in national, international journals and chapters in books. So I request you, Dr. Sugandha, to tell us why do you think that it is possible to implement in our NICU? Please come here.
So now we are moving towards little heat. There's going to be a debate. So we expect some heat to be generated, not debate. So probably now activity will be more. So the question is, as sir has already introduced, zero separation means we do not, every baby to stay with the mother irrespective of gestation, weight and level of sickness. So well babies, it is easier to manage zero separation, but sick babies, how to have zero separation, that is the issue. But the first thing is, why do we need zero separation? The question of possibility comes later, that why are we even talking about it? Now, in the present conventional NICUs for years together, what is happening? The babies go to the sick baby goes to NICU, mother goes to the postnatal ward, and mother then comes to the nursery intermittently. As a result, what happens? It is very difficult to implement family participatory care and developmentally supportive care, as she comes for 2 to 3 hours average to the nursery because she has to come intermittently. And since she is coming for such a less time inside the nursery, the breast milk feeding rates are very less. Immediate kangaroo mother care is almost negligible in most of the NICUs. And since the nurse is taking care of all the babies with a low ratio, there is a high risk of cross infections and ultimately leading to high mortality. So what is the answer for this problem? So we need that the babies and mothers should not be separated. Then what do we need? Zero separation is possible only if now the sick baby cannot go to the postnatal ward and stay with the mother. We know that because he needs a very technical care. So the second answer is that the mother comes to the NICU and stays inside NICU 24/7, just like pediatric ICUs. So such a facility is defined as mother newborn care unit, where mother stays with the babies. So a MNCU is actually a NICU only, where baby has all NICU facilities and mother stays there 24/7 who doesn't have any major illness. This is how the mother newborn care unit looks like. This is a picture from mother newborn care unit of inborn from Safdarjung Hospital, which was made during the immediate KMC trial. So you can see it has all the facilities of nursery. I will show you a single cubicle. How does it look like? Single mother baby diet cubicle looks like this. So it has all facilities for, this was a level 2 MNCU. So all the facilities of level 2 NICU. Along with that, there is a bed with adjustable back support so that the mothers, postnatal care of the mothers can be done right in the ICU. The question was how to make it possible. So MNCUs Just basically, what does it need? Either we need to convert our NICUs into MNCUs, or we have to make MNCU to begin with, depending on your space allocation and all. And what do we need there? We need the same neonatal infrastructure equipment, exactly same as the NICU you wish to run, whether it's level 2 or 3. But by the side, as I told, every warmer has to have a mother's bed inside ICU so that she can stay with the baby. And to make MNCU functional, so you need an infrastructure, space, equipment, and along with that, some processes need to be upgraded. So KMC garments with binders and KMC chairs, because now you have a good opportunity for immediate kangaroo mother care. Also, you will have to provide basic services for the mothers. They are going to stay 24/7. So you need mothers' washrooms, bathing areas, dining areas. And also we need to provide obstetric care to these mothers who have just delivered and staying inside NICU. So normal NICU does not have these facilities for the mother. But actually these should be there. These are usually there in the postal wards. But now in MNCU, you need to have these facilities so that mothers can live comfortably with the basic facilities available. But now you want baby and mother together. So if a baby is born and is sick, then baby and mother both to be shifted to MNCU for together. But if mother is not stable enough to shift immediately, then baby goes with surrogate to the MNCU, and later on she can replace. We need to train healthcare providers to provide neonatal care in KMC position for the smaller babies. I've already talked about the other requirements. And very important, we need to train mothers and surrogates to maintain asepsis so that they can stay inside NICU without increasing the risk of infection. So the presence of mother inside ICU, if we made it possible, then it gives us a lot of opportunities. Prolonged effective kangaroo mother care is very possible. She's staying right there. So it is not difficult to have longer hours of KMC. Obviously, the frequent and early breast milk feeding will increase. Mother is right there with the baby. And not only baby gets immediately breast milk, mother also has a very good lactation when she stays with the baby. Family participatory care, task sharing happens between the mother and the baby. So our NICUs where nurses patient ratio is very low, there the presence of mothers really help out to manage these babies. And another very good advantage is mothers are very well prepared before discharge. She has done everything by her hand before she takes the baby home. This is the unit I showed you was the level 2 MNCU, which was made during IKMC trial in Safdarjung. Now, since February 2024, we are running a 40-bedded level 3 MNCU, where babies are ventilated also, and term babies are also there. All babies stay with the mothers, even those who are on ventilator. So this kind of unit we are running successfully, and we have found a lot of advantages by the presence of the mother. Now the forum is for against.
So thank you, Dr. Sugandha. She was very convincingly telling us that why it is possible, because she was actually involved in implementing this project in their unit. Can I have Dr. Kamalpreet's slide? Yeah. Because she actually implemented it, so she was convinced. But we have Dr. Kamal Arora from DMC Ludhiana. He is MD Pediatrics, DM Neonatology from AIMS New Delhi, Royal College Fellowship Liverpool, UK, and Professor in Division of Neonatology, Department of Pediatrics from DMC. He has many major achievements. He is part of many professional organizations. Presently, he is Executive Board Member of Central NNF for 2026 and Vice President of NNF Punjab 2025. He wants to implement this very revolutionary intervention in his unit, but he has certain reservations. So let us hear from him. What are those reservations in his mind? Why he is going against this particular intervention? Dr.
Thank you, ma'am, for that wonderful elaboration. But since I've been given a topic, and my first question would be to all of you: how many have a maternal NICU with them? 1, 2. So out of 3. Out of 50 or maybe 60 odd people sitting here, only 3 have maternal NICU. So that tells you they are against it. So that's what I want to say, man. That's what I want to say. Okay. So I have the word zero tolerance. So ma'am says the maternal infant diet has to be there. Zero tolerance means ये होना ही होना है जरूरी. तो निकू नहीं चलेगा. So is zero separation idealistic? Yes, zero separation may be idealistic, but not universally possible or safe. So that is what I'm saying. Maybe it is idealistic. Ideology बहुत अच्छी लगती है. ये करना, but it is not universally possible. So I have few points which say that why it is not. So I have the issues with the preterm babies, the mother, infrastructure, evidence, what ma'am said, and then WHO guidelines. So preterm neonates, extremely preterm or critically neonates. How many of you keep the ventilated baby, a very sick baby on HFO with the mother? Not possible. Requiring intubation baby, you may be on the CPAP and you have to intubate that baby. Baby is crashing anytime. So again, at that time, the baby will not be with the mother. Higher ventilator setting HFO, so inotropes, so you have to do sterile procedures, mother touching the baby, so you need to teach her everything. So continuous maternal presence may compromise the treatment effectiveness and the infection control. So that is my point. Maybe ma'am says that the infection control goes less, but I say that infection control can go up if you are here and there and the mother touches the baby immediately and the treatment effectiveness goes down. And then you look for a cause for it, it's an issue. Maternal health. So that was for the preterm babies, maybe for maternal health. Immediate post-cesarean. Mother is not comfortable to even move around. So mother stays there and she has a pain. Everybody, attendants are coming up over there and then taking care of the mom. So that's a major issue. And it is estimated that nearly 70% of the NICU mothers experience maternal health disorders. So it is already there. So hypertensive crisis, if the mother is in hypertension and pH is there, mother is anemic, not able to move around, emotionally unstable. So the next line says, the most common postpartum depression followed by anxiety and OCDs. So mother is doing so many things there and you are taking care of then is a psychiatrist coming inside to see the mother? Are we dealing with something with a baby or with the mother? So cannot be expected to provide a 24 hours KMC for such a sick mom. Third problem is we are living in a lower middle income countries. So NICUs are overcrowded. I think typical NICU in our scenarios looks like this. So is there a space to move around? And you are talking about a space to keep recliners and to keep the beds. And this is the mother is staying there very comfortably. It looks very fashionable and sundar acha lagta hai, but there's a problem with this. Limited staff. So we are talking about staff. There are government colleges where there are staff is 40 by 40, 1:2, 1:2 ratios. Here we are dealing with a ratio of almost 4 or 5:1. So mother will deal, the staff will deal with the mother or the baby. So we have a limited staff there. High baseline sepsis rate. We are already in a problem with a high baseline sepsis rate, and then I'm saying that sepsis will go down with this. So I doubt about this if these things are happening. The lack of space for the beds and recliners, no dedicated mother zones. So the mother zone has to be dedicated. So mother has to go for a wash, mother has to go for the space has to go up. There may be funds in the research which they are getting, but I don't think so anybody can get so much of funds that what will happen. So I just put down in the chat GPT that how much cost it would make for maternal NICU to cost for a 20-bedded maternal NICU bed. It told if you want a basic or you want an advanced. I said we want an advanced because the mothers are there. It said 18 to 19 crores. So 18, 19 crores, I don't think anybody would spend on making this maternal to just for the baby to be well and the mother to be comfortable. And it's a friendly NICU, definitely, but we need a lot of cost for this. So significant risk in the increased hospital acquired infection rates, disrupted workflow during the emergency. If there is emergency, the mother is there, the parents are there, so it will be very difficult. Staff burnout will happen because they are doing so much of work, they are not getting even a single rest. Unsafe handling of the unstable neonates. So the evidence which says evidence for benefit is not equal to universal feasibility. So evidence doesn't tell you equal feasibility. Effectiveness and efficacy are two different things. IKMC trials are conducted under carefully controlled conditions, not typically overcrowded NICUs with 40 babies and 3 nurses. So can the mothers replace the nurses? I don't think so. It can be done at this stage of time. Infection control remains a key barrier in real world Indian NICUs. Mother cannot replace trained nursing staff doing the critical management. They may be doing very good the KMC or the feeding part. So ethical care requires respecting maternal recovery also, posting 24/7 presence risk, exhaustions and neglect of maternal health. So WHO also says implement this. The manual says that implement this, but warns the zero separation requires high quality infrastructure and a policy support from there. Everything should be there in place. So my summary is mother-infant proximity is vital, no doubt about it. I think we are all neonatologists here, but absolute zero separation cannot be applied to all babies, all mothers, all hospitals. Not possible. So safety must come before the ideology. That is my take on this one. So let us aim for a minimal separation, not an unrealistic zero separation. You are saying it is realistic, so I am there for that part. Thank you.
Thank you, Dr. Kamal. And you have asked many questions, and Dr. Sugandha will be able.
That's why we thought in debate, it doesn't, if it ends like this, nothing we reach. So the challenges he has mentioned, he's very right. It is not an easy affair here. I didn't touch that because he was supposed to tell that. But it is very feasible and possible. And I wanted to clarify one thing that now the MNCUs are not running in the research mode at Safdarjung Hospital. That research is over. Now we are running with the hospital staff, with the hospital budget only. So number one. So it is not just the research, and Government of India has adopted this policy that new NICUs will be now MNCUs, at least at district level hospital for level 2. Right now they are not recommending for level 3. And that module has been released for the policy purpose also. Now his 2-3 points I will take fast. Timing has stopped. 3-4 points, which he has said the problems, but actually MNCU is a solution to these problems, many of them. And some challenges are really challenging, like asepsis, training, but the opportunities and the benefits are so much that they are worth taking. And the Safdarjung MNCU is a glaring example that we have been running for last 2 years and shown a reduction in mortality. Another thing he said, risk of infection. We were all very worried when we started MNCU, the risk of infection. But believe me, the trial also showed that the infections come down, and the reason is very simple. In a normal NICU, the nurse, he himself is saying that the nurses are very less. One nurse feeding all the babies in a line, giving the injection all the babies in a line, risk of cross infection is very high. But when diaper changing, feeding goes to the mother touches only her own baby. So actually the cross infections come down, but it's seeing is believing. Unless you do it, but once you start doing it, then there is no looking back. Then you find these apprehensions were more anticipations, but not the real time. Yesterday, Dr. Lalan said one thing, everything is impossible until it is done. So looking at that is why I showed you the slide. Why do we need it? If you are convinced you are going to meet these challenges the way we have met at Safdarjung Hospital, and it is feasible, but it is challenging, fully agreed with Dr. Kamal.
The cost is a major issue. So
now coming to space and cost, I wanted to tell. How are we asking extra space? These mothers are already in the postnatal wards at some other bed, but they are separated like this. Can't we reorganize our services that this mother's bed comes inside? We are just reorganizing the services. Can a ward be converted so that those 12 mothers will stay in that ward only? But now these will be the mothers whose babies are sick. It is just reorganized. If you look at it, there's no extra space. Then washroom, bathing areas. Aren't we supposed to provide good washrooms, bathing areas to the postnatal mothers?
अभी तो हम लड़ रहे हैं.
Postnatal wards.
अभी तो हम लड़ रहे हैं, फिर गायनी वालों के साथ भी लड़ाई होगी.
Now,
उनकी स्पेस लेने के लिए.
Then coming to the obstetric care. Mother's health is first priority. So if obstetrician says mother is not fit enough, there is any complication, these mothers are not shifted to MNCUs at all. Only those mothers are shifted who are uneventful. So there is a protocol which mothers will be shifted, which emergency science basic will be monitored by the neonatal nurses. And there is an obstetrician on call. What happens in postnatal ward if a mother suddenly becomes sick? You call an obstetrician. Same you will do here. We will call an obstetrician. Nobody sits in the postnatal ward 24/7 for normal mothers.
So doctor.
So it is just a way of looking at things, and obstetricians, one convinced, instead of seeing the mother in the postnatal ward, she has to make a little effort to come to NICU to see the mother.
Yeah. So Dr.
Like
Kamal,
in our hospital, they are very convinced. I'm sorry, have you seen it?
What do you think now?
No, ma'am. there are logistic issues. If the mother gets sick,
Said, what is the cost? Let me come to the cost. We have published an article on costing of MNCUs because everybody was asking this. I will share that article. It is it has just got published last month. Costing equipment in an MNCU is same as the newborn. Whatever NICU has, absolutely same. No different specifications or nothing. The only thing is mother's bed, which is already there in the postnatal ward. You are supposed to buy that bed in any case. And additional
Ma'am, I
KMC
request to conclude faster.
Yeah.
KMC garments
But
and
the clock
KMC
is still showing 2 minutes. So we are going according to the clock. Yeah.
need to have any altercation from the audience.
Yeah.
He's it.
Yeah.
Sir, I am Dr. Dhananjay from Jaipur. So very practical points. Both are very rightly said. Zero separation is required. So what we do, the maternal bed is not supposed to shift in the NICU. What we do after stabilize the baby and segregate the baby after when baby requires a long-term antibiotic completion course. So we shift it in the room along with the baby's cradle. This is like this MNC care. So nothing extra load on the financial or nothing load is required. So I think separate in the room with baby is as good as MNC
Yeah.
care.
Yes, certainly. But we are talking here the small and sick babies, those who are really sick actually.
So basically,
Yeah.
already said, ma'am, already said
Yeah.
that this is required for the level 2 or level
Yes,
1. That's
yes,
it. So
yes.
level 3 doesn't require.
Yeah. Dr. Ashok, yes.
So you can take that mic.
Okay, good. Thank you.
Yeah.
I enjoyed this debate.
We also enjoy.
Ideologically, I'm for zero separation. And the baby has stayed with mom for 9 months in utero. And after birth, by and large, there is no need to separate them unless baby is very sick or mother is very sick. Of course, there are challenges and barriers in implementing this thing. So for new units which are being constructed, we can have this kind of setup. But the old units, like if I think of my Banaras Hindu University, we have 24 beds for the level 3 NICU, and we have 16 MNCU beds. So where the mother and babies are there 24 hours a day, basically. Because it was being constructed 4 or 5 years ago under MCH program from National Health Mission funding. So we could create it. But for older units, when there is no space, they have to think of restructuring. More important, formidable barrier is the mental makeup of the health professionals.
Yes, yeah.
If
Attitudinal
we
change.
do not change, I think if 30, 40 years ago, who would have thought there should be exclusive breastfeeding?
Yeah,
Formula feed was the dominant thing. When we were raised in 1984, 85, all newborn babies used to give in formula feed. But nowadays, no one will think of it, doing it. And it has taken a long time. Same thing happened with ORS. Pediatricians never accepted in 70s. The ORS is going to work. But then it worked and worked and worked.
Yeah.
So I think it's a very good thing, but there are many challenges to overcome before we can really put into practice. Thank you very much.
It will take time, yeah. Okay, thank you.
बोलिए
I was so convinced to start MNICU in my area, but I had to speak against it. I had to actually think over it. What should I come up? Then I thought and thought it. Then it made.
So now there is a truce. There is a truce. You can shake hands now.
I can say it's like for Hindi movies का जो villain होते हैं ना, like Pran था, he played very violent roles, but as a person he was a wonderful person.
Yes.
So that was your role.
You can shake hands now.
Just one question.
Thank you, sir.
So there is a truce. Thank you.
Just one, out of one curiosity, I want to ask one question. What was the response from the obstetric team?
Yeah, I will. Whenever you start a new thing, you didn't ask the nurses' response. They also resisted initially, but after it started, they get very happier because of the task sharing. He said workload doesn't increase; it decreases by the presence of the mother. And regarding obstetrician, also initially they have this. They are giving their space to create because you have to take space from them only. But after we started the unit, our obstetricians also felt very nice coming there because they see the baby every time. And when they talk to the mother, they ask about the baby. We talk about the mother. How's your mom? You are doing, mom. And then this diet care gives a lot of satisfaction to obstetrician also. Their ultimate aim is to
Everybody's
send the
happy
baby.
actually, you know. Yeah.
So ultimately, after doing it, but initially there was resistance.
Yeah. So thank you very much. We stop here because
Thank
we
you, sir.
already
Thanks.
crossed the time.
Thank you, sir.
Yeah. Thank you.
Thanks for the well coordinated debate and
Made it a debate. It was not there actually.
I request speaker to felicitate the moderator and moderator to felicitate the speakers. Next, we have a panel discussion. Designing developmentally friendly NICUs, the built environment as a therapeutic tool. To moderate this session, I invite Dr. Prakash A. Panelists are Dr.
I will invite the panelists. Yes. Okay, sir. Thank you, sir.
Very good evening to all. I thank for the opportunity to be here. Is Dr. Kamal there? Okay. Dr. Kamal, I think I thought I should appreciate you for talking on this, despite knowing, this thing, and just for the, sake of acting. Yeah. Thank you for that. Right. So to start with, I think my topic is, I'm Dr. Prakash from SRMC as a professor and senior consultant. And so I'm going to talk on designing developmentally friendly NICUs. Actually, basically, I'm going to talk on the infrastructure rather than, anything else, not the developmentally supportive care and things like that. How do we have an environment which is going to provide a better ambience to the baby? So with me, I have panelists which I'll be inviting. So we know that neonatal care refers to most vulnerable population, and their brain is, quite vulnerable to the things what we do. And so baby friendly designing is quite important. Now, if you look at the history of neonatology, it began in 18th century with a very crude practices, and slowly changed with innovation of incubators, specialized cares, and what it is now. They save babies in extreme preterms and all that. But are we still complete in what we do? I think we are still, need to know what can be done, differently for the better outcome of the babies. So to talk on this, it's my, great pleasure and privilege to invite my panelist with great experience, Dr. Dhananjay, who's a director and senior consultant in Babylon Hospital, Jaipur. He has a lot of academic achievements, honors to his name. Now he's here because he's got 28 years of practical experience of neonatology, and he's been core member of NNF Accreditation Committee, established and guided many NICUs. I think he's an apt person to be here. And I think Dr. Arijit, same, Indigo crisis, is not here. And then Dr. Sumita Saha, so Fortis Hospital, Calcutta, West Bengal. And she's also been a great academic achiever, has a lot of papers to her name. She's been the vice president of Neonatal Society of West Bengal. And she's here with her lot of vast experience, 8 years in UK, and also including more than 2 years in tertiary care and ICUs. And last 13 years been the head of the neonatal unit in Fortis Hospital. Then we have Dr. B.P. Jaishwal. So he has been a lot of executive member, ex-secretary, and organizing secretary for various things. So he's a good administrator. So he is also the professor and head of the Department of Pediatrics in NMCH partner. So with this, great stalwarts, I think we can ideally start with the discussions, right? So of course, no disclosures, and I'm not promoting any products. I'm just whatever is shown would be accidentally what has been captured. Now, how are we going to discuss this? The discussion will be like, suppose somebody comes and thinks that, shall I start an NICU? Now, what should I do? or they already have an NICU, they want to modify it, to have a baby friendly or development friendly hospital. So now the question goes to Dr. Dhananjay. When planning to build a new NICU, how should we decide on its optimal location within the hospital or a healthcare facility?
Thank you for giving me opportunity here. So NICU is a bit different from the other adult ICUs or pediatric ICU because it requires we are caring of the tiny babies, so we have to take care of the developmental supportive care along with this NICU setup. So NICU should be located where it is safe and it is sound like it should not be a very much noise, and it should be easily accessible, and it should be nearby the operation theater where the delivery is there, whether it's an operation theater or it's a labor room. And they should be like located when it requires to shift the baby from the delivery site to the nursery, then it should be a very much very less transporting time, because critical baby
Time
doesn't
is
require
better.
such time saving. Yeah. And they should be nearby the mattress, or must be on the same maternity floor, because
Yeah.
mother can be taken care of with the MNC care, and there should be
Understood.
controlled access also to
Understood.
take care of the safety.
Thank you.
So
Thank
these are
you.
the common, very common
Thank you. So, take home message for this question is that it's better to plan and ICU, of course. I think we've been talking about NMCU and all that. I mean, MNICU. So, the take home message, it should be located near to the labor room. Though ICUs are preferably placed in the ground floor for easy evacuation and other purposes, but the NICU alone probably should be planned near a labor room for other reasons. So that cannot be in the ground floor. Next is, I invite so I think Dr. Arjit did not come. So why is spacing and unit layout critical and development supportive in ICU? Is there anybody who would like to take that question? Yeah, thank you, Dr. Shivasu. Yes.
So adequate spacing is very important, just mainly to prevent the infection, and lots of level 3 NICU babies need lot of care. Sometimes there is ventilator, 4-5 syringe pump is going on, and monitors, and so many instruments going on, and that needs quite a lot of space. And also when little bit stabilized unit, also we are talking about IKMC just now. So during KMC, giving the KMC, we need a proper KMC chair that also needs spaces. So spacing is very important, and NNF accreditation guidelines suggests to have at least 100 to 150 square foot per baby for level 3 NICU. For low cost setting, it may be 80 to 100, but it's adequate spacing so that babies can be handled and infection can be controlled. That is very important.
Right. So it's quite important to have the spacing in NICU, especially because it's not only from one of the important things you avoid is infection. Not only that, it also helps in developing supportive care by not getting disturbed by the interventions for the babies who are nearby, and the lighting and the noise of the monitors and other things. So every a distance of this thing double the distance reduces the decibel noise by 6. It reduces decibel noise by 6. Same as lighting. If it is focused lighting, then probably the babies next to it does not get disturbed. So these are the things which are why it is important to have spacing. So definitely, if you have a existing space, depending on the space, you decide the number of beds. If you're going to build a new one, then depending on the number of beds, you decide the space. So I invite Dr. Sumita to talk on how should ventilation air exchanges or air flow and air condition be planned in NICU.
So dedicated heating, ventilation and air conditioning systems should be planned very early when you are planning for making an NICU. And that ideally should have HEPA filter also, which reduces the very little 0.3 microns organisms also. So that system should have a separate system from all other part of the hospital. So NICU should have a separate dedicated system, and there should be a 12 to 15 air changes per hour in open bay system, and single family room NICU there should be 10. If there should be ideally a septic NICU, if there is a septic NICU or isolation unit, there should be a laminar flow or negative airflow system so that infection from the septic babies doesn't go to the other part of the NICU. The temperature should be controlled. Overheating can increase the complications like sudden infant death syndrome. So temperature should be around 22 to 26 degrees centigrade. And humidity also is very important to make the babies comfortable. And humidity should be 40 to 60% for general babies. But if it's an extreme premature baby, less than 30 weeker, 28 weeker, they should be looked after in the incubator where humidification may be much higher. So for the little babies less than 1 kg, we can use humidifier even 70 to 80%. But for general NICU, humidification should be 40 to 60% to give the best care, best comfortable environment for the baby.
Thank you so much. Can I request the people in the last row to either move out or because it's creating and is disturbing our session, please. Excuse me, Dr. Ravi, and I don't know, maybe Dr. Ashok. The session is disturbing. Sorry to inform that. Thank you so much. Thank you for your cooperation. Yeah. So now to start with, so you have. So it's important. This part, remember, it is little costlier, but it is important to implement. Otherwise, if you have a very poor air exchange system, it's going to now produce more of infection, the breakdown, and other things are quite higher. Now, though the HEPA filters and this thing are more to do with infection, but the humidity and other things are related to a baby's comfort. So this is basically, if you see make a comfortable environment, would definitely make the job easier for the making a developmentally supportive care. Now I invite Dr. Jaiswal. So how should lighting be designed to support a neurodevelopment?
Good afternoon, everyone. Actually, in NICU, lighting should be taken care of. And I have seen that usually we don't pay much attention to this fact. Then what should be the arrangement of the light? Lighting should mimic circadian rhythm. And I need not tell you what is circadian rhythm. Therefore, if in 24 hours, sometimes the illumination of light is too much, or sometimes it is low, then it will hamper the sleep pattern of the newborn, And sleep is so important that it leads to good, if sleep is sound, there is good neurodevelopment of the newborns. All of us know. Therefore, I would suggest that there should be very specific lighting so that the lighting could be controlled at any juncture. And lastly, I would like to tell you that when, some procedure is being done, then the lighting should be around, 2000 lux. And lux is the illumination SI unit. And if you are not doing any procedure in NICU, then you please maintain it should be 50 to 200 lux. Therefore, illumination must be taken care of. With these words, I think lighting and should be taken care of by each and every neonatologist.
Thank you so much. I think it's right. So I think a lot of research has really proven that, either too much of lighting throughout the day or the dim lighting throughout the day, both does not help the baby's development. It's a circadian rhythm. So you need to have 12 hours of lighting, 12 hours of darkness. for the to have a normal development, especially the melatonin is an important hormone to produce sleep. And all of us know if a sleep disturbance, how much impact it has in our life itself. So you can imagine how it would impact in a baby. So because a baby doesn't mean they don't need sleep. So this, the lighting should be important. So what we would suggest is there are a lot of lighting which has come now. This is one of our students' unit where it's called skylighting. It's called skylighting where, it comes on top, and once you switch on, it will be bright, but it won't it doesn't actually harm the eyes that much. That's one part of it. But of course, it's all comes with a cost. Or you can actually also have a timer. Nowadays, I think all of us have to have at home. When you're designing itself, it should be connected in such a way that there are some of the lights on the passages switches off on, after 7 p.m. and then switches on at 7 a.m. So that is some of the designing you can plan, and that's very simple. And each individually you can have lights for independent babies where you are going to do something on that specific baby, or a focus lamp on that specific baby. So this is something quite important. The lighting, when you're doing it, as you say, the normal lighting should not exceed 600 lux. Okay, that's the maximum lighting you should have to not to impair, babies. When you're going to do examination, focus on the part you're going to examine. So you should have a focus light, and these are all lights which does not produce shadows also. So that way also the lighting. Otherwise, what will happen? Say, imagine if you have a light on the sides, you need to have a higher flux compared to a light which is just above it. So that way also it's important that there are lights which does not produce shadows. Lighting with setup which may not produce shadows. So these are some of the tips you can use when you're going to build, or if you're going to modify lighting in your environment. And this is one of the video where you can see that there's not common infrastructure, like something like this can be set up where I think you have lighting. If you just show that it dims and goes on, so we don't actually switch on the light, and it's also done aseptically. So something like this can be designed even in the environment, right? So these are all ways for you to look at. So now I invite Dr. Thananjay. So what features should a development support NICU include in terms of acoustic designing or acoustic noise control?
Okay. So it's again a very, very important part for the developmentally friendly NICU setup. So there are the two facts. One is we have to include during the formation of NICU, or another part is to act, how to minimize the loudness of the voice. So one is this, during formation of new ICU, we have to include the sound absorber surfaces, soft closing doors, and disable monitoring and zoning noise equipments. So these are the common things. So just to reduce the stress, apnea, and bradycardia, and so many things. So this is probably this is around not loudness should not be more than 45 decibel ideally, but in stressful condition, in intensive care condition, it should not be go beyond 85. So this is the basic. We have to act also to reduce the noise. So we have to setting the alarm, monitor alarms, and we have to accumulate the different works of procedure, or a different cumulative that procedure. So we should not disturb the baby repeatedly for the development. So these are the common things we have to keep.
So if you see there, I think you can see what is the actual decibel, because the hearing starts by around 27 weeks of gestation. So those babies, so if you're going to have that acoustic, things you have to take care, because in utero you see there's only 35 decibels, and then as per recommendation it is 45. And then if it is going to be an average, it should not exceed 70. And then peak noise should not exceed 85. Actually, when we conducted an sound audit in our unit, so we did find things going up to 75, and average was actually around 52. So then when we designed the new NICU, we could bring it down to 48. But still, it's a challenge for us to really, have a decibel below 45. But whatever it is possible, because air conditioning itself was producing so much of noise, and something which is inevitable. So the main, the noise which comes in the unit is because of the air conditioning. So the air conditioning should be in such a way is insulated, and see to that can be having a proper ceiling, which has, and also with the sound absorbing materials. There is something called, what is that? Attenuated noise. There are two things. One, you can have an alarm in your system where, this thing will just give an light alarm. Not, again, you cannot keep an alarm with a noise, which will again increase the decibel count there. So you should have something called alarming system where, this will be at green color, and the moment it increases, it will come into red. So we know that something is happening. Whatever is preventable, like, the way we speak, sometimes we just forget and then keep talking, then we will say, whoosh, like that. So instead of that, this will just, highlight, a color will come where we can notice it. I think some of the units do have with just a simple red light. There's something called hybrid acoustic diffusers. That's a new thing which has come where, you can actually, the sound will be neutralized by, these things will, send the waves which will neutralize the other noise, and by which it reduces the noise in the unit. Now, does it really affect the, baby's, outcome? Yes, all these have been proven that, the sound decibel higher has led on to later, adverse neurodevelopmental outcome and also hearing issues. So, Anil, please see to that, whatever possible way in our unit, we do not have the pulse sync noise. We only have alarm noise there. So, you can imagine that thing, can come down, and then alarm noise is the only thing which is kept there, of course, but you need to have a good nursing ratio for that. So come to the next thing, because you can't skip infection control in newborn unit. So in the newborn topic, so I invite Dr. Arijit is not there. One of you can take that question. What infection control and prevention aspects should be considered when designing an NICU?
So from starting from
Thanks, Dr.
when you were preparing the NICU, you should take some important steps to prevent the infection. So as I mentioned earlier, the spaces should be adequate so that sister can handle the baby and infection doesn't spread from one baby to other baby. Mother can have spaces to give KMC, or if MNICU is possible, that is absolutely better idea. Number two is the adequate hand washing station should be there, and that should be accessible to all beds, accessible to all beds, not one corner of the room and the other corner of the room is the NICU. That should be adequately accessible. There should be the display of different steps of hand washing. Single use or easily disinfectable surface for the furniture and equipment is important. And of course, when you are using, there should be a proper guideline how to maintain. There should be a tick box, should be followed by the staffs when the cleaning protocol of everything starting from the incubator to door handle to or surface, everything. There should be an idea. Isolation room for the infective babies, and as we said earlier, the isolation should have a separate air circulation system. There should be negative pressure. If it is possible, there should be negative pressure. That will be better. That infection wouldn't spread to the other organisms, other babies. And if there is a HEPA filtration is possible, then that is the best to have. Minimum clutters. So there should be the labeled bins so that that could be cleaned properly, and separate staff and families to be there to reduce the exposure to the baby's infection.
Thank you very much. So here, so the infection control, suppose for example, negative pressure control is very easy to establish. Just you have to put in an exhaust fan in a low resource setting to create a negative pressure, though it may not be ideal, but it is better than not having anything. So next would be like I invite Dr. Sumita that how can NICU be designed in a family center? I think we have a lot of debate now. Probably we will leave out on mother newborn care unit. I think already have that. Probably you talk on the other aspects of it. Yes, madam.
So as we discussed just earlier, MNICU is one of the ideal spaces, but that of course needs a lot of more sort of infrastructure for that. But at this moment, those we have got the NICU, every NICU should have a special Kangaroo care unit, should have a special breastfeeding unit, where and NICU itself, even level 3 NICU, where babies are ventilated, we are giving a KMC from the ventilated baby who are already attached with the monitor, who are in the CPAP, already attached with the monitor, and there should be a bed available, KMC bed, I mean KMC chair available in the next to the baby bed, if the NICU is not possible. So it's adequate space for KMC. Quiet environment, as we mentioned earlier, that for the hearing development, environment should be reduced noise, and for that the light and noise should be all the staffs, especially the sisters, should be aware of this importance of this light and noise. They should be, when the NICU, when the babies are stable, they should in the night, consultants are not there, but they should be aware that what is the implication of the high noise and the high lights, and they should be using it properly. Breast milk should be available for all babies in both preterm and term baby, of course. But there should be parental educational material and engagement, proper classes for breastfeeding, proper breastfeeding lactation consultant should be available. All the maternal unit, they can help the mother to express breast milk for their babies, to establish the breastfeeding from the very day one. And the proximity of parents that we have talked about earlier, from that zero separation from the beginning for the sick babies also, and that will give the better outcome in long term also.
Okay, thank you very much. So family-centered care is again an evidence-based practice. Definitely, it has been shown to improve breastfeeding outcomes, shorter stay in hospital, like a trend towards reduction in the infection, and a lot of comfort. Mothers, confidence, mothers' satisfaction or parental satisfaction, everything shown to be higher. So at least the things which you can do is like allow the parents all the time into the unit, and parents to participate in the care and have a KMC facility to provide KMC. You cannot have small areas where KMC cannot be provided. So all these comes under family-centered practices. So what role do the mother-child care units play in the design of the baby-friendly units? I think anyway, we just shortly will finish because I don't know, some maybe newly people could have joined. Yes, sir, sorry. Dr. Jaishwal, sir.
Yes, Dr. Prakash, this is a much debated topic, and our previous speakers, they also debated very in a very detailed manner. And Dr. Ashok sir from BHU, he also participated. That what should be the role of, and now there is no doubt that there is tremendous role of mother in an ICU. Mothers, they are the integral parts of an ICU, I should say. And if mothers are involved in the upkeep of their, sick babies, there will be more of bonding, and breastfeeding will also be, promoted. And thirdly, I should say that new research has suggested that if KMC is started within 2 hours, then it leads to much neurodevelopment of the baby, and mother should be a resident of MNCU. The concept of MNCU is there, and of course, there are less MNCUs at present, but MNCUs have been advocated by UNICEF and WHO and Government of India as well. Therefore, gradually, we neonatologists and pediatricians, we will, agree to the concept of MNCU. And I think that this will be a boon so far as the, neonatal mortality rate and infant mortality rate, these indices are concerned. They will come down drastically if this will be taken care of. But Dr. Prakash, one thing I would like to tell you that I'm heading 40-bedded NICU in Patna. And one thing I was very scared. Before, I was not allowing the mother to be present in the NICUs. I was scared of infection. But so far as my observation is concerned, infection is not, rather it has been cut down, and babies are thriving well and doing well, even prematures and newborns. So these things I would like to share with you all. Therefore, the policy of zero separation, that must be stuck to. And Dr. Sir has already said, Ashok sir, one thing, that very sick, very premature, if babies are there in an ICU, then this will be debated again, that whether the mothers, they may spread infection or they should be there for 24/7 in an ICU or not. That is a thing that should be debated by NNF and all the bodies, all the stakeholders. Therefore, I think the role of mother can't be
eliminated.
Yes.
Yes. Thank you, sir. So I think I think probably we, especially those who are already planning to start, I think probably think of this concept, how it can be implemented. Probably it may not be impossible, maybe worth the cost, extra cost we may go. Definitely it will have a little bit of extra cost, and the infrastructure we need to have a little more for an MNCU. So this is what I think we just saw Safdarjung Hospital, which is just projected, and this is our MNCU we just got, and then these are the things we could not get a consent from mother and infant, so we did not put with the mother and the baby. So everything is there, that can be done short of ventilation. Whenever baby is requiring, even with the moderate distress, the baby can be kept there. Anyway, one nurse will be allocated for that. So this is our, this thing there. We just started probably a few months ago, and we are just going on. It should work very well. Now, I think they already had a lot of debate, and the challenges is, the main challenge is to convince the management to go for it, because they will look at how do we take the cost out of it, and we cannot. In neonatology, especially putting a cost, already it is a costly affair, and adding on to this cost would have and this thing impact. But I think over time, when you show them the results and things like that, and they will get convinced, and even the parents will come forward. And I think most of the time, probably in future, parents will come and say that we don't want to get separated from our baby. So probably when you plan, I think this would be inevitable from your point of view. So this is the thing where baby is an active participant, and the primary focus of caregiver. Family is integral part and inseparable from the baby. The neuroprotection of the developing brain automatically happens because the baby is with a known person, and then the environment gets impacted because the mother is there always, and infant's mental health is supposed to be. In fact, they find that when the mother is there, or when all this is implemented, the baby's heart rate is down. They have less stress, less cortisol was measured. These are all evidence, was very evident that, how much stress induces or causes stress to the baby. So I invite Dr. Dhananjay. So how can we, how can the NICU design help in minimizing pain and stress to the neonates?
Yeah, basically, I have already mentioned. So again, reinforcing that in spite of the designing is definitely a part, because nobody want to put the capex during this designing. But other than designing, we have to make a standard operating procedure manual for the local level, so we can improve this development friendly environment. As single family rooms reduce the environmental stress and provide a calm setting. So what does it mean? It's the MNC setup setting. So I already mentioned that it is not required to put all the babies inside the MNC room. Rather, we can shift the baby. Once baby is hemodynamically stable, then can be shifted in the room, a private room, along with the cradle. So this is a sort of MNC in the separation. So segregation is a very, very important part, and we have to say even we shift at 1.2, 1.3 kg of weight, because that is again a concept of the MNC. Second is dimmable light and noise, we have already discussed, and easy access to the comfort measures. So this is the therapeutic intervention. Early therapeutic intervention is very, very important part that has to be discussed. So even baby is the 900 gram, 800 gram, and we have to start the therapeutic intervention during ventilation, even extreme premature baby. So that is very, very important to increase the development friendly environment. Third is space and facility to KMC. Yeah, so nothing can be without KMC. We cannot achieve. So KMC, for the KMC we have to involve obstetrician also, because day before yesterday we did the parental strategy TOT just to improve this uh, uh, neonatal mortality. So space and facility for the skin to skin through a standard operating procedure and minimize the handling during procedure. I already mentioned that we have to club multiple procedure at a time. So they should not be disturb baby again and again. And injectables, lines, or whatever, cleaning, so whatever suction. So we have to club multiple procedure at the same time. And proximity of staff or the patient to enable gentle intervention. So we have to repeatedly, once we take the round, whispering neonatal action very gentle, very soft because of their day-to-day routine practice. So we have to be very gentle, very like very soft spoken. It's a whispering sound rather than a loud sound. So the other practice. So my advocates not to put on the design of fancy design. We have to put the amount in the designing the NICU. Rather, we have to stress upon a practice of the developmentally friendly environment in the NICU.
Yes, Lord, sir.
Dr. Prakash,
Yes,
one
sir.
thing I would like to add. Dr. Dhananjay has rightly said about cluster care. And cluster care must be resorted to. You know, once mother comes for feeding, again, she comes for diaper change. This should not be resorted to. And I think the pediatrician and neonatologists who are working in NSU and the nurses, they must be instructed. I think this is not being practiced as it should have been.
Yes, sir.
Therefore, cluster care, mother comes once and does the
All
2
the
or
things
3 things
together.
once. Yes, that should be resorted to.
Thank you, sir. Point taken. Yes, sir. So, could like, how can a technology, and because we cannot escape from the technology.
Yeah, so basically, I just take the technology because nowadays, very, very important, we have to adapt the technology, especially like all monitors and all hemodynamics to be captured through iota measure. So INIC concept, ENIC concept is being taken up, and we should not afraid that the data is being captured, data is real or structured or not structured. So we have to adapt. So these are the same, many devices and on integration of the monitoring, and all the monitoring are being integrated through computer or internet, and all data is to be centralized, so we can monitor from the distance also. And
yeah, technology, and also as I told you, like
yeah,
we can
so
have
technology must be
incorporated,
yeah,
and it should involve somebody who can know that, and also like that light, circadian lighting can be utilized by using technology where it automatically switches on and switches off as per the time. So all these are all things which you can have on. And then like these all technology which you can implement smart. I think all this Dr. Thanajay has just informed. So now like whatever happens in India, like they will buy a Benz car or a Ferrari, and the end of it they will ask how much mileage does it give. So Indians are they like to do things with which can be done much more easier, and also I think we are good at it. It's not that I'm actually here sarcastically saying that a lot of things are actually done in Western world are not always necessary. So is it there? Is there ways that I invite Dr. Sumita to say, is there any way that we can have some low cost which are quite effective in having in the designing developmentally supportive care?
So local setting, the spacing can be, especially if it is a spacing is a issue. We talked earlier that for one baby there is 100 to 150 square foot. For low cost setting, it can be 80 to 100 for NICU baby. Rather than we can separate the zone, just putting a red zone, blue zone, just putting a tape rather than so high intensive zone, low intensive zone, and maybe a separate room for the infective babies. So that we can be done. For the sound reduction, we can use the clothing material, the plain clothes. If we rather than high technical window sill, we can just plain curtain can absorb the sound and reduce the sound level in the NICU.
Yes.
Lightings also can be used, is not very much costly, that we can reduce the light, and that needs the empowerment of the sisters. Nurse should be trained. Nurse should know what is the importance of all these simple small things to infection control, to reduce noise, to reduce light, give cluster cares. So sisters should be empowered
Education.
to take the proper care developmentally.
So I think education will be part of the deal here. In low resource setting, you may have a good education. Do you have like lot of posters inculcated in your design itself, so that they know what to do and how to do that. There are very cheap materials which can absorb sound, not necessarily the costlier ones, though it can come with its own disadvantages. And use things which does not produce. If you're using an iron, made or a metal made product basis more noise, probably you can go for a softer material or fiber material which will causes reduced noise. So things like that. In fact, I've seen many of times when you just put a little bit of little noise, the baby will jerk like anything. So that's a big stress we are going on. So as we are just going into lack of time, quickly can Dr. Jaishwa sir, can you say that how feeding and nutrition from the point of view of designing can be implemented?
Yes, yes, Dr. Prakash, this is a very important thing about nutrition and feeding, And I would like to tell everyone about BFHI. What is BFHI? That is, Baby Friendly Hospital Initiative. And Baby Friendly Hospital Initiative, this maneuver and this thing has been advocated by WHO, UNICEF as well. Therefore, milk preparation space must be there. Lactation support should be there, Comprehensive lactation management center must be there. Feeding protocol can be displayed. And of course, display of posters to promote feeding, to promote nutrition in NICU, that should be there.
Thank you, sir. So I think from the organizer only wants me to go faster, and I think almost you're coming to the conclusion of the session. So this is one important thing which I want you all to look at. So when you are planning to plan anything, so it's something called design thinking framework, which uses a double diamond model. So what does it do? Like the first thing, when you see that whatever you're starting, you involve all the stakeholders, ask them that what all things are required, or already there's an existing system. Find out what all things are there and what are the problems, and then you find out which is the important problem to be there, and then define that problem. And then again you diverge, you have a lot of inputs to have solutions to that problem. And once you know that what is practically feasible, or sometimes you can do a pilot of certain problems, and then finally you deliver it to find a solution. This is the most probably one of the suggested model to use it in any kind of designing. As I already told you, contextual inquiry is nothing but the stakeholders are asked about what is said and what they think and what they feel and what they did. And this is a guideline which is easily available in the network of Indian UNICEF guidelines. All that has been available. So to conclude, so a well-designed NICU is not just a space; it's a therapeutic tool that protects the brain, supports the families, and enhances the outcome. So with that, I think we conclude the session. Anybody would like to have the PPT with you? Can you scan the QR code? Yes, sir. Srinivas, sir, please, sir. I think government has done a lot on MNCU. I think he will have a lot of things to share. Yes, sir.
Since I have 5 MNCUs, 15 bedded, 75 bedded MNCUs in Tamil Nadu, another 5 is coming up. I think it's a boon to the community.
It's a great
That's
job,
what I
sir.
feel. It's a boon because I see the pediatrician and obstetrician interacting during the rounds. The mother is becoming like a one more second nurse taking care of the baby each and every day. So it is a big advantage. And don't worry about the challenges where the space you are talking about. If you don't have the space, convert your level 1 room or rooming in room as a MNCU room. That is point number 2. And point number 3, see, Government of India is pushing very hard. For all government institutions, they are giving 1 crore. That is 55 lakhs for the equipments for Fowler's cards and the warmers and other things, 25 lakhs for civil modifications. So any proposal regarding the MNCU, Government of India says, yes, go through. So there should not be any hiccup in starting the MNCU. In fact, my dream, converting level 3 as MNCU in Tamil Nadu, sir.
Yes, I think you'll do it. And I think only you got to this level where, which we initially thought was not possible in the public sector. But I think that's a great job from the Tamil Nadu government on the.
And for Professor Patna, today, 2 hours back, I discussed with the Sashivani madam. She was in Vietnam last week,
Sir,
where all the 500 grams babies are put in zero separation KMC, and the mortality and the infection rate is very low, according to Sashivani, the mother of KMC.
So finally, it's my humble suggestion not to stick on the design or MNC. So it's a
sir, because of lack of time, can we?
So finally, we have to make a standard operating procedure and adapt the technology. These are the 2 words we have to incorporate during our NICK.
Thank you so much. I think a lot can be discussed, but for want of time, we are concluding here. I really thank my panelists to have enlightened on this topic. Thank you so much, sir. And ma'am.
Thank you for the nice discussion, sir. I request the panelists to please felicitate the moderator and sir. Yes, sir. Moderator to felicitate this panelists. And next we have panel molecules in motion, multi-omic signatures of neonatal sepsis. For this panel, I invite Dr. Ashok Kumar to moderate the session. And panelists for this session are Dr. Ashok Rai, Dr. Sanjay K. Ghorpade, Dr. Ravi Khanna, Dr. Anish Pillai, Dr. Sunil Gavane. Sir, I request you all be seated on the stage, sir. Our moderator, Professor Ashok Kumar, sir is former head, Dean Research and Dean Academics, Faculty of Medicine, BHU. He is FNNF, FIAP, FAMS, Commonwealth Fellowship UK, ICMR Fellowship.
I think that's all. No issues.
Thank you, sir.
Right. So may I request my panelists? So very good evening. I find very thin attendance. And what comes to your mind when you think of this topic, multi-omics? May I ask the audience? Something exotic, new, probably futuristic. So to discuss this topic, we have a panel of experts. First is Dr. Anish Pillai, who is a very renowned neonatologist from Mumbai. A lot of papers and awards to his credit. Dr. Sanjay Ghorpade, again a very eminent neonatologist from Satara, Maharashtra. Dr. Sunil Gavane, again a renowned neonatologist from this Aurangabad, now it's known as Sambhaji Nagar. There was a fifth panelist, Dr. Ashok Rai from Varanasi, but he became a casualty of Indigo issues. In any case, my panelists were very happy to take up his questions. And we have Dr. Ravi Khanna from Bareilly. He is operating a level 3 neonatal intensive care unit in the heart of UP. So very expert people who will be talking on this exotic topic. I bring you greetings from my parent institute, Banaras Hindu University, and the Holy River Ganges and the holy city, Varanasi. So if you look at neonatal sepsis, essentially, fundamentally, the management has not changed in the last 5 decades. We have used one-size-fits-all approach, antibiotics and supportive care. And this is in contrast to, let's say, autoimmune disorders like rheumatoid arthritis or SLE, where we understand the molecular pathobiological mechanisms. We have biologicals and cell-based therapies, including the field of cancer, which have revolutionized the management of these conditions, but not in case of neonatal sepsis, where morbidity and mortality remain high. If you look at the definition of sepsis as per Surviving Sepsis Campaign 3, It is a life-threatening organ dysfunction due to dysregulated host response. This is the most important part, which I am going to focus. Due to infection. So we have taken care of infection, be it diagnostic or be it treatment with antibiotics. Not much effort has been paid to understand the dysregulated host response to infection, which is fundamental to the definition of sepsis or septic shock for that matter. Over the last 1 to 2 decades, there's the emergence of newer technologies like artificial intelligence, machine learning, computer engineering. There is a fusion of biology with mathematics, physics, chemistry, we have spectroscopy, next generation sequencing. So this has propelled this field to a level that it is getting noticed by the clinicians. And we are hoping that probably multi-omics will deliver us from the perils of neonatal sepsis. So the whole intent of multi-omics is to have a deep understanding of the pathobiology of the sepsis, to understand, to unravel the molecular mechanisms of sepsis so that we can design molecular-based therapies and we could alter the outcome. We can go for early diagnosis, we can go for prevention and all those things. So now the stage is set. Well, it's not like kaun banega crorepati. There are no rewards, but my expert panelists are there, and I'm sure they will be more than happy to answer the questions. So the first question goes to Dr. Anish. So, sir, your question is, what is multi-omics and what do you understand by it?
So multi-omics, as the name suggests, is an integration of multiple biological data layers. We have heard individually about proteomics, genomics, metabolomics. Multi-omics is a newer concept where they will integrate all of these to give a uniform or a final result. Just like in meta-analysis, you have pooled analysis. You can think of multi-omics as a final result of many individual omics. So genomics, there is DNA variation and susceptibility that can be studied. Transcriptomics, where RNA, everything related to mRNA, gene expression changes will be studied. Proteomics is the protein which is produced, so all the cytokines comes in that. Metabolomics, which is picked up by mass spectroscopy, metabolic fingerprints. Epigenomics, where methylation, gene regulation, so anything around the gene, and immunomics. So you can think of multi-omics as a integrated result of all these individual omics that we discussed.
Okay, so thank you, Anish. So now you understand the meaning of multi-omics. So these are different omics which are now integrated. And once we use this integrated approach, we make a deep dive into the pathobiology of sepsis. So let's see what happens next. So you have.
So this is just the methods of multi-omics. So hybridization methods, amplification methods. We learn about this separately, but combined they are all called as multi-omics.
Okay, thank you. So the next question, what is the scope and the relevance of multi-omics in neonatal sepsis? Dr. Sanjay.
Yeah, sepsis is one of the important area where early diagnosis is a very important part. And whatever the conventional methods, what we are doing in our day-to-day practice, CRP, PCT and all, CRP takes more than 48 hours, PCT takes more than 24 hours. So early diagnosis that within hours, that is the most important to detect that what is the bug and what antibiotic I should write. Because that is the most important part. That's why accurate diagnosis early. Second thing, whether it is infective or inflammatory. You know that CRP is a quite fuzzy marker where it can be increased in infectious process as well as inflammatory process. Again, a bacterial versus virus. All these is not been pinpointed with the previous biomarkers what we are using in day-to-day practice. That's why whenever we are using the antibiotics, that majority time we are going on the empirical basis, and there is the emergence of antimicrobial resistance. So these multi-omics, that is transcriptomics and proteomics signatures, they will rise in quite early within the 12 hours to within the 48 hours, and that will be easy for early diagnosis of sepsis, early use of the proper antibiotics. These are the two important aspects about that.
Okay, so thank you very much. Dr. Sunil, so how do proteomic profiles change in neonatal sepsis and what biomarkers can be identified?
Okay, thank you, sir. Basically, as Anish sir and Sanjay sir were discussing, and as you said, sir, this is a new, actually, sort of emerging or promising field wherein we can't we don't have the biomarkers which are very sensitive and which have negative predictive value, which we want as ideal biomarker. Now, to support or to complement that, see, this omics, what we're discussing is not replacing anything. What we are doing, it's continuing, but these is in addition to the one which we are using, but they are not helping us to diagnose in time, or can we predict? Like proteomics. Proteomics is basically what we are going to do here in fetus, newborn, or in late newborn period also, if they are going to develop sepsis, what biophysiological changes which occurs in the body, and from that genomics, the transcriptions happen, translation happens, some proteins are produced because body goes in a state of sort of catabolic stage, down regulation of metabolism. So all this happens, and some amino acids or peptides or proteins which are produced, and the one which are useful for us before CRP rises, before cultures come positive, before baby becomes septic. If we can identify these proteins of interest, analyze them, and we choose from them which are going to be useful for us, like in the fetus, in amniotic fluid, in the umbilical cord, in the newborn, you can do that, and they have good sensitivity. Right now, this field is like proteomics, analyzing the proteins. It looks easy. Availability is an issue. A lot of things we'll discuss, but they can help these proteins. Like simple, like CRP is a protein, S3, defensin in the amniotic fluid, haptoglobulins. So these proteins are going to help us to diagnose sepsis, even if the other markers are negative, and the baby which is going to develop sepsis later, even though we can predict outcome, preterm delivery, long-term outcomes also based on, and we will have data. We can cutoffs, we'll have cutoffs. Like right now, we don't have specific things to cutoffs, but it's evolving and it's going to help us a lot.
Okay, so thank you. So basically, proteomics follows the central dogma of biology. The information flows from DNA to RNA to proteins. So proteomics is you characterize the proteins, their interactions, their functions, and then you try to find out what proteins, molecules can be used in diagnosis or prognostication. This is already done, I think. Yeah. The next question, how can multi-omic approaches identify novel therapeutic targets for neonatal sepsis? Dr. Ravi, this is a very, very challenging question because all clinicians want a newer therapeutics other than antibiotics and routine supportive care. So is it really possible to identify?
So what we have is how to simplify the whole thing. So I'm in practice since last 35 years. For me, it's simplification is the answer. So genomics tells us...
Simplify it in the simple words.
In a very simple word. Everybody can understand. Genomics tells us about genes and all DNA variations. Transcriptomics shows which genes are active through RNA. Proteomics looks at all the proteins, the real work happening in the cells. Epigenomics tells us how genes are switched on and switched off by the environment, nutrition, and other factors. And multiomics bring it all together. So it is precision medicine, and as Sir said, one shoe fits all approach versus a precision medicine approach. So can I have the next one, sir? Next slide, please. So we collect genes, we collect proteins, we collect chemicals and gut bacteria data from the same newborn. This gives a full biological picture instead of one test at one time. Each type of data shows a different part of sepsis, risk, inflammation, energy failure, dysbiosis, and the actions can be taken accordingly. Okay. Next, please. When all layers are combined, computer models find key changes driving the illness. These key drivers are the most useful places to aim treatments. If a driver can be changed by medicine, it becomes a new therapeutic target. Baby sepsis may have different biological patterns, so one drug will not fit all. And we have all felt the pain of losing a premature baby, of a sick baby, all due to only one thing, sepsis. So somehow, somewhere, if the prediction is here before 24 hours, that thing is going to happen, then measures can be taken well in time. That is what multi-immunity is about.
Okay.
Thank you, sir.
So it will take a long time for the researchers to find out the molecular pathways and then the molecular targets. But it's an active area of research, and I'm sure in coming years, we are going to have a newer molecules like what has happened in autoimmune disorders on cancer chemotherapy. So
they have
been able to
designed
answer this question.
precise endotype therapy safer for all newborns.
Yeah.
It also helps develop new drugs, biologics, prebiotics, and metabolic support systems. Overall, multiomics create a map of sepsis, guiding more accurate and personalized treatment. Thank you.
Thank you. So, Dr. Anish, what are the key transcriptomic signatures associated with neonatal sepsis and how they can be utilized for making diagnosis of neonatal sepsis?
So from clinically relevant picture, this is one of the least advanced modes. So this transcriptomics means everything around, mRNA and its products. Next slide. So it can be upregulated genes and downregulated genes. As we know, during inflammation, your interferon toll-like receptor pathways will be upregulated, so elevated. Neutrophil activation happens and inflammation happens. So interleukins, CX, CL8, all these cytokines are surged. And downregulated genes are the ones of adaptive immunity. So these are downregulated. So when they study transcriptomics, upregulation of inflammatory factors and downregulation of immune factors can thereby be combined like a clinical panel. So there could be a 52 gene panel or 11 gene panel. So these panels are already come under research where it gives us more specificity in terms of infection versus inflammation.
Okay, so this was an interesting discussion. Until now, we have treated sepsis as a one single entity, but there are different subphenotypes, or what people call endotypes. Endotype is intermediate between genotype and phenotype. So multiomics is going to unravel those endotypes, and based on the endotype, probably then we will be designing diagnostics and therapeutics. The next question to Dr. Sanjay: what are the potential biomarkers for neonatal sepsis identified through multiomic approaches?
So my first question is why actually multiomics approaches definitely to differentiate between inflammation and infection, where that is always confusion. About the first part, that transcriptomics already been discussed by the Anish. About second part, that proteomics, what it contains. Of course, the conventional markers, CRP, procalcitonin, and presepsin, that is in day-to-day practice we are doing, definitely depends upon the severity and specificity. Already we know about that. The second marker, that resistin, and then serum amyloid A, and third, that angel. Angel is specific for the renal marker because that is increasing quite early as compared to the creatinine, because creatinine took almost 24 hours to increase. About metabolomics, yes, lactate we are using in day-to-day practice. Absolutely, what the lactate suggests that the severity of the disease, and it will detect about the prognosis of disease. So whenever using all these things, yes, we also track the response to the therapies, and it should be in used in the combination. That's a term we are using as a multiomics.
Okay, so in a nutshell, how the host is responding to infection. So how that dysregulated host response can be captured by multiomics through either through proteomics or metabolomics or through transcriptomics. Clinically, I think you have already mentioned, right?
This already we have discussed that basically upper part, that CRP, PCT, lactate, and presepsin we are using in day-to-day practice. Angel nowadays that is used in India, but rest of the parameter set is not regularly used done in the Indian setups till now. That is being, I think, in research purpose whenever we are taking our Indian scenario. But in the future, this will be the revolutionary markers in the day-to-day practice.
Thank you. So next question, Dr. Sunil. What are the potential implications of multiomic approaches in neonatal sepsis prevention? Prevention is very, very important, especially in the era of multi-drug resistant antibiotics. Hardly anything to the babies can be treated. Hardly any choice is left with us, right? So can multiomic be used to prevent sepsis?
It's a promising field. Just to right away, if I say it's going to help us to prevention, it will be too premature, because whatever the data we have about multi-omics, transcriptomics, proteomics, metabolomics, genomics, microbiome, all these things are studied. They will be analyzed, and that we call it as a multi-omics. Prevention in the sense, what we want to know, either anticipate sepsis, which baby is going to develop sepsis with the help of multiomics, or those who are baby who are septic before they develop clinical signs, can this help us? Or can they help us in treatment, antibiotic stewardship, identifying the bacteria, gram negative, gram positive, severity of the disease? What are the data we right now we have from the fetus, from mothers also blood? Right now it's something which is studied at a large scale, but at a research oriented purpose, because these things are not available in public domain everywhere. Not all laboratories are doing this process. So maternal blood or fetal blood, something defensing, cancaroline, all these are proteins which are studied. Metabolites are studied in the fetus, and those babies were followed up. Out of that, which came culture positive or developed sepsis. Similarly, in the cord also it was studied. Like lipoprotein B, CRPs, these they are more sensitive than the IL-6. These are multiomics if you are using in a cord, and even the infants or early infants, first 3 days or after 7 days, in early or late onset sepsis, also these metabolic, like lactate we just now discussed, glucose we discussed, amino acids, phenylalanine, leucine, these are amino acid. If as a part of multi-omic study, if you do early, they have quite a good sensitivity where your cultures comes negative. They have quite a good sensitivity where the lab markers are still negative. So these are the way which are going to help us to identify which fetus, which newborn at day 1, which newborn at day 4, 5, where there's no signs and symptoms still are going to develop sepsis. Because we all know these are the markers, we CRP, all these marker cultures come so many times becomes negative because a lot of factors are there. Apart from this identification of the babies who are at risk, which are going to develop sepsis, these are the markers, they changes with the time. This like profiling of proteomic, genomic changes with the bacteria, with the time, with the severity of the disease, and the value change. That can help us to prognosticate, tailor the treatment, even with the genomic transcription, all these things we can identify background which antibiotic is going to help us.
We have a question on prognosis.
Yes, so that's how it's going to help to prevent or anticipate the sepsis.
Yeah. Okay, thank you. Thank you very much. So Dr. Ravi, can multi-omics data be used to predict the outcome for neonatal sepsis?
Yes.
So when a baby is septic, we want to see whether the baby improves or doesn't improve. The parents want to know what will be the fate of the baby 2 or 3 or 4 days later. So can you use this information, big data, to predict the outcome of neonatal sepsis?
Definitely, it can be done, and that is what the things of the future, near future is, not a future very far off. So they collect the genes, the proteins, the metabolites, and the microbiota of the same newborn. When these layers are combined, they show how severe the illness, at least even before the clinical signs appear. See, one should not lose a baby out of sepsis because we are not able to predict it. The computer model.
now to jump immediately at least, and this is going to, it's a promising, as I said, we know we are searching for the molecule which are actually more helpful to like early detection and treatment of sepsis. But this is again a evolving process. And now the one which I've used, like genomic is there, which I've used for India. Can it be applicable for the other countries? Because everything changes. Microbiome changes, genomic changes, proteomic changes. These profiles are different for different community, different ethnicity, different persons. So if I have to apply it, or like external validity, what we can say, what these studies are there. So their external validity also, we are not sure about external validities also.
So that brings us to the challenge of generating local data.
Right.
Yeah.
Yes.
Because the people can react differently. The newborn babies in this part of the world can have a different kind of multi-omic profile compared to what we have the
Exactly.
Caucasian newborn babies or African newborn babies. So a lot of research needs to be undertaken at the, the researcher level.
So,
Only
sir,
then
so
probably
next-
we will be able to understand it. Yes.
So these are the things like
that was the thing. Yes.
right now we have a limited data, no prospective RCTs on multiomics. What are the data we have? Code studies, maximum good studies are retrospective data. Heterogeneity, as I said, ethnicity, heterogeneity, lack of standardization. These processes are like endotype uncertainty, no like workflow integrations are there, regulatory barriers. Now, these are like ethicals, legal issues are also are cropping up because of this, because you're using genetics, genomics, how we are preserving that. So that also is there. So cost and infrastructure, again, it's we are going to discuss in the next slide, but that is a major hindrance right now to generalize it, where it maximum is going to be utilized in the tertiary care area or government setups, where the cost will be going to be a major issue. So these are the main challenges
Thank
when
you.
we are
Thank you.
discussing.
You have highlighted the major challenges, be it at the sample size, heterogeneity, endotype uncertainty, and there are many ethical and regulatory issues also. When so much of genetic information about the individual becomes available in the public sector, there's going to raise many ethical issues. So, Dr. Sanjay, how can multi-omics data be used to promote antibiotic stewardship? We always talk about restricting antibiotics use.
Yeah, that is the main crux of this discussion today, because why we are interested in this part of the multiomics. Definitely advanced tests like the MNGS, of course, that will detect the pathogen, especially whether it is a virus, fungus, and empirical use of the broad spectrum antibiotics will be avoided, number one. Number two, high negativity value. See, if it is a negative, it rules out that there is an infection, and unnecessary overuse of antibiotics will be avoided. Third, a rapid detection of time. You know that whatever the older methods, culture will take to 72 hours, CRP and PCT will take a little more time. So early detection, whether it is infection or inflammation, number two. Number three, what a possible bug is. And number four, accordingly, the use of the narrowest spectrum of the antibiotic that will, of course, prevent the development of the drug resistance, and that will avoid the killing of the normal flora, which is not been required in the day-to-day practice. And definitely the last part, to distinguish the colonization from the invasive infection. Many times actually colonies are treated as the true organisms, and unnecessary use of the antibiotics that is been done by the many of the neonatologists or a clinician or pediatricians, that will be avoided, and that will be the base for strengthening the antimicrobial stewardship program. And of course that will avoid the further development of the antimicrobial resistance. And of course that is the most important part.
So we see a potential use of multi-omics in antibiotic stewardship. In fact, the technology is advancing so fast. You look at next generation sequencing. If you look at the original Human Genome Project, it took us 13 years to unravel the mystery of complete human genome. Now the human genome can be done away with in less than 5 hours. That is the power. That's why it's also called massively parallel sequencing or next generation sequencing. And when you combine all these newer technologies with bioinformatics, with artificial intelligence, I'm sure good things are going to come, but we have to wait for some time more. Okay. So Dr. Sunil, can you tell us the availability of and cost of multi-omics approaches in present era? Was it available and likely cost?
Yes, it's a very limited availability, as I said. But the good thing is, like nowadays, a lot of, as sir was saying that genome projects, like med genome projects, the government is actually funding. ICMR is also funding. Like Department of Biotechnology, they are funding these products, and there are central institutes who are actually analyzing the data. Collection centers are many, but there are very few, 8 to 10 centers who are analyzing these data, and that like Mumbai is there, sorry, Pune is there, Delhi is there, Bangalore is there. And these are Kolkata is there. So Institute of Biotechnology and Research Centers, they are doing these things. So very few centers right now are analyzing this data. Collections you can do collect at anywhere, but analyzing. The major problem is cost. Cost wise, if you see genomic studies, it can vary from private sector, from basic like genetic workup study from 3,000, it can go up to lakhs. If you want to see evaluate a exome, whole exome sequencing up to part of transcriptomics or protein metabolism or genomic, it can vary from 20,000. And if you are do multi-layers in detail analysis goes to 1 lakhs up to 1 lakhs. Right now for public purpose, these are not free. But for research purpose, if you
as I understand, the whole exome sequencing around 15,000 rupees.
15,000
for the government
15 to 20,000 government.
Maybe
Yeah,
private
15,000.
maybe 5,000
Private may
extra.
go up little bit, but government 15 to 20,000.
If you are doing clinical exome sequencing or targeted, then
It goes little higher.
Yeah, okay.
So that is one thing. Other challenges is there having this data, and as the sir was saying, bioinformatics, like it requires high-end computing. Analysis needs a very expert analyzers, because out of this, the whole genome, the genes or proteins of interest we have to analyze, and the processing also, and then interpreting it and then applying it to the community at large. It is going to take manpower, infrastructure, apart from the cost also. So yes, definitely promising as said, but there are limitations. Government have institutes which are doing on this. It may come in a large way. But remember one thing, this is going to help us. This is going to add to our information. It is not replacing our clinical or the existing knowledge, but with a bit short, it's not going to replace the clinical things acumen. We have to use this
So this is
as an
an
addition.
important point. Multiomics should be used as an adjunct to our management, the clinical management. And that also includes our old test, blood culture, which we must optimize. But here we are discussing multiomics. Okay. So you have already, I think this costs a little bit more. I think.
Yes.
Right.
Right. This is actually done.
There's a pneumonia panel is
Panels. They seem like part of pneumonias. We are doing to just genetic microarrays are there. Some peptides are there. We are detecting from this bacteria. So samples can be any biofluids. If your blood, urine, skin samples, these are going to help us. So sampling will not be issue in a multiomics will need hardly any sample, a very small, microliter sample, ml required. So that is a good thing, and we can add in one go. We can detect which is the bacteria, which is the fungus, which is the bacteroids. So everything can be detected, which can't be detected. Even blood culture also most of the time.
But one of the problems with big data is sometimes you get information on which you do not know what to do. That's one of the biggest problem. Right.
That's why the false interpretation.
We have to make sure when we use this.
False interpretation must be that should be identified.
Ravi, what is the scope of multi-omics in neonatal medicine beyond sepsis? So we talked of sepsis. Are there any uses other than
Yes, there are
neonatal
definitely
sepsis
other
in
uses.
newborn babies?
Thank you for the question. So early diagnosis without imaging, metabolites plus proteins detect disease before clinical symptoms, personalized fortification metabolics guides individual nutrient supplementation for the preterms, risk stratification for essential molecular markers, identify newborns needing closer follow-ups, early interventions, clodomics plus tele-NICU. Remote analysis from the higher center can tell us as you send a sample digitally. And so next, and we can also have neutral immune mediated disorders, BPD, HIA, neutral brain injury, neutral metabolic disorders, metal fetal multimeals for preterm babies, drug response और pharmacogenetics. We may think कि आज मुश्किल लगता है, पर मन में है विश्वास, पूरा है विश्वास, हम जल्दी होंगे कामयाब एक दिन. That is what is going to be. Who have thought कि it will be so easy to, अब AI आने के बाद क्या बचा? What is remain? It's only application. So there is not far off where multimedia will be the in thing and easily for all the small centers and small cities.
So my only concern is we have too much of information, and I don't know how much of it will be average clinician will be able to digest. and imbibe and act upon it. So there are many unknowns.
Curling is it?
Yes, yeah, right. So, Dr. Anish, so can you summarize the current limitations of traditional diagnostic methods for neonatal sepsis, and how can multi-omic approaches address these limit? We have already discussed some of these, but still, I think for the benefit of the audience, and we still have some time. Okay.
So this is like a very practical summary slide
Yep,
from the
yes.
full, take home from the discussion.
Even for
today.
those people who were sleeping till now, I think you can now get up and listen to this slide. It will be wonderful.
So the traditional test like blood cultures are slow and they are insensitive. We know that culture positivity rate can only be, 10 to 30%. So multinomic solution can be the mNGS, microbial cell-free DNA, host pathogen integration. The biomarkers are non-specific currently, CRP, PCT with low sensitivity. So a multi-marker, multi-omic RNA protein metabolite panel, like I showed in some research, 52 panel, 11 gene panel, they can be much more specific. Clinical signs often occur late. And by the time the baby or premature baby has already deteriorated. So early pickup, even before symptoms start. So we are talking one step ahead, just like how we do IEM screening, metabolic screening, before the symptom starts, this will pick up sepsis. So that is the whole, goal for the future. Currently, we don't have insight to the immune state, whether the child is immunodeficient, hyperinflammatory to give, we think whether to give steroid, IVIG, what medication to give. So this endotype immune state, it will give us insight for each baby. So we can personalize the therapy. Not able to distinguish colonization from true infection. So again, this will host pathogen model. So it will pick up and also see the host response. So we know that it is not a colonizer, but actually causing problems to the baby. And it will definitely prevent antibiotic overuse. We had a full slide on the antibiotic stewardship.
Thank you very much.
So all these things
Yeah.
are there for the future.
So this is the last slide. We still have 5 minutes. So I will conclude.
NICU, all the weights are captured, and these are the outpatients clinic. I'm not plotting anything. I just the nurse enters the weight, head circumference, and the length, whatever.
How we use in our unit, we do use it in our unit when we have a child who's been on the high frequency or ventilation for a long time on fentanyl infusion or midazolam infusion for a long time. What we do is we tend to put them on dexmedetomidine and then for a day and we extubate. So certainly it gives
Dr. Pratik Bandya, Dr. Brajendra Singh, Dr. Devendra Dangar, Dr. Screen. Timing is everything. National faculty and clear your doubts.
50 or 50, we will end up with something.
इतना नहीं जाएगा. Now AI is doing wonder.
Maybe I'm an old man, so I am a little bit hesitating, but that's fine.
Sir, within next 4 to 5 years.
For your patient attention, thank you. If there are any comments from the audience, my panelists would be very happy to respond.
So within next to 4 to 5 years, it will, within next to 4 to 5 years, definitely multi-omics will maybe the bedside industry, what you are telling about. AI did a lot of revolution in the...
Cut short the whole process. So when Neil Armstrong stepped on the moon,
Any comments from the audience? Please come up. नहीं तो एक रवि यहाँ है, दूसरा रवि यहाँ है. रवि बोलो यार. I think कुछ interaction or maybe organizer. Should I close or?
Yes, sir.
Please.
I think
unless you have an interaction with the audience.
and that is a optimum utilization of technology. So that is really futuristic, sir. Your talk was really very futuristic, and I think, yeah,
and their views.
Yes, of course, sir.
Mediator, just question here and there.
Of course.
Yeah.
Your moderation was very good. And the panelists, of course, they have represented their express opinion. Absolutely, they were. I think we are very much, getting newer insight about these, the futuristic of proteomics and genomics. Thank you so much.
Thank you. Thank you very much.
Thanks. The 3 cheers to you. You gave us a lot of time to speak.
Thank you, sir. Thanks a lot for the nice discussion. Now I request panelists to please felicitate the moderator and moderate to please facilitate. Please felicitate the speakers. We have a panel next. So the panel is a tapestry of care, weaving quality into neonatal initiatives. To moderate the session, I invite Dr. Ravi Sajan, sir, and panelists are Dr. Satvik Bansal, Dr. Dheeraj Divakar, Dr. Santosh Kumar. Sir, please. Dr. Ravi Sajan, sir, is Professor and Division of Neonatology. He is currently affiliated to UCMS and GTB Hospital, Delhi, Central Health Services, Ministry of Health and Family Welfare, Government of India. He has multiple achievements. Thank you, sir. I request moderators sir to kindly introduce speakers. Kindly introduce panelists.
Slide changer. Slide changer. Slide changer. Forward. It's not working. Okay. So thank you for organizers for inviting me. So I think there's going to be a huge transition from futuristic means talk with Dr. Ashok sir, and now we will be talking about little bit what is the present we are dealing with. So we will talking with the discussion. We'll just start with the our discussion is the tapestry of care, weaving the quality of neonatal initiative. Right. So how the quality improvement is works on the ground. Right. What does it mean, the tapestry of care? So what we are taking care of the day-to-day practice in our newborn, right from the early initiation of breastfeeding to the skin-to-skin contacts, or from the recent advances with the highest quality of care. So that actually, once we are, got these clubbing these all essential newborn care practices, and then we are weaving all these quality of care, and that becomes a tapestry of whole care, what we call in other perspective is the bundle of care. Right. So we'll be discussing about a little bit tapestry of care. So very with some background of the quality improvement, the Professor Peter Decker has said, he's a very great economist, and said that if you can't measure it, you can't improve it. So therefore, if you want to improve something, you need to have as a basic parameters, and that which are measurable. All right. You must be knowing that nowadays neonatal resuscitation 8th edition, the American Academy of Pediatrics has incorporated the quality improvement in every care. The Government of India program Laksh is very much example for this, and the WHO has come out with a strong quality improvement, parameters and the quality improvements indicator for pregnant women during pregnancy, childbirth, and later on postnatal period. And and all these things are based on the simple point of care quality improvement initiative, right? So these are the just nothing, just a common sense practice. So these are the 4 steps of quality improvement: and identify problem, analyze, develop, and work for the sustenance of the quality improvement. As we all know that NFHS 6 data it says that the number of deliveries taking place in our hospital as far as the urban area is concerned is more than 90. It is around 95%. That means the patient is now coming to the facility, but he or she is not getting the appropriate treatment of quality of care. That means if your what we are the utilization of patient care services, if you are not able to club with the quality, and the quality of care, if it is zero, then ultimately healthcare system, what we are delivering to the baby or what we are delivering to the patient care is going to be the zero, or the quality of care is going to be lesser, right? So what is QI? QI is nothing. It's just a common sense. It is doing the right things to doing things right, right? And this is just a what we call the quality improvement is a connecting link between the last mile connectivity from the protocols to the the court side implementation of evidence-based practices. That's all. So and this is for generalist understanding. These are divided into the outcome, process, and structure, what is called donor obedience trial. And with this, I invite our esteemed panelists. Uh, One is Dr. Santosh Kumar Karaleti. He is one of the public health expert and probably associated with around more than 2.5 decades, the experts in the public sector. And another is Dr. Dheeraj Divakar. He's MD Pediatrics, Dermatology, and Director and Head of the Neonatal Unit, Radiant Children's Hospital, Udaipur, Rajasthan. And Dr. Satvik Bansal is Associate Professor, Department of Pediatrics, Gajra Raja Medical College, Gwalior, and he is working in various capacities at the state level and the central level in NNF organization. So with this background, may I ask Dr. Satvik Bansal, so what does the quality of neonatal care means to you in a day-to-day care practices in our neonatal unit?
Thank you, sir. Thank you, sir, for this question, because so many frameworks and everything you have told, but what is quality improvement or what is quality of care? It is very, very simple. It is just about not about doing extraordinary things, but doing normal, ordinary things repeatedly, reliably, and with consistency. मतलब साधारण भाषा में ये कि if a baby comes to me at 3 a.m. in the morning on a Sunday morning, or a preterm baby or a term baby comes to me at 10 a.m. on a Monday morning, both the times the care that is being given to that baby is evidence-based, reliable, and repeatable. And this is what quality neonatal care is. That is, you develop such a system, that system is not dependent on staff, on shift, on workload, but it goes on, keep on giving, as sir said, small things rightly and correctly. That's all. So another important thing is about quality is prevention first. Again, it is not about some very glamorous treatment strategy or anything of that sort. It is about preventing infections by using various models, preventing hypothermia in delivery room and on NICU admissions, and all these things. Starting early initiation of breastfeeding, or starting early skin to skin care, working on your antibiotic exposure. All these things can lead to avoidable complications and in turn better outcomes, and much more than probably doing some extraordinary thing in treatment later on after the baby has succumbed to a complication. Next, using data for small improvements. आप अपने नर्सिंग स्टाफ को और अपने रेजिडेंट्स को नहीं समझा सकते. आप कितना भी उनको लेक्चर्स देंगे, they will not get to know what the current picture is. But if you will just keep on showing the run charts to them every week, they will start owning that process. They will start getting the improvements, taking that step or taking that leap forward towards improving breastfeeding, towards improving hypothermia on admission. It is quality of neonatal care is also about family-centered care. We need to involve parents. We need to involve mother. This will improve the bonding. This will improve how we are communicating with the parents, and it will also lead to better outcomes. We all know that NICU is a culture of empathy, and therefore all these things come into play.
So that means what the Dr. Satvik Bansal is trying to communicate, that we need to decreases or the lessen the variable of practices. It doesn't mean whether the the morning shift or night shift, there is a different kind of, the services is being provided to the newborn. It should not be like that. So that means we have to develop a system like this where the variable of practices should not be there. It should be a uniform quality of care. And they are the very small thing. So next, Dr. Dheeraj, can you please a little bit elaborate about what is one of the practical, low cost intervention you have implemented and that has got a miserable outcome in your neonatal practice?
Thank you. Thank you, sir, for the questions. Very well elaborated by Dr. Satvik about the quality. That irrespective of the time of the day, irrespective, and our protocol-based, evidence-based practices should be continued. So as far as low-cost interventions are concerned, there are so many low-cost interventions, but some of them which has really measurable impact on the outcome are, one of them is thermoregulation bundle, strictly monitored thermoregulation bundles. So during our NRPs, it is a routine, talk that when you are attending any delivery call, first thing you should do that the temperature of the labor room or OT should be adequate. So any extra source of air current, like any open window or anything, any AC running above the radiant warmer, these things should be taken care of promptly, because it takes seconds for a newborn to get cold.
Yeah.
And
hypothermia.
very rapidly it goes into hypothermia. So,
Exactly.
so it start right from the delivery. Even before delivery, our preparation should be such that a baby, when it comes out of mother's womb, as the baby is wet and there is much heat loss through evaporation. So immediately after drying the baby, putting in the radiant warmer, and now the newer concept is that after immediately baby is to be put on the mother's skin to skin contact, mother's abdomen. So that thing and all the component of warm chain should be maintained. If the baby requires admission to the NICU, so right from the labor room or delivery room, transport to the NICU, it should be that temperature should be meticulously maintained. Like preemies, VLBW babies are there. So they can be wrapped. If in Apex centers there are transport incubators are there. So temperature can be taken care of, and in the low resource limited settings. So what we can do, plastic wraps are available. So we can cover the baby and then we can transport the baby so that we can maintain the warm chain. Because there are so many observational studies which has shown that admission temperature to the NICU has that is very important. Admission hypothermia at the time of admissions have adversely affect the outcome of the babies.
Exactly.
There are so many short-term, like increased risk of RDS, sepsis, pulmonary hypertension is there.
Definitely.
Some studies are going on which shows that even long-term outcome also is affected, though we do not have much evidence on the long-term outcome, but short-term outcome definitely are associated with the admission temperature. So thermoregulation, proper thermoregulation is very important. Sometimes like embrace also are available. We can put the baby in embrace and can also be transported. Some other low cost interventions are there, like CLEPSI bundles. All these ELBWs, they stay for a longer period in the NICUs. So they require central lines like UVC, sometimes arterial lines and your PIC lines also. So these are double-edged sword. So we cannot just put a line and forget it.
Yes.
It requires prompt care.
Regular care.
At every point,
Yes.
from the insertion to the removal of the line. So web preventing bundle, the moment you put the endotracheal tube, you should start thinking when we can take it out. Similarly, while putting these central lines, these require enormous monitoring, strict monitoring. And whenever there is no requirement, we should take it out. Proper insertion, following all the insertion bundles, all the checklist, and then daily, day to day, like your insertion site, that monitoring of insertion site, whether there is any arrhythmia or induration, or the dressing is getting that dirty, or that timely changing of the dressings. And sometimes we have to do audits. If there is unexpected high infection rate in the unit, or suddenly some surge in the infection, then periodic interval audits also are required. Then
Okay.
it can be done by nurses.
Okay.
And those people who are being audited should not be aware that they are being audited. And there should be healthy discussions after the audit results.
Of course.
So these are the low-cost intervention. And KMC, I think much has been spoken about KMC. There
Yes,
are
yes, of course.
conferences about the KMC.
Of course.
Multimodal advantages. Like doing KMC is such a low-cost intervention. It decreases the time of discharge, length of hospital stay. The baby achieves the birth weight rapidly, thermoregulations, early breastfeeding, these are advantages, as well as that parental bonding, mother and infant bonding. So these are some low-cost intervention that have, these all have significant impact on the outcome and measurable impact on the outcome.
So thanks, Dr. Dheeraj, for elaborating. So in nutshell, what Dr. Dheeraj is trying to elaborate that there are at least no cost. The maintaining a temperature at the delivery room, it requires no cost. Just a small plastic wrap or during maintaining a temperature during transport or just providing a KMC, it can impact neonatal outcome in a significant way. So therefore, the very small intervention, they do not require at all any cost. They just require a counseling. That's all. So it can have a significant impact on neonatal outcome. So next is Dr. Santosh. You have got so much of experience in the public health. So what is the sustainability of the quality improvement? Do you think it is easy? It is easy to take up the issue and for a quality improvement project, it's so significant improvement. But at the end of the 1 month or 6 month later on, the people start getting low, and their outcome indicators getting lower down. So because you have got so much experience in the public health, can you just give some message to our audience? What it makes the sustain for these small intervention?
Yeah. Thank you, Dr. Ravi. And thank you, Neocon, for having me here. One of the important things to make any of these QI, I would say experiments or whatever we start studies, some of these pilots sustainable, is ensuring that once the study is over, having the team publish this, whatever is there, document it and ensure that it becomes a part of the protocol in the system. Until and unless it becomes a part of the SOP, then you would not be able to make it a sustainable.
Exactly.
And once you make it a protocol, take another QI study. For example, in Andhra Pradesh, where we started QI around 2013 and 14, I was in Arogyashri, a government health insurance program. And there we did a big study on hand hygiene and many other bundles, CLAPSI and many other bundles. This was around 2013-14. And we noticed that out of the 50 newborn intensive care units that we were taking up as a pilot, only 8 had wash basins inside the NICU.
Okay.
So that was the audit. And then we audited hand hygiene, etc., many other things. So the point is, one of the important things to make any QI project successful is have fearlessness in your team.
Exactly.
You have to report the data as it is, and you can pat anyone's back even if the QI indicators show thumbs down. It's fine.
Yeah.
So I think that is one of the most important things, that the team must have confidence, and they have to feel confident that no one is going to punish them.
So therefore, they must have an enabling environment to report that,
Absolutely, absolutely.
Yeah.
And Edward Demings, who's regarded as father of data, he said, "In God we trust, everyone else bring data." And if you don't have data and if you don't measure what's happening, and I think that is the biggest Achilles heel.
Yeah.
So in our NICUs after that, in Andhra Pradesh, we ensured that we have a dashboard, a small
Dashboard
thing outside.
indicator.
And whatever you're measuring, write it. For example, you have 25 babies in your NICU. 14 babies are on mother's own milk. 9 babies are on PDHM. 2 babies are on formula. Fair enough. Can we increase it to mom by another mother tomorrow?
Yeah.
Can we increase the formula feed to PDHM by day after tomorrow? And mom plus PDHM to total mom. probably by day after tomorrow. And until and unless you have a small dashboard with smallest of small indicators, your staff will not understand. And आप उनको बताते रहो कि ये करो वो करो. Instead of that, they themselves can work on what they have to do if they have data in front of their eyes. So leadership must be at their hands. And I would say that doctor, consultant, or staff nurse, plus the mothers, if they can form a team, and I think nothing can be beatable. Even mothers can understand what's happening and they can be a part of your QI study and team, which we did.
Exactly.
For example, 50 days, 40 days, your baby is inside. And you know how much the mother is expressing, how many drops of milk, how many ml of milk, and how she can increase. All of that can be counted, and mother is the best QI team member in your QI study.
Of course.
And it will become sustainable if you develop into SOP. See, plan to study act cycle matures into a SOP. So any QI study matures into SOP, and that's the most sustainable way forward.
So what the Dr. Santosh is trying to say, you have a small improvement and that try to integrate that change ideas into the main your day-to-day routine clinical practices, and that can only be it will be sustained. So whatever the small changes are there, they are hardwiring into the system that become a first and foremost key for the sustained improvement. Thank you so much, Dr. Santosh.
One point.
Yeah.
The QI is not about a new scientific innovation or invention that we're doing.
Yes,
It's
yes,
about
of course.
implementation practice.
Implementation. That is why it is called as a transformational research. So what we have there is no. Everybody is agree. There is a lot of evidence are there. A lot of guidelines are there. A lot of studies are there. But still we are fails to deliver that on the ground. That is the main issue of our and the quality improvement is one of the bridge for the policy into the practice, which is called as quality improvement practices. That's all. Thank you, Santosh, Dr. Santosh, for again, Dr. Satvik Bansal. With the rising preterm birth, you may have seen recently there's an increase in the preterm birth because of lot many infertility treatment are there, and there can be so many risk factor for the premature delivery. So therefore, the premature babies are delivering a lot many in the nursery. So can you please elaborate what are the most 4 important quality improvement indicator in which you would like to track, or you would give some idea about this?
Sir, this question is in itself is a crash course in quality improvement for newborns.
Yeah, exactly.
तो आपने बिल्कुल सागर में गागर या गागर में सागर करा है.
So this is what the crux of the
yes, sir,
the message to the audience have.
Question also.
Yeah.
So if I have to pick 4, I will choose these 4 which are enumerated here. Proportion of newborns who are initiated on SSC and breastfed within 1 hour. Proportion of newborn who received delivery room CPAP. Decrease in the percentage of device-associated infection rates by various bundles, and proportion of neonates on antibiotics. Now you will ask why these 4. So, जो first point है कि this itself, these 4 things talk about 4 different aspects of newborn care. First point will talk about the stabilization. Second point will talk about the respiratory care. The third would talk about prevention of infection, and the last one would talk about antibiotic stewardship, which are the 4 most important pillars, especially in a preterm baby with sepsis. Now, coming to the first point, it is not only about stabilization. When we are initiating SSC and breastfeeding, we are also giving family-centered care. We are increasing the bonding. We are initiating early enteral feeds. So 3-4 initiatives we are keeping into one single point. Regarding delivery room CPAP, now we are specifically talking about preterm births, and delivery room CPAP is the single most important strategy. So if we are ensuring that delivery room CPAP is being given, that means that our unit is running evidence-based in terms of respiratory care. Similarly, when we talk about device-associated infections, this is a little bit underused, but a very high quality indicator for good SNCU practice or NICU practice. Because एक hero resident या एक hero doctor infection नहीं बचाएगा. It will, if your CLABSI bundles or your sepsis is coming down, that means the entire unit is working as one whole and is working in a way which is leading to these improvements. It's a teamwork then. Similarly, when we talk about neonates on antibiotics, this is very much underused, but it is also very, very reflective of your own strategies, of the unit's policy, whether it is fear-driven and not evidence-based, versus whether it is very, very evidence-based. Just we start the antibiotics soon, we end the antibiotics even sooner. We are very pro giving out cultures. So all these things will come into play when we see how many neonates are on antibiotics at a particular time. So if given an option, I will choose these four, but as it is a very overwhelming question, so it can be variable for everyone else.
See, so what Dr. Satvik is trying to say, we must have some, audit, self-audit kind of thing. When you are running your unit, so you must be having idea how many babies are, born, how out of this, suppose 100 babies born, how many babies they are receiving skin-to-skin contact, how many babies they are early initiation of feeding has been started. So you have to have some baseline audit on baseline assessment, and then you can track these, the data, and then how much we have improved since from our baseline data. So therefore, these are just an example. You can devise any kind of quality improvement outcome indicator, like anything. Any process of care can be converted into the quality improvement indicator. Thank you, Dr. Satvik. And next is Dr. Dheeraj. Can you elaborate how can an ICU integrate family-centered care even in a crowded and resource-limited settings?
Yes, this is a very hot topic right now. Family-centered care. This is a healthcare approach that recognizes and supports the key role of families, integral role of families in care of the infants, particularly those who are admitted to the NICU. So this is key concept is that recognizing that families are essential partners in planning, delivering, and evaluation of the care.
Yeah.
And why it is important? Because if we involve family right from the beginning, the bonding and that attachment, that part can be initiated at proper time. And there is zero separation, no separation. Nowadays, we are also going toward the concept of zero separation.
Yeah.
So the IKMC and these MNCU, these are all concepts towards the family-centered care. So these have multiple advantages towards holistic care. What we are trying to provide holistic care. So family-centered care comes there. So what are the advantages of family-centered care? It has advantages for staff, for newborn, for families. For staff, like their work is shared, they have better job satisfaction and better allocation of available resources. For newborn, it decreases the length of hospital stay, better early attainment of birth weight, and similarly lesser rehospitalization rate. Major advantages for the family is that their stress level and tension comes down as soon as they are involved in the care of the baby. And that very important aspect is a 26-weeker spend around 50 to 80 days in NICU. So if you involve the mother right from the beginning, she recognizes all these things what are happening day to day, like what are the bed episodes, what is bradycardia, apnea, desaturation. And some smart mothers are so intelligent that they can differentiate, sir, this was desaturation alone.
Yeah,
this
babies
was
are
not
normal.
apnea.
Yeah, babies
was,
are normal.
Yeah, so we are preparing them for identifying danger signs. We are preparing for smooth transitions
Exactly.
towards discharge.
Definitely.
So some mothers are so intelligent that they can tell, sir, this is motion artifact.
Yes.
Like sometimes desaturations because of the movement of the limbs. So these mother can recognize that, sir, these are the motion artifact. This is because of the movement. No need to worry.
Exactly.
Sometimes they reassure you.
Yes, of course.
So these are the benefits of family-centered care.
Yeah.
So how now the question is how we can integrate. So first thing is during communication with the parents, it start during antenatal periods also. If we have some opportunities to communicate with the parents
Even before
from
the
the
delivery.
even before delivery, during
yeah.
antenatal counselings.
Yeah.
We can emphasize these things, that we will involve you in the care. So like, something gaining confidence.
Yes, of course.
Then, like some visual displays, IEC display on the prominent part of the hospitals in the counseling area where parents used to sit, that also help us increasing awareness about the family-centered care. And like I said, some mothers of ELBW babies who spend lots of time and they are expert, we can use them as leaders. They can mentor others. They can motivate other mothers also.
Yes.
If some parents are hesitant to be involved in the family-centered care, they can motivate other parents also.
Yeah, the mother who's visiting the facility, the one, so the young mother came again, the new admission is there. So they are talking each other and then they are sharing their own experience.
Yeah.
That boosts the confidence and for the next mother to come.
The only thing is, in Indian scenario, what happens, like we are talking of MNCU also. So our purpose is to promote family-centered care. But in Indian scenario, relatives used to visit. When a patient is admitted, relative used to visit. So we have to be careful that this is family-centered care rather than society-centric care.
Okay.
Otherwise, the whole concept of this family-centered care can be diluted, and even we may end up having some adverse effect also. So there, I think we have to be a bit careful.
Okay, so what the Dr. Dheeraj is trying to say, we need to empower the mother with the informed consent and informed decision making. Let the parent decide about and involve the mothers as much as possible in the newborn care, and that has got studies has shown it has got a better uptake in the community care. The mother, they are experienced, they are better able to take care of the baby at home. Thank you so much, Dr. Dheeraj. And the next question is Dr. Santosh. What would you like to say in one innovation, as a clinical or digital that will significantly is going to improve for the next 5 years in neonatal care?
I think the biggest innovation is going to be telemedicine. And this we are already seeing in our hospital, Nilofer Hospital in Hyderabad.
Yeah.
Nilofer happens to be the hub for all the SNCUs of Telangana.
Okay.
And we have around 30 SNCUs. And each SNCU is from here mentored and supported from Nilofer Hospital. And we have a huge telemedicine screen, which is like life size. And then each screen has around 30 sub screens.
Okay.
And then we have 30 desks and laptops and desktops where we communicate with all the SNCUs from the periphery.
That means you have to have a good, strong networking with your handholding.
And we have a very good team, telemedicine,
Exactly.
a pediatrician, neonatologist, and a staff nurse who keep interacting.
Yeah.
The future is going to be telemedicine, probably to the next level as well, probably NBSUs to the newborn stabilization units.
Telemedicine along with some AI, that is going to be the game changer for the coming days to come.
And
okay.
But one thing I would like to also add that there have been some jugaad innovations, especially on the ground, apart from these high-end technologies.
Exactly.
For example, one of our SNCO medical officers, he did a wonderful innovation. Mother has delivered somewhere an upgraded primary health center, and the baby is in the NICU. Every day he has a network with all the Road Transport Corporation. The mother expresses milk and you get in a dabba to the SNCU.
Okay.
Now, this is the actual QI.
Yeah.
See, the implementation science.
Implementation.
आपके पास इंडेंट के लिए पैसा नहीं है कि आप हर बेबी के लिए टोपी खरीद सकें, thermoregulation.
Yeah.
But then he did a jugaad by having the socks. 10 रुपए का पेयर ऑफ सॉक्स खरीदो, उसको काटो, बीच में 4 कैप बन जाएंगे और उस 4 कैप्स मतलब लो रिसोर्स सेटिंग्स में क्या हो सकता है implementation.
Exactly. This is what the quality improvement actually, without additional requirement of the resources. If you are able to deliver the practice, this is what the quality improvement. Contextualizing the evidence-based practices into the daily routine practice. That is only the QI. Very rightly said, Dr.
And I would like to add one last thing.
Yes, please.
In our NICU, we have a very good support of CLMC.
Okay.
Or mothers, agar, if they don't have enough milk,
Yeah.
we are writing a paper and we're going to publish soon.
Yeah.
We have done 4 QIs. One is warm water shower for the mother.
Okay.
We have implemented this.
Oh, that's great.
Second thing we have implemented is a jaggery gudwala biscuit with shatavari
Okay. Okay.
for more galactagogues.
That will help in lactating.
Lactating.
Okay, that's great.
And third important thing that we did is provide water and warm liquid for the mother as soon as she comes.
Okay.
And the fourth thing is we have a naturopathy team
Okay.
which does massage for the mothers.
Oh, that's really great.
So these are some of the implementation.
So that is called a humanized way of caring the mothers. You know, that was probably available in our rural the system, but nowadays maybe because of
So this will increase dopamine, oxytocin, serotonin, endorphin, and we call it the dose study.
Yeah.
Dose study.
Thank you so much, Dr. Santosh, for your expert from the public health. And one last question for each, and that will be only 30 seconds for all of you. Dr. Satvik Bansal, what is one message would you like to deliver to our audience?
I would say start small, pick one metric, and just track it well so that you see the improvement over
So
time.
even if you take just a small step, you know how many babies delivered and how many babies out of that get breastfeeding within 1 hour. That's okay. That's one more than enough. Yeah, Dr. Dheeraj.
Quality is everyone's responsibility, not just leadership. Leadership can take initiatives, but it has to be followed by each and everyone, by entire team, and it has to be go to the ground level also.
Exactly. So quality improvement is actually, it is not the leader, it is the teamwork. The spirit of the team has to be there, and then we can pursue the quality improvements. Dr. Santosh, one word, please.
See, parents are partners, families are partners, and the society community is a partner.
Yes, of course.
In our CLMC,
Yeah.
there is a mother who delivered, who was not having enough milk.
Yeah.
She got help from the CLMC, and after she went out, she donated more than 240 liters to the same CLMC milk bank. She is the highest milk donor in our Nilofer hospital.
Oh, that's great.
240 liters. And then the family members of these people, they started collecting, and one community volunteer, he collected 980 liters as a volunteer free of cost. So this is how partnerships and parents can be a part of the system.
Yes, definitely. That means what the Dr. Santosh is trying to say, utilize optimally mother. In what way you can, utilize the mother. Whether if it is not baby is able to accept the breastfeeding, just involve her, just give a simple touch therapy, that is okay. If the baby is not stable, just drop a few drops of colostrum to the baby. And if it is not possible, just give an skin to skin contact. So thank you so much. We have got a lot many studies are for the quality improvement is concerned. This is one of our studies there. So post-delivery counseling, skin-to-skin contact, delayed cord clamping, and early initiation of feeding. So this we have published from the BMJ in one of the quality improvement practices. Another is how to utilize mother's own milk as a first feed that we decreases just by communication bundle we have created and implemented, and therefore we bring down the significant reduction in the formula milk, and the mother use of mother's milk goes significantly, right? In a just 6 months period. So thank you so much, our esteemed panelists, for your views regarding the quality improvement practices. I hope our audience will get some insight, and will sensitize something to do. Start with one practice only. That's nothing like that. We are going to do in high frequency ventilation and ECMO and everything. Just start with a very small one dashboard indicator, and that can serve our purpose. Thank you so much for our audience. I would be happy to answer all means whatever maybe I will the organizer time will permit. Otherwise, anybody can come to me. Yeah, Mike.
Sir, can you?
Just one interaction,
Just
please.
one question. So we have been collecting milk from the relatives also. So what minimum thing that you check in the milk, because there is a risk of cross infection or something, HIV, what do you do for that person?
No, we follow all the standard protocols. HIV, Hep B, VDRL, everything is tested. And once that is done, then only we do. And then we have a checklist. Mother is not on any drugs for, let's say, cancer or anything else.
Relatives are contributing, no?
Absolutely.
So how do you check each of them before acceptance?
Any community donation we check.
So we accept. What do you check for? VDRL?
VDRL, Hep B, HIV.
Sir, for that means, the CLMC has got all the, laid down the procedure for the, screening and for the donated milk. As far as, direct is concerned, then some communities practice is going on, some, relatives which they are giving direct milk, that is not recommended actually. The ethically is not recommended. But you have to go through the human milk banking and then you can provide the milk. Thank you so much for patient listening. Thank you so much.
Thank you, sir. Thank you for completing it in time. Now I request panelists to please felicitate the moderator and moderate to please felicitate the panelists.
I would like everyone to say a small slogan because we are in Andhra Pradesh and in Telugu. Let's all say Talli Palu Muddu. Very easy. Everyone can say. All Hindi people also can say. Talli Palu Muddu.
Talli Palu Muddu.
Dabba Palu Vaddu.
Dabba Palu Vaddu. So what does that mean, please? Let me.
माँ का दूध प्यारा है और डब्बा का दूध मना है.
That's really Thank you. Then nothing can be a mother's milk. This is the, I think, one of the divine from the God available on earth. Thank you.
Thank you.
Next, I would like to call upon our next talk, newer biotherapeutics for NEC, focus on fecal microbiota transplantation by Dr. Gaurav Gupta. To moderate this session and to chair the session, I call upon Dr. N.B. Madhur, who needs no introduction. He is former director, professor, and head of Department of Neonatology, MAMC, Delhi, and Dean CNBC, Delhi. And he has more than 250 publications and more than 100 chapters in book and edited 4 books, faculty of DM Neonatology program, MAMC, and guided 45 MD and DM Neonatology thesis. And he has multiple awards to his honor. Thank you, sir. I request the sir to introduce the speaker.
At the outset, I welcome you all to this session on breaking news snippets and the state of the art and the future of neonatology is going to be discussed in this session. And we have Dr. Gaurav Gupta, who is an associate professor from All India Institute of Medical Sciences, Guwahati. And he will be speaking on newer biotherapeutics for NEC, focus on fecal microbiota transplantation. So dysbiosis in NEC is a very important pathogenetic factor. And so we'll see something about this newer biotherapeutic of fecal microbiota transplantation. Dr. Gaurav Gupta.
Thank you, sir. Thank you, sir, for kindly introducing me and giving me opportunity to speak on this very much awaited topic. This is actually a futuristic thing. I think most of the people are not aware of. This is something which is unheard of because there is actually only, to be truly speaking, only animal studies are available and there is no human clinical trial available on this. And first thing is that I just wanted to have a background and burden. Like we know that it's the most common surgical condition, usually found in 5 to 10% of VLBW neonates. However, mortality rate is more than 50% in these if the babies are affected. However, and it can be found in 10% of the babies who are actually even term babies. So risk factor in term babies including like congenital heart disease with systemic dependent circulation, with polycythemia, or term baby with severe asphyxia can also have NEC. So these are the certain stresses or risk factor like formula feeding, prolonged parental nutrition, prolonged duration of antibiotics for more than 5 days, prematurity, less than 1,500 gram baby. Maternal risk factors include smoking, obesity, maternal history of chorioamnitis, preeclampsia, diabetes in the mother. So these are the risk factors. This is something related to pathogenesis like prematurity, formula feed, antibiotic administration can give rise to dysbiosis. So here we are more concerned that it is the actually intestinal microbiota which is disturbed. This is dysbiotic. Increase in the proteobacteria like Salmonella and E. coli, increase in the barrier disruption like increase in the toll receptor protein and increased permeability, which will ultimately give rise to inflammation, necrosis, and increased bacterial translocation. So we have to do like my topic is like to focus on fetal microbial transplantation. So this is the emerging trends. These are the newer biotherapeutics like breast milk. We know breast milk is important in prevention of NEC, but these are the certain factors in the breast milk like lactoferrin, human milk oligosaccharides, and exosomes. If we can provide them, we can actually prevent NEC also. Fecal microbial transplantation, stem cells, futuristic therapy for stem cells transplantation, and TLR4 targeting agent like immunotherapy. So we know it's a breast milk is the exclusive breastfeeding has a protective role for preventing and treating NEC. So near therapeutic approach means okay, why don't we do the like we give the components of the breast milk which are actually helpful in the prevention of NEC, which include lactoferrin or human milk oligosaccharides and breast milk derived exosomes. So, human milk oligosaccharides, as we all know, they are actually prebiotics. They are non-digestible dietary products which promote the growth of beneficial bacteria and improve intestinal motility and gastric emptying, and they also act as a inflammatory and immune modulating agents. And so there are certain other factors like lactoferrin. Lactoferrin, we know, it maintains the gut barrier. It has anti-inflammatory effect, decreases the IL-6 and TNF alpha levels, and it is the most abundant protein in the colostrum also. And human milk oligosaccharide, they have a variable composition. They are helpful in the intestinal protection and immune modulation, and they accelerate the turnover of Krebs cells. And exosomes, something like if we can, exosomes are the mRNA or iRNA products, protein degraded products. They help in the cellular repair and regeneration, and they protect intestinal cells also from the oxidative stress. So we have heard of like lactoferrin. There was lactoferrin. There was also one Elfin trial also going on, but Elfin trial has not shown to be lactoferrin was not helpful in the prevention of the NEC. But there was a systematic review which was done, and there was 6 RCT was taken, and they have found that lactoferrin supplementation with or even without probiotics helps to decrease the late onset sepsis along with the all stages of NEC, surgical stages of NEC, NEC stage 2 and NEC stage 3 in preterm infants. Now, something about that, our like need of art, which is the fecal microbiome transplantation. So we know that gut microbiome dysgenesis is the core risk factor for the development of NEC right now. So what is fecal microbiome transplantation? It is basically strategy to transfer the healthy feces or healthy feces microbiome from the donor to the recipient intestinal flora. And currently we know that this therapy is being used in adults for Clostridium difficile infected disease, irritable bowel syndrome, inflammatory bowel disease. But in NEC, it has a potential role because it has been found in the experimental model in animal studies, and they have found to be given a proven and positive response, positive results when this biosis occurs in the NIC, and when it was given in the experimental models in piglets with the suffering from NEC. So, what is the mechanism of microbiome transplantation? It strengthens the intestinal barrier, it decreases the intestinal permeability, and decreases the inflammation of intestine also. It can be given by the route. I will be discussing what is the route of administration. Fecal microbiota can be given by the oral routes or mainly by the rectal route. Rectal route of administration is generally recommended as it's the most preferred method. Oral routes can also be given, but actually it can increase the lethal sepsis and even overall mortality because it exposes the proximal gut to the potential pathogenic organism. So rectal route is the most preferred route. And when it comes to the safety, it carries the safety concern because there is no screening method which can exclude the transfer of these infectious agents from the donor. And guts of the recipient shows higher level of pathogenic microorganisms like Escherichia coli and Salmonella. And oral administration increases the risk of lethal sepsis. So certain safety improvement technique were developed, like we have now moving from like there was study which has taken fecal filtrate transplantation. What it has done, it has removed the pathogenic bacteria using sterile filtration by UV sterilization or UV radiation in order to remove the harmful bacteria. So research and donor selection, this is the challenge. There are limited few published data on FMT, infects on the game, and only this in the preclinical or only animal trials are available. And most of the they have been done on the 10-day-old healthy piglets or even the rat model. So there was a two study, like the one study they have compared the effect of fecal microbial transplantation on the route of administration on the preterm pigs. They have found that if FMT decreased the incidence drastically by 75%. However, oral FMT has increased the mortality because of increased bacterial overload, and rectal administration protected against NEC without any adverse effect on survival, while oral administration may lead to lethal sepsis. So this was the fecal filtrate transplantation study which was done. They have found out the effect of rectal fecal filtrate transplantation was equally effective as compared to the rectal FMT in preventing the NEC. So these are the future direction and challenges. Like research should focus on the human clinical trials, and research should focus on the definite preferred route of administration and strict screening criteria, how to screen then, how to see for genomic sequencing of the intestine in which FMT has been done. And coming on to the next therapy, like this is a short word about the stem cell therapy.
Maybe, yeah. So basically, thank you, Dr. Gaurav. So Dr. Gaurav has very nicely highlighted this fecal microbiota transplantation. This is already approved by FDA for adults. But for NEC and for neonates, it is not approved. So this is, when we do something innovative in neonatology, because neonates are the most vulnerable group. So we take cues from adult medicine and whatever has been tried in children. And this seems to be a very promising future for necrotizing enterocolitis, wherein you transfuse the fecal microbiota, preferably rectally, and you try to correct the dysbiosis. So thanks a lot, Dr. Gaurav, for very nicely summarizing this fecal microbiota transplantation. Thank you. And now I call upon Dr. Amit Kumar. Dr. Amit Kumar will be speaking on managing inguinal hernia in preterms, expeditious versus expectant. And Dr. Amit Kumar is Assistant Professor of Neonatology at All India Institute of Medical Sciences, Nagpur.
Good evening, chairpersons, my senior and colleagues. At the outset, I would like to thank the Neocon Scientific Committee for giving this opportunity. And I will discuss about the inguinal hernia, which is one of the common conditions in the preterm baby, but yet there is challenges in managing the preterm in terms of timing of surgery. So, as you know that this inguinal hernia is very common in preterm babies, and the incidence is 9 to 11% in the baby who is less than 32 weeks age. So these baby already have multiple challenges, and they have a low birth weight, prolonged NICU stay, prolonged mechanical ventilation, leading to bronchopulmonary dysplasia and IVH incidence. And all these morbidity increases the chance of inguinal hernia in this baby, and it become another major concern in the management of these preterm babies. So the main dilemma in managing this inguinal hernia is, should you repair the hernia early or before the NICU discharge, or we should have to wait, we have to discharge the baby and call the baby after 45 weeks of gestation, post-menstrual age, and repair this baby. So main dilemma and about the deciding the time of surgery. So if you are going to do the early repair, you have to you have to repair at when it is diagnosed before the discharge. And if you are going for the late, so you have to discharge the baby and call the baby at 45 weeks of post-menstrual age and diagnose. So as you know that in a preterm infant, the processus vaginalis often remains patent, and it creates a potential space in which the bowel or even the testis and ovary can slip in and form the hernia. Because in the preterm baby, the abdominal muscles are very weak, and due to the increased intra-abdominal pressure, the chances of incarceration is very high, and it can up to 30% in first year of the life. So this incarceration can lead to the bowel ischemia and sometimes the testicular atrophy and ovarian necrosis also. So that first we look for about this the first strategy about the early repair. So doing the surgery before an ICU discharge. So the rationale behind the early repair is if you fix the hernia early, we can prevent the risk of sudden incarceration. And the advantage is it reduces the risk of emergency incarceration, strangulation, and avoid the prolonged NICU stay just for the hernia repair. And it also reduces the anxiety of parents associated with monitoring of a known hernia at home. And it also saves the family from the repeated hospital visit for the frequent follow-up. But early repair is not without the risk. So as you know that any surgery performed before 45 weeks of post-menstrual age has a higher chance of anesthesia-related complication like post-operative apnea, desaturation, and bradycardia. So it's proven that if you do the surgery before 48 weeks of a week, the chance of apnea will be 5%. If you do the surgery after 55 weeks post-menstrual age, the chance of apnea decreases to 1 to 2%. So, and although if you do the early surgery, the chance of recurrence and wound infection is also very high. And doing the surgery in such a small, tiny, preemie baby is a very difficult technically also. So, if you look about the evidence, the recent meta-analysis published in 2025 shows that if you go for the early repair, it is associated with a 3-fold increase in hernia recurrence, along with a 3-fold increase in the respiratory complication compared to the delayed repair. Still, some centers continue to prefer early repair, particularly in setting where the access to emergency surgical services is very limited, but the evidences clearly indicates that early surgery carries a significantly higher post-operative and respiratory risk in preterm babies. So now we go for the delayed repair strategy, that is usually after 45 weeks of post-menstrual age. The logic is here, let the baby grow, which reduces the complication of anesthesia and surgery itself. So the advantage is in this baby, the bigger baby has a better respiratory compliance, so the anesthesia is very safe, and there's a reduction in the post-operative apnea, and technically doing surgery in a bigger baby is very easy. But the bigger concern in waiting for the surgery is the risk of incarceration while you wait, and this may require emergency surgery, which is associated with a higher morbidity, and parent also remains anxious throughout waiting period, and some cases family may face difficulty in accessing the emergency services in time of need. So if you see the evidence, the earlier studies reported that incarceration rate is quite high, up to 15 to 30% with delay repair. But if you see the recent meta-analysis 2025, it shows that there's significant reduction if there's significant reduction, significant association between the early repair and reduced incarceration rate. So this means that that operating the late does not increase the chance of incarceration. A recent RCT, that is a hernia trial published in NEGM 2021, also shows that expecting repair associated with the fewer post-operative complication and incarceration risk present, but overall outcome was not worse if careful follow-up is ensured. And another RCT published in JAMA clearly shows that likelihood of serious adverse event are lesser in the delayed repair approach than the babies who are older than 55 weeks of post-menstrual age. But the current guideline now support that the delay repair is safe option in a stable preterm infants, provided the consistent follow-up is easily available. So how do you decide which baby will go for the early repair and which baby will go for the late repair? So there is a no one size fits all approach, and you have to decide according to the babies, like if the baby's gestation age is very the extreme preterm, the current weight, and the comorbidities such as bronchopulmonary dysplasia, cardiac disease, or ongoing ventilator needs are there, and the availability of expertise or local pediatric surgery anesthesia team is also available, then you can go for the late approach. But if the baby is stable, already grown well, and there's no much complication, in that case you can discharge the baby and call the baby up at after 45 weeks of postmenstrual age for the surgery. So to conclude, the inguinal hernia in preterm is a common and potentially dangerous, and early repair prevent incarceration but carries higher anesthesia risk, and delayed repair minimizes the anesthesia complication but require vigilant follow-up. Thank you.
So, thank you, Dr. Amit. And Dr. Amit has very clearly put out the pros and cons. If you do an early surgery, then there are the risks of anesthesia and the risk of surgery. And if you delay it, every third baby is going to have incarceration. So, in such a catch situation, the best thing would be to individualize the decision. See how accessible are the emergency services to the particular family, and how confident is the pediatric surgeon in performing surgery on a smaller baby. And so with that, I thank you, Dr. Amit, and we move on to the next talk, and that is by Dr. Richi Dalal, and our topic is what is new in synthetic surfactant production. So Dr. Richi Dalal is an assistant professor in neonatology at AIMS Patna.
Thank you, sir. So the topic given to me is what is new in synthetic surfactant production. So as we all know that surfactant is an amphiphilic compound which is necessary for reduction of the surface tension, and it is very less in pool size in preterm infants with RDS compared to the term neonates. I'll not go into the details of the mechanism of action, but you need to know that the composition is mainly DPPC along with surfactant protein B, C, A, D. Of these, B and C are crucial mainly for the biophysical function. So mainly the surfactants can be divided into natural and synthetic surfactants. We'll mainly be discussing the synthetic surfactants. So as we know that earlier, the first generation of synthetic surfactants were protein-free synthetic surfactants. Now, these protein-free synthetic surfactants were created because there was a thought that proteins may actually be immunogenic that were present in the natural surfactants. However, these protein-free synthetic surfactants, as we'll see in the subsequent slides, when they were compared with the animal-derived surfactants, in around 15 trials, it was found that the animal-derived surfactants were in fact still better than the protein-free synthetic surfactants in terms of reduction in mortality as well as reduction in pneumothorax, BPD, or mortality combined risk. So even if these synthetic surfactants were produced, the animal-derived surfactants were still better. So we kept on using them. But there were still some potential issues with these animal-derived surfactants in the form of the fact that there was the production was costly. The composition of the animal-derived surfactants also varied from batch to batch. And sometimes parents raised concerns regarding the administration of animal-derived medications to their babies. So still, synthetic surfactants was an attractive alternative. So then scientists started thinking that maybe we can make protein-containing synthetic surfactants. So then protein-containing synthetic surfactants were created. This cinepultide is basically a KL4 peptide, which is a mimic of surfactant protein B. And leucinactant was one of the first single peptide protein-containing synthetic surfactants. It was tested against previous protein-free synthetic surfactants as well as animal-derived surfactants. Both in vitro as well as in vivo studies showed that this protein-containing synthetic surfactants were comparable to the animal-derived counterparts. This is one randomized trial between leucinactant, which contains KL4 peptide, which is a modified surfactant protein B analog, synthetic analog. It was compared with poractant alpha, And it was found that all these outcomes that are all-cause mortality or BPD, air leaks, and multiple other outcomes were comparable between the two groups. Subsequently, a meta-analysis in 2007 was done, which did not show any difference between these two types of surfactants. And also a network meta-analysis was done, which showed that surfactant, which contains this KL4 peptide, was actually better than the previous protein-free synthetic surfactants and animal-derived surfactants in terms of reduction in mortality. So from the studies which were done till the year 2015, it can be concluded that animal-derived surfactants were better than the protein-free surfactants, but protein-containing synthetic surfactant, that is leucinactant, was comparable to the animal-derived surfactants. However, there were few issues with leucinactant. These were the dose required by for leucinactant was 5.8 ml per kg per dose, which is quite high. Also, leucinactant was a very viscous fluid requiring rewarming till 44 degrees, followed by vigorous shaking. So all these made it less preferable for usage. So still animal-derived surfactants were used. Now, in order to overcome the problems with previous generation synthetic surfactants, newer generation synthetic surfactants that contained both surfactant protein B and C were created. One of the first was CHF5633, which was comparable to poractant alpha in terms of the dose, that is around 2.5 ml per kg, and it also contained surfactant protein B and C. It was compared to poractant alpha in a randomized trial, and it was found to be equivalent in terms of mortality and reduction in the oxygen requirement. So the advantages of this CHF5633 were the dose was much lesser than leucinactant. It required short period of warming before administration. It had anti-inflammatory properties, and it was also resistant to inactivation, better than both the animal-derived as well as the single peptide synthetic surfactants. But the issue with CHF5633 were that it had very high production costs. So it never could enter into a phase 3 trial, and it was withdrawn. So there was still some hope. Further, multiple other combinations of synthetic modified surfactant B and C were tried. And one of these was combo peptides consisting of a modified 34 residue peptide of surfactant B called mini B, along with a surfactant C analog called SPC33-LU. This combination was found to be, in fact, better than CHF5633 in animal models. Further modifications have also come. This super mini B is another modification of mini B, and BYL is also a modification of mini B. So these two newer surfactants are available in the form of mini surf and synsurf, but these are only being used in animal studies currently. There are no clinical human trials yet, and it is expected that maybe in future studies we'll be able to know if they are better in comparison to the animal-derived surfactants. So the take-home message is that synthetic surfactant, it does offer a promising alternative to animal-derived surfactants. But the main issue is the production of the synthetic surfactants, especially the SPC peptide, because this has been hindered by its tendency to convert into beta sheet aggregates. And the only perfect synthetic surfactant, which was CHF5633, it could not enter into a phase 3 clinical trial because of high production costs. But it is expected that the newer modifications of SPB and SP3, which are being tested in the animal models, maybe once further studies are done in humans, then maybe they'll be found to be better. But till further evidence is available, we are still going to use the animal-derived surfactants. Thank you.
So, thank you, Dr. Dalal. Any question from the floor? So you see this surfactant is not alone that works, and you require surfactant protein also. And as you want to sort of eliminate the animal sources, a search for a better surfactant along with the surfactant proteins is going to continue. And although products have been tried, a number of products have been tried, but the search continues. And that is what research is all about. I believe you are asking.
Boris Kramer, Poznan, Poland. Thank you very much. A very good overview. A little bit further back away, SPD, there have been recombinant proteins tested even in clinical trials. Can you give a short summary whether this will be a quantum leap in surfactant treatment?
So surfactant protein B as such, we don't expect it to have that reducing surface tension capacity. It is mainly responsible for immunity. So what we are mainly, we need modifications or modified versions of surfactant protein B and C. So probably if we work more on these, then we'll be able to devise a perfect surfactant.
I partially agree with you. B and C also have immune modulatory functions, and surfactant is more than reducing surface tension, but point taken.
Yeah. Thank you, sir.
Okay, so thank you, Dr. Richi Dalal. And now I invite the next speaker, Dr. Devansh Sharma, who is in Sitaram Bharti Institute of Science and Research, New Delhi. And he is going to speak on Beyond the IV, rethinking oral antibiotics in neonatal care.
Thank you, sir. So I'm Dr. Devansh, and I'll be discussing about beyond the IV antibiotics, rethinking the oral antibiotics in the neonatal practice. It seems to be very thrilling, and like we are always tempted. Why not oral? Why not oral? Like life will be so much easy if we are able to manage everything on the oral medications. So overview, I'll be discussing why, what are the barriers, what is the current evidence, and what are the existing protocols, and maybe then we'll be able to understand whether anything can be done in our setting or not. So as we start, why are we discussing it? What is the burden? So burden, let's think about it. Like India is a country where the maternal risk factors are so common. Mother will be having, lot of mothers will be having fever for one or the other reason. Some other like prolonged labor has been there, some leaking PV has been there. It may misjudge as whether the respiratory condition is because of the sepsis or whether it is just MAS or whether it is KTNB. So these are the some symptoms which can disguise us. So we ultimately end up giving antibiotic to many of the patients. We start antibiotic and then we have to stop also early. But similarly, sometimes associated setting like perinatal depression, MSL, with the misguiding laboratory parameters may require, such patients may require prolonged stay. And then when it's get complicated and we end up looking at the laboratory parameters, sometimes then we are towards giving longer duration of antibiotics. So the burden, social, mental, we look only as a burden in the sense of economical. We never try to look on the burden, what is happening with the mother, her mental status, her social status, her economical, financial, personal, and national also. Emotional burden to the mother and neonatal bonding, it is also affected. So these are the burden when we talk about the duration of IV antibiotic. Still, the IV therapy is the standard of care. Sometimes the use of oral antibiotics when IV, we consider using, we are already using oral antibiotics sometimes, off-label sometimes when the IV access is problematic. So meanwhile, we try to bridge in case basis in skin infection, eye infection, ear infection, sometimes use it as an off-label practice. We are using it. So maybe early timely switch from IV to oral antibiotics. Can we do that? If we can, then it will reduce hospital stay in select cases. The approach not yet standard worldwide, being adopted and studied in some specialized neonatal protocols, which we'll be discussing. Thus, IV antibiotics while remain gold standard. So opportunity is there if we can look in like some select cases where we can identify which population where we. So the reason there is the oral bioavailability is there or not? Okay, thank you. Oh, ये screen नहीं आएगा. ये है no. Then we have to select what patient population we need to focus on. What are the laboratory parameters? Maybe at that time we will take help of the laboratory parameters. Then data in the confirmed infection cases, oral formulations, and long-term outcomes. Since most of these data is insufficient still, because we have to look at the long-term outcomes and probable. Shall I continue like this only? I'll finish it off. So the oral bioavailability, when we talk about oral bioavailability, let's see what is the existing literature, if it allows us. So the literature says that it can reach adequate serum level we can reach an adequate serum level of antibiotic by the oral route also. The relapse and mortality rates are comparable in IV versus oral both, and the tolerance has also been comparable with comparable side effects. So, oh, fortunately we are on time. No? This is the evidence, the paper, European Journal of Clinical Pharmacology, where they tried to.
Can you use mark? Highlighter. Just pointer.
Achha, yes. So they tried to study the effect of oral versus IV in neonatal group B streptococcus infection. So that means it was a culture proven sepsis. They selected the patient who had responded to the IV amoxicillin and then switched to the oral amoxicillin of the dose 300 to 200 mg. The results were none of the significant side effect in terms of oral tolerance and none of the serious side effects in the terms of treatment completion. So again, here, this is another by Manzino et al. In the Italy. So here they have taken the presumed or proven bacterial infection and they tried with the oral cefotoxin poxetil. And here also they found that the result showed that the full-term newborn were presumed or proven sepsis initially treated with IV can be switched to oral antibiotic after 3 days of therapy. If physical and lab data indicates that the infection has disappeared. Again, so they are talking about some lab parameters. We'll be discussing again about them. So again, now here is one meta-analysis. Very great. Next comes the meta-analysis. Oral antibiotics for neonatal infection, a systematic review and meta-analysis by Keach. Again, the oral antibiotics administered to neonates are absorbed and result in adequate serum level judged by MICs of relevant pathogen. Efficacy studies are promising, but again, as usual, the robust data is lacking, evidence is lacking. But yes, they say that oral antibiotic again administered here has been found to be in an adequate serum level. So potential benefits, what can be the potential benefits if we take this evidence with us? What can be if we start using them? Oral antibiotic, shorter hospital stay, reduced need of IV, painful IV access, early discharge, better parent-infant bonding, better breastfeeding. What more we need? If there is a better breastfeeding, we have been talking about constantly better feeding. Again, one of the things which can help in better maternal and neonatal bonding, reduce healthcare cost, and it empowers the family. Like we are always talking about partnering with the family. Again, we are making family a partner. So RAIN trial, a non-inferiority trial, they selected few neonates, more than 35 weeks, 0 to 28, weight more than 2 kg, probable bacterial infection, not the culture positive sepsis, who received empiric antibiotic, and they randomized after 48 hours, who were clinically well, tolerating oral feeds well without vomiting. Any culture positive sepsis was excluded absence of blood culture was also excluded, severe localized infection was excluded, severe clinical sepsis was included, continuous need of central line was excluded, and hyperbilirubinemia or parents are not able to provide medication at home were excluded. So these are some data, like I don't want to get into it because of the time. Again, here what we CRP is positive, 24 hours is also again positive. The results which they showed is yes, so cumulative reinfection rate was comparable in oral versus IV. No serious significant side effects in terms of oral tolerance was also comparable. So still, understanding this, still there are some barriers that if you ask me, like, this is a rain trial, will I be able to adopt it in my practice? No, I am still feeling insecure. What is the insecurity? I have still, again, always one big thing, large data is needed. Variable adoption in the guidelines, until unless somebody tells me it is here in the guideline, that particular guideline, that particular system is already using it in their system. Maybe that will give me confidence. My local guideline says this. Maybe that will give me confidence. So coming to that, adoption in the guidelines, NOAA, neonatal oral antibiotics at home. So this was a project which was started by here, Royal Devon University Healthcare System NHS Foundation. When we talk about NHS, we are knowing that there are few things, like they are always cost analytical, and a lot of things are going on there in their mind, because again the burden of the cost is always on the government there. They also took term neonates, clinically well tolerating oral feeds, received IV antibiotics, suspected early onset sepsis, CRP less than 50, falling trend, culture negative, CSF negative, no medico-social concerns. They developed some robust follow-up system, and then they switched as a routine protocol that they will be discharging their all neonates on oral antibiotics who are qualifying this, provided the follow-up is robust. Again, now maybe after this much of insight, maybe there are still some barriers which are lacking. Unpredictable absorption in the more preterm baby. Longer outcomes need to be assessed regarding the microbiome impact, IV versus oral. Again, until unless I say NHS is doing that, until unless my governing body is not doing it, am I safe? Standardized protocols in terms of protocols and practical implementation. I think, like, with the data enough, maybe it is a time that we can start thinking of some standardized protocol in our country population, which we may be able to select, maybe term or late preterm, clinically improved, remained hemodynamically stable. Bacteria, again, some studies have shown in bacteremic patients also safety. Some have shown in culture negative. CSF done negative or not done, maybe we can always debate it. Switching time is another concern. 36 hours versus 72 hours. What is a safer period? Further studies may be needed. Partnering with the family, empowering them, and ensuring that there will be a follow-up will remain a challenge in our setup. We need to have an outpatient follow-up plan. Documentation and communication will always be playing a pivotal role here to prevent the errors and ensure the adherence. I have just taken out this slide with some oral antibiotic dosage in the neonates. Now I will end my talk here and open the discussion and debate, and for the expert comments, sir.
Yes, so thank you, Dr. Devan Sharma. So actually, this session basically is to kindle the young researchers to look into the issues which are of high import, very important issues. Now, this treatment of infection using IV antibiotics is never an ideal situation. And there is always a charm for a shorter duration and for oral antibiotics or something which can be done at a lower level and less of nursing time, all those issues, less of phlebitis, family more comfortable. So these issues are very important. Now, when we look into the duration of antibiotics, for various conditions like sepsis or meningitis. These guidelines were formulated when the only concern was that there should be no recurrence of infection once you treat that condition. And it was never presumed that a longer duration of antibiotic is going to be harmful. And gradually, and it has been one of my favorite topics, I have conducted studies on short-term duration of antibiotics in sepsis, meningitis, pneumonia. So, this concept of giving antibiotics for shorter term, that has now started emerging, and it is a key area. And similarly, as Dr. Devansh has pointed out, maybe there is a role for switching from IV antibiotics to oral antibiotics in situations where one doesn't have a sort of very good backing from the say family and the society, and then gradually the people have to understand the benefit of oral antibiotic and the harms of IV antibiotic, so that it is considered more ethical to switch to oral antibiotics rather than to complete a course of IV antibiotics. So, I mean, all these talks have been really very thought provoking, and I'm sure this will kindle research into the young minds of young researchers. And any questions on any of these talks would be welcome from the floor also. So, anybody? Any questions? Any interaction? So, yes, thanks, Dr. Devansh Sharma.
Thank you, sir.
All these talks have been really very nicely done, and these issues are very important for research, for future research. And we all have this hope that in future these things will come true. So, with that, I close the session.
Thank you so much.
Thank you, sir. Thank you, sir, for moderating the session very well. And thank you, Satish Thakur, sir, for chairing the session.
या नहीं, बहुत ही अच्छा रहा, सब अच्छे अच्छे टॉपिक्स पर बोले, नया नया रूप से चले, दैट इज द गुड थिंग्स फॉर द फ्यूचर प्रोस्पेक्ट ऑफ द न्यूनेटॉलॉजी.
Thank you, sir. May I request now NB Madhur sir, moderator sir, to present mementos to the speakers of this session, Dr. Gaurav Gupta, Dr. Amit Kumar, Dr. Richi Dalai, and Dr. Devan Sharma. I request speaker to receive felicitation from the moderator, and I request speakers to felicitate the moderator and chairperson, sir. Thank you everyone for staying back till the end. I request everyone to join the live music and entertainment evening followed by grand networking dinner at from 8 p.m. onwards today. Thank you. 20 నిమిషాలు లేట్ అవడంతో మొత్తం లేట్ అయింది.
అవార్డు వరల్డ్ కప్ వచ్చారు
అదే అడిగాను.
ఎట్లా ప్రజెంట్ చేశారు?
కాంపిటేటర్ ఎవరు అనుకున్నారు సార్? వెంటనే విజయానంద్ సార్.
ప్రజెంట్ చేశాడా? నువ్వు కూడా బాగా ప్రజెంట్ చేశామా? పేపర్ ప్రజెంట్ చేశావు కదా?